On the second day of INSPINE 2022, we present you with not only multiple sessions, but also talking posters that will be displayed outside from 9 a.m. to 6 p.m. Therefore, we would like to humbly request you to go and watch our talking posters.
Recording in progress.
After the successful completion of yesterday's event, we are here today again. We would now like to directly jump into the first session for today. In our first session, we will look at some scientific papers on the state of spine surgery. The moderators for this session are: our first moderator is Professor Dr. S.S. Kale, Head of Department of Neurosurgery, AIIMS Delhi. May I please have the honor of inviting sir on the stage? He is not here with us. He will be joining us soon. Thank you.
Our second moderator is Dr. Krishna Sharma, Head of Department, Neurosurgery at Nepal Medical College Teaching Hospital. May I please have the honor of inviting sir on the stage? Thank you, sir. Our third moderator is Dr. Bal Gopal Karmacharya, Head of Department of Neurosurgery at Manipal College of Medical Science. May I please request sir to be on the stage? Thank you, sir. The floor is all yours.
Good morning to you all. The second day of our conference. I welcome you all. Let's start with the first presentation. This very important day, we are starting with a very important person with a very important talk. This is Professor Edward. Mike, please. He will be talking on cervical spondylotic myelopathy and deformity correction. Sir, can we have your talk, please?
Okay, thank you, Dr. Sharma. It is indeed a great honor to be able to participate even for such a short period of time in your meeting. And I'm so sorry that the circumstances do not allow me to be in your presence. I enjoy your wonderful country and all the collaboration, and I also enjoy the collegiality and competence of the Nepalese Neurosurgery Society and Spine Society. I am going to address today cervical spondylotic myelopathy and deformity correction. I don't have a lot of time, so I will rapidly go through things and answer questions if you have them. From a biomechanical perspective, there is fundamentally 4 ways that we can load the spine or correct deformity. We can apply distraction or compression, which we call tension band fixation, like a clamp. 3-point bending, which means 3 or more points of fixation, and cantilevers. And there are a variety of types of cantilevers, which I will not go into here today. This device here is a bridging implant. It resists extension so that in a sense, it is a compression device. It is a fixed moment arm cantilever beam, so it's a cantilever. It also is a distraction device because it can be used to distract the spine. But more importantly, what it does not offer here is an intermediate point of fixation. So this is not a 3-point fixation device. We know that this type of fixation commonly fails mainly because there is significant rotation and translation at the termini, and this results in failure at the bottom. Had the surgeon put an intermediate point of fixation in the native bone, say in this case, the C5 vertebral body, then the whole spine would move together and failure would not occur. as it did here. This would be an example of using intermediate points of fixation to provide 3-point bending fixation to improve fixation. There are a number of strategies that we can use to stabilize and the spine and correct deformity. And we should focus on deformity. Why? Because the patient with a deformity often has neck pain. They often have myelopathy. We can decrease end fusion degenerative changes and improve short and long-term success. This is a patient that in extension that I operated on with cervical spondylotic myelopathy, and I left her in this position. Her myelopathy improved, which we would expect because we did a laminectomy, but she was left with significant neck pain that was my fault. And we need to work very hard on getting the correction we need before we fixate the patient into position, such as I did in this case. We can use applied moment arms through devices like Caspar pins to correct deformity. We can bring the bone to the implant, which is used here with this 3-point bending fixation device. And here's a depiction of how to do that. Basically, put the screws in and then bring the bone up to the implant like this. And we've converted a kyphosis into a lordosis, as depicted here. We can also use gravity in the supine position using the principle of viscoelasticity, which is defined as the gradual deformation with the application, following the application of a constant load. Let me give an example. If I have a patient with a kyphotic deformity and a myelopathy, and we can see that there's some signal change in the spinal cord, patients had previous posterior and anterior operations, and now has a progressive myelopathy and significant neck pain. We could correct ventrally because the facets weren't ankylosed. We can see how they're free, and we could see that the intervertebral disc space opened up with extension. So we put a log roll under the shoulder, a donut under the head, began our dissections and discectomies, etc., and then removed the donut from beneath the head and allowed the head, which weighs about 10 pounds, to fall backwards. And that utilized the principle of viscoelasticity, and that, along with bringing the bone to the implant and applying bending moments, we were able to create a 5-degree lordosis compared to the pre-op 15-degree kyphosis. It's all about leverage. In the prone position, it's more difficult, as I already mentioned, because we cannot allow the weight of the head to fall backwards. We must continuously and maybe perhaps repetitively adjust the head holder in these circumstances. But regardless, fixation follows. And here she is postoperatively. Her neck pain improved remarkably early on, and her myelopathy improved remarkably early on as well. We can see the signal change in the spinal cord is gone, and she is in a good alignment. Pre-op, post-op. So this got me to thinking, caused me to think. This was early, about 20 years ago when I operated on this patient. And shortly thereafter, this patient came to me from Puerto Rico, and he'd had a laminectomy 10 years ago for myelopathy and improved tremendously. And now he's deteriorating again. And here's his MRI. And the physicians had trouble sorting this out. So we know that cervical spondylotic myelopathy is a manifestation of repetitive trauma and tethering and distraction. And so we see that the patient can't really extend his neck, but he can flex his neck, and he's mobile at every level. And here's a flexion MRI. So this was the first dynamic MRI that I obtained. And if you compare extension with flexion, you can see a world of difference. And this clearly explains his progressive myelopathy. I knew we could correct him dorsally because he was moved at every segment, and all we needed to do was to decompress the facet joints, so to speak, and do facet osteotomies, and we were able to achieve a nice lordosis. However, he later came back to his treating surgeon in Puerto Rico with this. He slipped forward and bent forward at C23, which led us to determine that the C23 disc interspace is very important. And a mistake I made with this operation is that I didn't extend it to C2. You lose very little motion and gain a huge advantage. And he'd had 2 operations here, so the facet capsule was probably disrupted. And the C23 angle is not perpendicular to the floor in the standing position, and it should be if you look at x-rays. So his surgeon in Puerto Rico did this operation, which wasn't optimal, but I completely understand, and the patient actually did very well. I was able to see him at a couple of years post-op, and he was doing very well with this. This is another patient who had a C7T1 disc herniation from trauma, and the surgeon put in this device, which was later taken out, and he was basically frozen in this position with a solid fusion. So he doesn't have any spinal cord compression. His neck is flexed, and he stands here with a hypertrophied and tense trapezius muscle, which is the kyphosis trapezius sign. And he also complains of back pain because he has to bend backwards to see forward. So we did facet osteotomies from behind, and then used multiple discectomies with trapezoidal bone grafts and bringing the bone to the implant to correct his deformity. Look how comfortable he looks here and how miserable he looked prior to this surgery. He had a very good result. So the C23 angle is important. We did a study to look at this. Patients who have a angle that is significantly slanted forward like this have a significant reoperation rate, pseudoarthrosis rate, progressive kyphosis rate, adjacent segment degeneration, and adjacent segment disease. I use the C7T1 angle or the T1 slope to determine how much the cervical thoracic junction is playing a role. If this slope is steep, the problem is not up here. He's got a cervical lordosis here. The problem is down below. We're going to need to do something from C7 to T1 to T2 to correct the deformity. I use the CT23 angle for intraoperative utility. This is an example of a patient who has tremendous neck pain. She has that kyphosis trapezius sign. She's had multiple operations, obviously, and has a significant sagittal vertical axis, as you can see that she's leaning forward. So we knew we had to do some correction down low, and we did C7, T1, T1, T2, and T2, T3 facet osteotomies, and we're able to bring her back. And we assessed that by looking at the C23 disc interspace. In the prone position, it is perpendicular to the floor. And if we flip this x-ray 90 degrees, we see that it's horizontal to the floor. This is our endpoint. This is the angle we wanted to achieve. So here she is pre-op, here she is post-op. And here's the cervical x-ray post-op, and here's the lines. Notice that pre-op, her plumb line drops close to the L5S1 disc interspace because she's forced to lean backwards to look forward. After the correction, her plumb line drops a little bit forward, but her C23 disc interspace is horizontal to the floor. Remember that when we do not maintain that angle at a proper orientation, there are numerous complications that can ensue. One last quick case of a 34-year-old male with small fiber neuropathy and weak neck muscles. And his neck, these are artifacts, these are a gown. And his neck is bending forward with backward with a hyperlordosis and upper cervical kyphosis. And my partner said, you're going to have to do a C2 to T2. Keep in mind, he's 34 years old. He's a young man, and doing a long fusion from C2 to T2 would be a horrible thing for him to live with for the next 80 years or 70 years. He doesn't have significant compression, but we decided that we needed to do a little bit of a decompression. Here's his scoliosis fuse, and I'm going to emphasize to you the fact that you should order scoliosis views probably much more than you already do, because they tell you so much about what's going on in the rest of the body. So we did a C4 and upper C5 laminectomy, a C4-5 bilateral foraminotomy, and a C2 through 5 instrumentation. We knew immediately when we opened him up that his spine was mobile and we could get this type of a correction and do a shorter segment fixation as depicted here and here, comparing pre and post-op. Here is his post-op MRI, and here he is pre-op. Notice the effect of correcting his deformity here compared to here on the rest of the body. The thoracic kyphosis has reverted to normal from a little bit more of an exaggeration. The exaggerated lumbar lordosis has moved to a more normal alignment, and henceforth there is significant improvement in global spine alignment by simply doing a C2 to C5 fusion. Scoliosis views can be incredibly important in determining outcome. Here we see the plumb lines in this patient. Here are two patients. This is my last slide. There are two patients with who had a cervical discectomy. The patient on the left wasn't corrected and has a focal kyphosis. The patient on the right was corrected and has a normal lordosis. The literature is abundant with data supporting biomechanical and clinical data that correcting normal alignment reduces end fusion degenerative changes. So it is much more likely that this patient would develop stenosis and degenerative changes at adjacent segments than this patient. I thank you very much. I can't hear you. I cannot hear you. I cannot hear you.
Hello.
Hello, now I can hear you.
All right. Thank you very much, sir, for the lecture. It was an honor to have you with us today. I hope next time we can have you in person. It was, are there any questions for him? Amit, please.
Dear Dr. Benzel, good morning from Kathmandu.
Good morning. Well, good evening for me.
And a very, very thank you to join us from Cleveland. And please extend my greetings to all your team members, to your family. We would have definitely loved to see you here and shake hands with you. But then somehow this problem of COVID is keeping us apart. But see you soon in Cleveland.
Okay.
Well, I appreciate and then I thank you for making these things very clear. And now when I do my practice, I really remember your words that your instrumentation failure is a surgeon's fault. And if I see something happening to my patient, I see how we can improve. Just two quick questions to you. In this endoscopic era, when the multifidus and the posterior musculoskeletal elements are being preserved, do you think the finite element studies which has been done in the early eras for the instrumentation still holds true? or we need a further evaluation of finite element analysis, keeping the multifiders and other elements intact? That's number one.
Okay.
And number two would be regarding the IONM study. Since I see you have done a lot of things on cervical spine instrumentation, do you think that the IM analysis, intraoperative neuromonitoring analysis, would be a little bit different in cervical spine as compared to the other spinal, say for example, thoracic spine manipulation? Thank you.
Okay. Well, first of all, I would not put a lot of stock in finite element analysis. I know that we're gravitating towards less invasive surgery, and I'm not sure what minimally invasive surgery means. Sometimes it means just a smaller incision, but more invasion because of the more of a disruption of the integrity of the spine. The cases that I'm dealing with here are all redo cases. And cervical deformity is a bit easier to understand than thoracic and lumbar deformity. I think there's still a lot of questions about PJK, et cetera, that are still unanswered and result in significant complications. Whereas in the cervical spine, I think we're coming to a resolution on how to deal with these. I think it's going to be a while before we make a big push from a minimally invasive or endoscopic perspective. What was the second question? I'm sorry.
Regarding the neuromonitoring, intraoperative neuromonitoring, because we find that the cervical spine manipulation is far lesser forgiving as compared to thoracic spine manipulation.
Yeah.
So what are your thoughts on that?
I will monitor intraoperatively. Number one, if I'm going to change the deformity and not have decompressed. So for degenerative disease, I rarely monitor. But for tumors, intradural, extramedullary, and most specifically intradural intramedullary tumors, I monitor routinely. And sometimes I ask myself, why? Because the monitoring goes down, say you're operating on an ependymoma in the cervical region, and does that mean you should stop? Sometimes the monitoring diminishes substantially, and the patient wakes up and moves well. But regardless of that, the other degenerative case that I would monitor is if positioning of the patient is critical. Then I'd monitor, because it will be a long time from the positioning of the patient for surgery until I get the patient decompressed.
Thank you very much, sir. Thank you so much.
Thank you for inviting me.
Thank you, sir. Now, the second lecture is no other than our dear Professor Mon Raj Sharma, and he is going to talk about ongoing research in low back pain. So the floor is yours. Thank you very much.
Thank you, respected chairperson, and thank you, Dr. Amit and the entire team for giving me the opportunity to share some of the areas of my interest. Though, unfortunately, I'm not that technically expert in the spine, but what I feel is what I'm going to discuss today. So my topic is why we should be interested in research, whether it's in low back pain or other. The first slide, kun चाहिँ हो? So I work in the Department of Neurosurgery at UTS, plus I also run the Department of Research at the IOM. So I bring greetings from both departments to all of you. So does doing research make you rich and famous? That is a question to the audience. For just one slide will be interactive slide. Anybody? Does doing research make you rich and famous? Pratyush, please. No? You know who this gentleman is? Okay. Who she is? Yeah, okay. So we know. Who this gentleman is? Anybody? Youngster? So, interestingly, Ranking Wave of University is the organization that ranks all the, all the researchers in the world. And this is Richard Kessler. He is the professor of health policy from Harvard University. And he has got the largest publication. He has got the largest publication in the world. And look at his H index and citation. But, before making this presentation, I also pain, another group of people. And we surgeons who are really devoted in surgery, they also inflate their data and say that, well, 70 to 80% of the will cure. So who cures? There is a problem. Just like this, they're like one elephant and six blind men. So everybody, because of their strong faith, believe that whatever they offer will cure the patient. Let's go to the basic fundamental principle of statistics and epidemiology. What makes any treatment effective for any disease? Natural history. Majority of the disease get cured by, if you give them enough time to, heal. Orphan effect, when you evaluate you monitor the patient very closely, they tend to have a positive impact. So orphan effect also takes care of many patients. Placebo effect is also there. We know, up to 30% of the patient with low back pain get better with placebo effect. Fraud, sometimes you erroneously claim that you do this treatment and I have cured this many patients. Lot of, this social media publicities. Fraud is there. And selection bias in treating patient. If you select the patient who will improve with the natural history and you institute some treatment and you claim that, okay, I have to, my outcome is more than 90% positive. And true effect of the treatment you institute is very low. And this is where, as a scientist, we should be concentrating. So, this was the, guideline from the, clinical practice guideline from American College of Physicians published in 2017. They have slightly tried to shift the focus of the spine surgeon to this. Now, they emphasize more on the non-pharmacological therapies, particularly for low back pain. No to analgesic, do something else, so physical therapies, lifestyle modification, all these things. And stronger caution regarding opioids. Too many patients are narcotized. It's easier for the physician, easier for the patient to get the prescription, temporarily relieve the pain, but that will perpetuate the problem further. And they have recently come that more evidence on mind-body intervention, yoga, tai chi, mindfulness-based stress reduction program. They are coming, and they recommend concentrating on this. So what has been the research from Nepal in terms of back pain? These are the lists. Probably, I don't know how readable this list is. Quite a number of paper. I am very pleased to say this here, that quite a number of paper publications from Nepal on the low back pain. Majority of them are retrospective, but it's still good. And there was, Dr. Thapa is no more with us. He wrote a paper published in Nepal Journal of Neuroscience back in 2016 on the, is open lumbar microdiscectomy safe at peripheral Nepal. It was also published. So quite a number of publications there. But saying this, there is a huge scope for doing a prospective research in the treatment of back pain. And with this spine chapter and the leadership, young leadership, I think we'll be able to do this soon. So I just look at the, this clinicaltrial.gov. This shows you the how many researchers are going on this. If you put the low back pain in the search, you get so many ongoing trial and research going on. And I think I have another one. So I just put the low back pain in the search engine, and you see there is so many 1,865 ongoing studies all over the world right now on low back pain. So it's people are doing the study, but the research, the conclusion is yet to come. I will take you through the short. This was actually displayed yesterday also. Saurabh Sharma from Dhulikhel Hospital did a fantastic systematic scoping review about the clinical pain research in Nepal. We'll be focusing on low back pain only, and there were a total of 15 studies on low back pain. And this is the slide, all musculoskeletal pain, low back pain, neck pain. So, and in terms of low back pain, dentists are the one who bear the greatest brunt in terms of professional hazard. And we surgeons, some are put in 60%, but if you specifically look at the spine surgeons or the neurosurgeon, I think they will go on the higher end because of the prolonged standing. And when we use the microscope, our neck bears the greatest brunt. Few studies of interest, there was a quadruple trial back in 2019 on photomodulation therapy on low back pain. They recruited 148 patients in each arm, and the outcome of interest was that really for back pain. The rationale for using photobiology on this, what they do is use of red and near infrared light to stimulate, heal, regenerate, and protect tissue that has either been injured, is degenerating or not. So the philosophy of, if there is chronic low back pain, all the tissues, including muscle and bone, undergo gradual irreversible degeneration, and this is arguably going to revert it. And this was published recently, actually, in Pain 2020 June, but unfortunately, the data was not there, that it was not working. So another trial of interest was the use of metformin on low back pain. Metformin use is, in the oral hypoglycemic agent. It was initiated at the University of Pittsburgh, again, quadruple trial. It started was 2020, and it is estimated to be completed by November 2022, but still the data is not out yet. Maybe they have submitted. The rationale of use of this metformin was this: the clinical neuropathic post-surgical pain studies implicate AMPK is a compound as a potential pharmacological target for the treatment of chronic pain condition. And metformin acts by activating AMPK, is safe and clinically tested for a long duration of time, and potentially it will be of use. But still the data is not out, so we'll be eagerly waiting. Another which has generated a lot of attention is the aerobic exercise. I'll finish very shortly. So aerobic exercise is also arguably going to work, and the rationale is aerobic exercise increases the blood flow and nutrients to the soft tissues in the back, improving the healing process and reducing the stiffness that can result in back pain. So I myself have experienced some improvement on this. And another is the acupuncture for chronic back pain in older adults. Back in Action trial, this is also going on, and hopefully this trial will be completed in November of next year. We'll have a data, though it is also used very rampantly all over the world, more in the third world country. Rational, I'm not going to say that because we all know. And other researches of interest are sleep ergonomics in low back pain. How you sleep at night makes a difference in the daytime, and effect of yoga and stabilization exercises in individuals with low back pain. These are also ongoing researches. So to conclude my presentation, we should learn some lessons from the history. This is a gentleman back in 1875. He was very interested in quantum physics. So he went to the professor and wanted to join physics, but his professor discouraged him that, almost everything is already discovered. There is nothing to discover, so you should not probably join. But what he said is all he did not want to discover anything, just learn the fundamentals. So he went on to originate the quantum theory and won the Nobel Prize. So even if some senior discourages you, don't get discouraged. And there will be a lot of opportunity in doing research on low back pain. We need to have our own data. Thank you very much for your attention.
Thank you, Dr. Mohan. Interesting talk. There is no two ways about it. We need to have our own data, and for that we need to have research. Anybody, any questions?
Thank you, Dr. Mohan. Well, I should appreciate your talk and your active participation in bringing the Neurosurgical Forum to the research societies in Nepal. Well, to tell the crowd, Dr. Mohan has been very active.
Hello.
In the National Health Research
Dr.
Council,
Vaishali?
and he is
Yes, sir.
the forefront in
Hello.
guiding the researchers.
Yes, sir. Yes, sir.
Community. So, sir, what do you think
Hello,
would be the best
Dr. Vaishali.
to encourage
Yes, sir, I'm there, sir.
Talents or young neurosurgeons into the research fields? Because your
Hello,
perspective had been
Dr.
a lot
Vaishali.
of negative points as
Hello,
well as
I am there, sir.
fame and
Yeah.
money. So
Can you
how
put
do
on
think
your
that
video,
can be
please?
there, besides the professional contribution one can make?
Thank you so very much for your question, Professor Amit. Yeah, if we want the real fame, we are in the wrong profession.
Jordan,
We know it
just
is
after this.
exciting.
Yeah.
So
Yeah, I can
we will have
immediately
some
see
fame.
you
We
now.
become a big
So you'll be
researcher, we will
presenting
have
your
some fame. But the way to
from that.
go and encourage research in developing countries like ours is to start with a small scale research,
Shali ma'am,
get the paper
You have my
published,
video,
or
no?
through the collaborative
we do
research,
have your
whether
video.
we can
That's
do
why I'm
collaboration
asking
with
whether I
any
have to play that
Indian
recorded one or
spinal
you will be
development
playing it
research
from your end.
No,
we
no,
can
you have
take
to
small scale
play the
research,
recorded
and
one. That would be
once we
better
become
because there
little
is a lot of
visible, then we
transmission
can
problem.
start
So I will
Yeah,
answer the
this is my
questions.
suggestion. But
sure,
only
sure. Not an
operating
issue.
and
That
seeing
would be
these things
better.
will
Yeah,
turn into
I'll play the
techniques in
video
no time.
and
Yes.
just hand over the question session to you, ma'am. Okay.
Yes, yes.
Okay, thank you, Dr. Mohan. I think so. Now we move to another online lecture. I think Professor Vaishali Suri from AIMS will tell us about tumors of the spinal cord, current concepts and classification. She's online? Okay.
Opportunity to participate in this conference. I will be discussing current concepts and classification of tumors of the spinal cord. Primary tumors of the spinal cord are relatively consisting of population-based data. According to the recent individual data, these tumors comprise of 3.1% of all CNS.
I think there is some problem in the volume, sir. I can give a presentation if you want.
Can you hear the volume, ma'am, of the recorded one? It is live and it's clear.
Yeah.
Volume.
Acha, it's clear there? Okay.
Yeah, it is well clear there, ma'am.
Okay.
Yeah.
When we look at the epidemiology, a lot of research has happened over the last century, and now a 2022 classification of epidemiology is completely different from what was proposed in the last 10 to 20 years. And interestingly, in 2015, on whole genome methylation array, epidemiology were divided into 9 and the current WHO classification is based on this methylation classification only, and they can be divided into 3 main compartments, that is supratentorial, posterior fossa, and the spinal epidemiology. Now, this is not only important for prognostication, a lot of research is now going on in clinical trials to investigate new interventions. Now, when we look at spinal epidemiomas, the classic epidemioma in the spinal cord can be grade 2 or grade 3. These are intramedullary tumors, and like other epidemiomas, these tumors may show historically presence of perivascular pseudorhodes, and they are immunohistochemically immunopositive for GNAP and EMA, and dot-like positivity for EBP50 is also noted. Usually these are located in the cervical or cervicothoracic region with a median age of 20 to 40. Interestingly, very small subset of grade 2 epidemiomas or grade 3 epidemiomas in the spinal cord, median amplification has been observed, and spinal epidemioma can amplify. It's a rare entity. 27 cases have been reported so far, and these are seen in the cervical or cervicothoracic region. Rectomeningeal dissemination is seen in a higher proportion of cases, and although WHO has not been given by the current classification, but usually these tumors behave as grade 3. Now, if you look at mesopapillary ependymoma, it's a slow-growing tumor which commonly occurs in young adults, and the prognosis is usually favorable with a 10-year overall survival of more than 90%. However, persistent disease with repeated operations requiring adjuvant therapy is seen in cases with local and advanced growth and cases with CSF seeding, and these are the cases seen in pediatric age or tumors arising in the conus. So thus, the mesopapillary ependymoma is now regarded as grade 2 by the current WHO classification. And we have also published one paper of mesopapillary ependymoma occurring in the lumbosacral region with CP angle
with the cerebropontine angle metastasis. On histology, what you see is perivascular arrangement of cells, and there is a myxoid degeneration, extensive myxoid degeneration in the background, and these cases are usually immunopositive for GFAP and show a very low MIB1 Li. Now coming on to the second tumor, that is spinal meningiomas. These are the second most common tumors in the intradural extramedullary location, and these comprise of 12% of all meningiomas and 25 to 45% of all spinal tumors. 80% of spinal meningiomas are located in the thoracic spine, and not much has changed as far as the WHO classification is concerned. In 2016 itself, brain invasion was marked as an independent criteria in grade 2 meningiomas, and this still holds true in the 2022 classification. And the markers which are mostly recommended for pathological evaluation of meningiomas include 1p14q, CDKN2A homozygous deletion, PTERT mutation, S3K27M, ME3 loss, and these alterations are actually associated with poorer prognosis. And mutations like AKT and SMO are seen in basal meningiomas and are therapeutically targetable. And other mutations like KLF, TRAF, phosphoinositol 3 kinase can also be seen in meningiomas. SMARC1 mutations are seen in clear cell meningiomas, and BAP1 mutations are seen in rhabdoid meningiomas. So in cases with inconsistent results, small genome methylation can be performed in cases with ambiguous histology. Now coming on to the gliomas and glioneuronal tumors. Spinal pilocytic astrocytoma is the commonest glioma occurring in the spinal cord, and 75% of the cases occur in the first 2 decades of life. The 10 and 20-year survival is between 80 to 100%. And the histology is very classic in a pilocytic astrocytoma. They show piloid features, or they can sometimes show presence of protoplasmic areas, EGBs, and rosenthal fibers can be seen. And sometimes you can see nuclear atypia, extensive endothelial proliferation in these cases, and these kind of changes sometimes make them difficult to be differentiated from high-grade astrocytic tumors. Interestingly, majority of the pilocytic astrocytomas, they show BRAF-KIA fusion, which is seen in 50 to 80% of spinal ependymomas. This is a diagnostic marker and is also a therapeutic target. And many studies are now being carried out to explore MAP kinase pathway inhibitors as therapeutic targets. Then coming on to the pediatric type diffuse high-grade gliomas, in 2012 itself, it was realized that most of the pediatric high-grade gliomas are distinct from adults, and majority of the midline tumors, they show K27M mutation, and the tumors occurring in the cerebral hemispheres, they show G34RB mutations, and thus diffuse midline glioma S3K27 altered has been introduced in the new WHO classification. These tumors are CNS WHO grade 4. They occur in thalamus, brainstem, or in the spinal cord, and the prognosis is very, very poor, with the 2-year survival rate of less than 10%. Histologically, they can look like even GBM, PNET-like, oligo-like, or pilocytic-like, but S3K27M specific immunohistochemistry is available, which can be used for diagnosis of these tumors. And we have done a study in which we have shown that although this entity has been introduced, their overall survival is not different from wild type tumors. In both wild type as well as mutant tumors, we found that the prognosis was dismal, and in the cases occurring in all locations, the prognosis was similar. That is, irrespective of the location, the prognosis remains dismal in this entity. Now, a few words about glioblastoma. In a autopsy series, it has been observed that 25% of patients with intracranial GBMs can show evidence of spinal metastasis or spinal seedings, but exact incidence is not shown. The GBMs, they classically show marked pleomorphism, mitotic activity, endothelial proliferation, and or necrosis. So what has changed now is 2016, classification introduced IDH mutation, ATRX mutation, P53 mutation, and 1p19q loss for assessment of these tumors. And in the the current classification in diffusely infiltrating astrocytic tumors, any tumor which is grade 2 or grade 3, IDH mutant should be subjected to FISH assay or any other assay for analysis of CDK and 2AB homozygous deletion, and if present would be called as astrocytoma IDH mutant CNS WHO grade 4. And again, a grade 2 or grade 3 looking IDH wild type tumor should be subjected to third promoter mutation, EGFR gene amplification, and chromosome 7. You should look for chromosome 7 gain and 10 loss. And if any of these alteration is present in a grade 2 or grade 3 looking IDH wild type tumor, it will be called as glioblastoma IDH wild type. Diffuse leptomeningeal glioneural tumor was introduced as a provisional entity in 2016 classification. These are actually indolent, slow-growing tumors with widespread and diffuse leptomeningeal involvement, and these are very rare and mostly seen in pediatric patients. And patients usually present with signs and symptoms of obstructive hydrocephalus. And on radiology, there is diffuse involvement of leptomeninges, but in a small subset of cases, nodular deposits or discrete masses can also be seen. Intracranial component can be seen in some cases with leptomeningeal involvement or nodular deposits along the parenchymal surface, especially in the posterior fossa region. Now, if you look at the histology, they look like any other monomorphic tumor like oligodendroglioma. The cells are seen in a fibrillary background, and they are importantly immunopositive for both glial as well as neuronal markers. And these are IDH wild type cases. And interestingly, they can show either 1p deletion, 19q deletion, or they can show 1p 19q co-deletion. And the majority of the cases on whole genome methylation analysis, two subclasses have been identified in these tumors, namely methylation class 1 and 2. And the prognosis usually is good, but even worse survival has been observed in some studies. Although a grade, WHO grade has not been assigned to this entity, they can either behave as grade 2 or grade 3. The grade 2 behaving tumors, they show basically 1p19q co-deletion and they belong to methylation class 1. And the cases which show anaplastic features, they show 1q gain and they belong to methylation class 2. Now coming on to extraventricular neurocytoma, these are the tumors which occur outside the ventricles, and mostly these are seen in the cerebral hemisphere, but 25 cases of extraventricular neurocytoma has been observed till date in the spinal cord. And these are usually the morphology is similar to other neurocytomas occurring in the ventricles, that is central neurocytomas. They actually look like oligodendrogliomas. They show neuropil-like substance in the background, and sometimes endothelial proliferation and mitosis can be seen. And MIB1 labeling index is usually low in such cases, and they come under differential diagnosis of ependymomas and oligodendrogliomas. And these tumors are usually synaptophysin and mu-n positive and are IDH wild type. On FISH assay, 1p deletion can be seen in a good number of cases, and however on genetic profile it has been observed that majority of the cases show FGFR tag fusions and absence of IDH2 mutation and MGMT methylation. And good favorable prognosis on long term. And thus, gross total resection is the gold standard of treatment, which is associated with better survival in spinal cord neurocytomas. And extraventricular neurocytomas occurring in the cerebral hemisphere can also metastasize to spinal cord, and few case reports have been observed in this regard. The other tumors which can be observed in spinal cord include schwannomas, neurofibromas, MPNST, Ewing sarcoma, ATRT rarely, and hemangioblastomas, chordomas, chondrosarcomas, osteoblastoma, plasmacytoma, mild lymphomas of the dura, and melanocytic neoplasms. I'm not going into the details of these tumors because of lack of time, but it is very important to now remember that it is very critical for pathologists to recognize the diversity of molecular testing which is available. New technologies need to be introduced for critical workup of cases, and interestingly, in places which do not have access to such technologies, the generous use of NOS labels is allowed. But the need of the hour is that we need to improve molecular detection methods if we want to follow the new WHO classification as in a balanced, optimal way. Thank you very much. Thanks for your patience.
Thank you, Dr. Vaishali.
Thank you,
for a
sir. Good morning,
brief,
sir.
Introduction, if I can say, to the various classification models and the latest development in the 2016 WHO classification. Any questions from the audience? Yeah.
Thank you, Dr. Vaishali Suri. So, ma'am, it had been a very pleasant talk from your side, and we had learned a lot. Just a quick question from you. Considering the spinal pathology, the biopsy specimen we receive from the spinal cord is very, very less as compared to what we can achieve from the brain when we compare it. Considering there's so many of molecular targeting which is available, how do you advise to efficiently use the very limited specimen we get in the spine? Do you have any recommendation for that?
Yeah, what I would suggest is, like, when you see the slide, like when you see the HND stain, then only you should decide like what all you want, and very, very judiciously you should actually use the panel of available immunohistochemical and molecular methods. And if you know with say a battery of say 5 or 6 single tests you cannot make a diagnosis, then it is better not to waste the tissue. And if you are keen on giving a correct diagnosis, then I would like to recommend you to actually go in for upfront NGS or methylation analysis. Unfortunately, in our country, those kind of platforms have not been standardized. I have recently put a request to ICMR to at least, you know, and mark either AIMS or identify 4 or 5 centers. It's very crucial at this stage to identify 4 or 5 centers in the country which can provide this kind of support to most of the centers in India. So that is what we are looking for in next 5 to 6 years. Otherwise, it is very, very difficult, as you say, because of the number of tests which are available, like the battery of tests which WHO recommends is very, very laborious. At AIMS also, we are, you know, trying to develop most of the platforms which are now available. So we have ongoing studies where we are doing methylation analysis, we are doing NGS analysis. Maybe, you know, in next 4 to 5 years, for difficult cases, for the cases which have less tissue, NGS facility would be available at economical cost. That's what we are looking for.
Okay, thank you, Dr. Vaishali. Thank you very much. And I think we move on to the next lecture in this session. And that is Dr. Pang Hung Wu from Singapore. And he's going to tell us about revision UBE.
Yeah, they will be playing my slide. Thank you for the invitation. Greetings, I'm Dr. Pang Hong Wu. My topic today is recurrent prolapse intervertebral disc and foraminal stenosis, revision bilateral approach by portal endoscopic decompression and discectomy. Introduction of myself, I'm practicing in Ng Teng Fong General Hospital, which is part of the National University Health System, Jurong Health Campus. Most of my surgeries are endoscopic spine surgery, which is also my subspecialty interest. I do a mix uniportal and biportal endoscopy. I acknowledge my mentor for their trainings. And the scope of today's talk is based on the following: incidence of recurrence prolapses, causes of recurrence of prolapses, revision surgery consideration, the technique of biportal far lateral approach revision decompression discectomy, and the techniques of management of dural tear. What are the reasons for recurrence of pain after discectomy? The incidence of discectomy, recurrence pain. Look, in the long-term outcome of discectomy published in the Journal of Clinical Neuroscience by the group led by Dr. Takato, they show that 22.1% of the patients after discectomy needs a reoperation in 10 years. 16.5% of patients actually had recurrent disc in the same level. 10% are recurrent disc, 3% are due to instability, and 2% are due to surgical site infection. And then there's another 5.6% of the patients because of operation of a different level. 75% of the repeat operations are done actually in the same level after a microscopic discectomy. Data from the American College of Surgery Surgical Quality Improvement Program database, this large database of 6,901 patients who underwent surgery due to recurrence of prolapses, 43% of them had recurrent disc revision and with fusion surgery, and 57% had revision discectomy. The fusion group of patients has more post-operative events and complications than revision discectomy. Hence, there is a consideration, if possible, in my opinion, to perform discectomy rather than fusion. However, we need to understand the benefits of minimally invasive surgery, such as endoscopic surgery, spine surgery, in the index operation when the patient has prolapsed disc. This is beyond just having a small scar. There are a few reasons that it benefits the patient in view that a fifth of them might need revision surgery in the future, even in good hands. First, we need to provide a pleasant post-operative surgical experience for patients who had very bad first operative experience. For example, they post-operatively they're in a lot of pain and they need to stay in hospital for prolonged duration. They may not want another revision surgery, despite the fact that they are probably in severe pain in the recurred when they have a recurred disc. So in such scenario, actually, the first operation, index operation, is a marker of future success. So hence, endoscopic spine surgery has a role. It allows surgery to be done in the ambulatory setting, if not a short duration of stay in hospital. Minimal post-operative pain occurs in most of the patients. Early mobilization, decreased perioperative complication-related immobility. More importantly, beyond the small scar, endoscopic spine surgery with good visualization and advanced equipment that supplement the surgery allow preservation of soft tissue and bony preservation. It's important to preserve the facet joint and posterior spinal elements so that when we do revision surgery, which also require further resection of bone and soft tissue, we will not compromise the stability and hence leading to the surgeon choosing fusion surgery rather than revision discectomy, and to minimize scar formation in the neural structure to prevent complications. We are also in the COVID-19 generation. Early post-op recovery and decreased length of stay is not only a good thing to do, but something that we should perhaps consider to do as a regular basis so that we can preserve hospital beds and oxygen supplies to patients who require COVID management. Early post-operative pain does occur as a post-operative phenomenon, and 10% of the patients experience rebound pain, is self-limiting after conservative treatment. The data by Dr. Chen Zhang is published in the Auto Search 2021, and they found this phenomenon. Another group, which is a very well-established uniportal endoscopic surgeon group by Dr. Berendrowski, Dr. Anthony Yong, and Dr. George Philip Ramirez. They are all pioneers in this group of transforaminal endoscopic surgery. They find that dorsal root ganglion irritation happens in about 1/5 of the patients, which also supports the earlier paper by Dr. Chen Zhang. Found that in foraminal stenosis and recurrent disc herniation surgery, and when they perform transforaminal surgery, these two group of patients, they have even higher risk of dorsal root ganglion irritation. My group, by my mentor and myself, also published data on the effect of dorsal root ganglion retraction leading to the DRG irritation, dorsal root ganglion irritations. And we suggest, or perhaps contralateral approach is one of the good methods to prevent these complications. And I further on also describe how to do that in the contralateral approach using uniportal endoscopy. Currently, I do both biportal and uniportal contralateral approach for various different cases, as well as in the transforaminal or bilateral approach using uniportal and biportal system in a different patient scenario. So our discussion point 2 is pain after foraminal discectomy is actually common, and evaluation of foraminal stenosis prior to revision discectomy is important in decision making. We need to understand the source of pain before we misunderstood the reason for the recurrence of pain after a prolapse intervertebral disc discectomy. We need to understand whether it's acute prolapse disc or it's just an annular bulge, whether there's a scar tissue enhancement or local perineural edema due to persisting foraminal and nerve root canal stenosis. We need to identify whether there's a presence of foraminal stenosis. Failure to understand these concepts can lead to wrong applications for revision surgery. Also note that there's a DRG irritation, and this is self-limiting, although it can happen perhaps a little bit more frequently in transforaminal endoscopic lumbar discectomy using the uniportal system. What are the key differences between primary and revision discectomy? In my mind, key differences in operating a patient with recurrence prolapse disc is there's some advantage and some disadvantage. The advantage of revision is that there's less bleeding and perhaps less bone work because it has been done before in the previous surgery. And less bleeding because of the scar formation and the disruption of soft tissue and its vascular supply leading to less bleeding. However, of course, being a revision surgery, there's perhaps more disadvantage and advantage in the surgery. Adhesion in many layers happen. It can happen in poor wound healing, can happen in the subcutaneous tissue leading to more difficult dissection. One of the main space
available solutions.
the previous surgery and then leading to this there's probably a higher risk of instability when you decompress further after initial work. Hence my earlier slide saying that we should try to preserve facet using minimally invasive technique and also preserve the posterior final elements using MIS techniques such as biportal endoscopic surgery or UBE. It's a picture of bleeding in a primary surgery. Before we actually get on to operating, sometimes when we put in the scope, there's quite significant bleeding. As you can see here, you can completely create a red screen, which decrease your confidence in starting the surgery. Of course, with careful coagulations using various radio frequency systems, such as the ones that's made by bones, can actually decrease bleeding and create a good view after you have cleared the bleeding sources. This is a case where we did revision surgery. As you can see, when you put in the scope, it's not so much bleeding. However, there's a lot of distance, adherent scar tissue. They don't bleed, but they are in your way. They are a little bit more resistant to being retracted or dissected. Hence, patients need to be there to actually slowly tease out all these adhesion tissue. Tools such as radio frequency ablator, as shown here, or a shaver, arthroscopic shaver, can be used. So this is a revision left L45 biportal bilateral approach decompression and discectomy. We did that recently, and it's a 35-year-old lady who have left cytoradicular pain over L45 distribution initially. They have a pain score of 8 and then trophic rate 70 with a decrease in power of L4 and L5. The initial presentation shows a foraminal disc, which she underwent a left transforaminal endoscopic lumbar discectomy in the L45 by one of my colleagues in the hospital, and she did better for about 3 months, but the pain subsequently recurred. And then she feels pain over the left L4 with a pain score of 5 to 6, but ODI is 24, and the strict mid rate is still 60 degrees. She had not feel satisfied for the operation, and the power of left L4 and L5 is still poor. Bear in mind, she did had initial first 2 to 3 months improvement. So in a way, the first surgery can have a short-term success for the patient. We did an X-ray. There's no cross instability on flexion extension film. As we can see, after discectomy, you can see from the picture on the right side that there is a discectomy that's performed with a residual scar. However, there is still a foraminal stenosis, an extra foraminal disc, as we can see from here. This protrusion, a bulge, is different from the initial surgery, where mainly is foraminal stenosis. So we managed her conservatively first, but the pain gradually increased over the past 6 months, 9 months after surgery. In a way, we rule out the rebound pain as she felt conservative treatment. We rule out dorsal root ganglion irritations as the patient has no improvement with conservative treatment. So what are the possible causes? We have seen the MRI just now. It can be recurrent disc, it can be instability, it can be foraminal stenosis. For her, it's a combination of foraminal stenosis and recurrence of disc, though the location of the disc is extraforaminal and foraminal location. So we can do, there are various options. One of them, we can perform a transforaminal approach or a spinal approach. We can perform an open surgery. It's a case of revision laminectomy done openly in the patients who had a previous unipolar endoscopic decompression. You can see that there is quite good preservation of bone surfaces. So even in revising unipolar or bipolar endoscopic patients, it is easier when you do it open. So this is one of the considerations for some of us who prefer to revise patients who have recurrent prolapses by open. So in a way, that's one option. The other option is that we can perform either, again, unipolar transforaminal approach or using bipolar transforaminal far lateral approach. The unipolar approach has the advantage of having the same scar, still MIS, direct docking in the Campbell's triangle. But as I said earlier, there's some disadvantages. First, there's limited ability to dissect the scar. Second, the docking is blind on Campbell's triangle, and in our case, the patient had foraminal stenosis and with adhesion to the neural elements. So possible injury to the exiting nerve root and causing dorsal root ganglion irritation, as shown earlier on by Dr. Kai Laurendrowski's group, is high in transforaminal revision surgery. So should we do open approach like what we do in this case? And of course, we can have the biportal system, which is also another good system, which is in between unipolar and open surgery, but shorter learning curve and minimally invasive in nature to consider. So to consider biportal, I consider that because we can dock on the bone. It's a floating technique rather than dock in Campbell triangle. Probably safer for the exiting nerve roots. We have open instruments or larger specialized instruments that can be used for dissection and hence easier to tease off the scar tissue. With a larger surface radio frequency available in biportal surgery, it's beneficial in my mind to get rid of scar tissue in revision surgery. I find that the floating technique in biportal surgery has less retraction of the exiting nerve root if required. So I went on to perform revision biportal left L4-5 far lateral approach. You can call that transforaminal approach as well in some people. Foraminotomy and discectomy. So the scar, we mark the incision 3 cm off the lateral pedicle of viewing and working portal on the TP, and then we dock onto the ventral lateral aspect of the superior articular process. I do give indigo-carmine in both primary and revision surgery, more likely in revision surgery to delineate the disc so they can give some guidance in surgery. So after we dock on the ventral lateral aspect of the left L4-5, as you can see on the X-ray, we also subsequently did ventral SAP osteotomy. And then for extraforaminal and foraminal discectomy, this is a video showing how it's done. So this is done on the left side of the L4-5, as you can see. After the prolapse disc revision, after TLD, we revise 3 cm off the midline, we set the viewing and working portal. You can see there's less bleeding in this case, however, a lot of dense adhesion scar. You can see there's some ventral foraminotomy done by my colleague. As you can see here, there's some ventral foraminotomy. So using that as a guidance, we went on to dissect the roots to the exiting nerve roots. In the 3 o'clock position is the foot of the patient. In the 9 o'clock position is the head of the patient. 6 o'clock position is ipsilateral, which is the left side, and 12 o'clock is the right side. We do further foraminotomy, further enhancing the foraminal size, increasing the foraminal size, as we are aware in the MRI that the patient has foraminal stenosis. We do a little bit of the lateral part so that we can get better access to the medial structures where the exiting nerve root and the at the entrance of the foramen, where the exiting nerve root exited. We slowly tease out the exiting nerve root. There's a lot of dense adhesion scar as we expected. You can be using forceps or kerosene to release the adhesion. And you can see from the indigo-carmine injection area that is lighted blue. So again, after we identify the nerve root, it's easier for us to perform more foraminotomy. And we release the nerve root. As you can see, there's some pulsation at the extraforaminal and foraminal region. we do it stepwise and slowly after we identify the existing nerve root cause. Throughout this whole process, we gradually tease off all the adhesion scar from the nerve roots. After we've done enough homework, I changed it to a 30-degree scope because you can maintain at 0-degree scope, no problem, because I wanted to see more medially, wanted to see the traversing nerve roots medially. Essentially looking at the axilla of this left-sided L45 segment. So we use the very curved Harrison to do foraminotomy. You can see now the lateral recess with the lateral recess fat can have a glimpse of the traversing nerve root, which is at the 10 o'clock position. And then we use a curette to reach medially. Then we perform discectomy, foraminal discectomy followed by extra foraminal discectomy using the forceps. You can see the discectomy is performed here. It's lighted blue by the indigo carmine. And then you can see the lateral end plates of the disc space of L45. The foramen has been decompressed, hence you can have a clear view of the exiting nerve root. Again, we have earlier on done release of the adhesion tissue. Now you can see a fully pulsating and free left L4 nerve roots. We also can see earlier on, we can see the L5 nerve root that is in the axillary region, and there's also free and pulsating. This is the scar, this is the disc. It's not a large disc in the extraforaminal region, but it's causing patient a lot of pain, of course, also due to the adhesion and foraminal stenosis. The patient is discharged on the same day, 6 hours after operation. This is the scar 2 weeks later. This is a result.
嗯，都挺舒服的哈，当天就回家了哈。
对哦，幸运。要不然我很怕住医院的。
对对对，好。
So as you can see from her description, she said she 很怕住医院. Actually, a lot of patients do not like to stay in hospital. So I thank my colleague who did the first operation for providing her a good experience as ambulatory transforaminal endoscopic surgery experience. And hence she's willing to go for revision. And fortunately for us, the surgery went well and she was discharged 6 hours later, and it was still a pleasant experience for her. So we do not underestimate post-operative surgical experience for patients, because that dictates whether they are willing to try to improve their condition with a revision surgery. In conclusion, management of revision discectomy using UBE is like climbing a mountain in my mind. Either you or your colleagues will have revision discectomy of decompression if they have done enough discectomy. 中文说得好，有说上得山多终遇虎. If you have done a lot of discectomy, you will have revision discectomy. My tips on climbing this UBE mountain of revision discectomy is: 1. Use the shortest and least complicated route to summit. Try to do the first operation using minimally invasive technique. It's easier to revise. 2nd, choose a revision technique that's less likely to lead to complications. If you can do a revision discectomy rather than a revision fusion, consider that. Of course, in patients who have instability, loss of bone loss, we have no choice. We still have to do fusion. Hence the importance of doing the first surgery right. Preparation is important. We need to be familiar with UBE techniques, be it the bilateral approach, interlaminar approach, contralateral approach, and other advanced techniques. We need to know how to handle the complication using UBE techniques. Also important is the clinical experience to rule out other causes of patient symptoms, such as dorsal root ganglion irritation and early post-operative pain is not related to recurrent disc. Finally, better view in UBE may reduce the chance of complications because the floating technique rather than docking technique in transforaminal surgery prevents DLG irritation, in my mind, in revision. The saline irrigation helps to dissect scar tissue together with the specialized UBE equipment, and the magnification allows clear differentiation of scar versus neural tissue. With that, I ended my talk. Thank you for listening. I hope you enjoyed.
Thank you very much, Dr. Wu. Now this paper is open for any questions from the audience. No questions? Okay, thank you. Thank you, Dr. Wu. We now move on to the next topic in this session: motion preservation in cervical disc surgery. Dr. Praveen Shrestha. Is he here? Online. Okay. He's also going to be online.
Namaste and greetings. I'm Praveen Shrestha, and being a current president of Japanese Society of Neurosurgeons, I would like to welcome you once again to this very vital event of our society. And at this moment, I really feel very sorry for not being able to present physically in this meeting, as I am out of country at the moment. And today, I am making this presentation with the help of this recorded video. Well, with many thanks to the scientific committee for giving me this opportunity today, I am going to present my topic on motion preservation in cervical disc surgery briefly. Well, I'm sharing my slide here. Well, I hope my slide is visible here. I'm presenting about motion preservation in cervical disc surgery. Well, as we all know, spine is a very complex structure with multiple elements like bone elements and joints, soft tissue elements including muscles, ligaments, and disc tissues, and neural elements. And out of many other functions of spine, motion is the primary function, as it controls the motion of not only the spine, but the motion of the whole human body. Well, whatever surgery we do in the spine, whatever spinal surgical procedures we perform, there are basically a few principles that we have to understand and follow. They are decompression and preservation of neural elements, and preservation and maintenance of the anatomy and physiology of the spine. They are maintenance of spinal vertebral alignment, maintenance and establishment of the spinal segments, and preservation of the spinal motion. Well, motion preservation in spine surgery is very, very important because if the motion is not preserved, there will be significant complications in the future. So, in order to maintain normal or near normal posture of the spine, and also to prevent adverse outcomes of lack of motion, when there is lack of motion in the spine, there is a local stiffness, pain, local deformity, adjacent segment disease, and degenerative disc disease at adjacent levels. Because of these factors, when the motion is compromised, we have to preserve motion in the spine in any spinal surgical procedures. Well, coming to the biomechanics of cervical spine. Cervical spine has 3 axes, 3 degrees of free movements, and the basic movements are flexion, extension, rotation, and lateral flexion. As you can see in this picture, in the cervical spine, there is 40 to 50 degree of flexion and 70 degree of the extension, and about 20 to 45 degree of lateral flexion or bending like this, and up to 90 degree of rotation in the cervical spine. And these varieties of movement in the cervical spine depends on the level of the spine. Well, at the level of atlanto-occipital joint, the basic movement is flexion and extension like this. And at the level of atlanto-axial spine, atlanto-axial joint, the basic movement of the rotation, which is up to 35 to 40 degree. And in the lower level of the spine, there are other varieties of the movements like flexion, extension, rotation, and lateral flexion. And in addition, there are other movements like compression and distraction. Basically, these movements, compression and distraction, are the protective function, protective for the spine. So in case of adverse movements, in case of adverse posture, because of this compression and distraction, there is a protection of the cervical spine. Now coming to the herniation of cervical disc, basically these are the main pathologies: degeneration and injury. Because of these pathologies, there will be a series of other minor pathological processes, which ultimately leads to the herniation of cervical disc. And different surgical procedures for the treatment of cervical disc herniation are ACTF, anterior cervical discectomy with fusion, laminectomy, posterior foraminectomy, laminoplasty, etc. Whichever surgical procedures we perform for this cervical disc surgery, the basic principles that we have to follow and understand, and the basic aims that we have to achieve are decompression of the neural elements, stabilization of the spine, and preservation of the spinal motion. So in order to achieve these aims, the main surgical procedure will be cervical disc replacement. This cervical disc replacement surgical procedure, it helps to achieve almost all of these aims in majority of the cases. Well, in ACDF, basically there are 2 procedures, like, as you all know, discectomy and fusion. And because of this fusion, there is to some extent compromise in the free motion of the cervical spine. And there is also possibilities of arthrodesis and pseudoarthrosis, in almost 5 to 10% of this in case of single level fusion, and up to 10 and 20% of cases in multiple fusion. Similarly, there is a possibility of development of adjacent level disease in up to 25% of cases in 10 years and up to 28% in lifetime after SCTF. Similarly, the possibility of reoperation rate in case of SCTF is as high as 5.6% in 10 years period. Well, SCTF is not a new procedure. It was first performed in 1960s, and that time also there was a concept of disc replacement. And that time also there was, they knew that the main objective of the surgery should be motion preservation and avoidance of complications of fusion. Since then, varieties of implants have been developed, and repeatedly the implants were redesigned to achieve the maximum motion of the cervical spine after the surgical procedure. Well, in addition to implants, there are several factors that we can take care of so that the spinal motion can be preserved as far as possible. For example, the placement of the implants in anatomical midline, so the placement should be in the appropriate location. Similarly, the osteophytes has to be removed adequately. Osteophytes also limit this motion of the spine, so they have to be removed. And once osteophytes are removed, the size has to be appropriate between the size of implant. So the size of implant and implants, end plates should be matching. The disc height should be maintained as far as possible. Multiple level fusion should be avoided, and correction of the local deformity should be done if possible. So these are some few points, key points, which also help to prevent, to preserve the spinal motion. Well, with the experience of more than 15 years of surgery in the cervical spine, more than 400 cases, among which around 150 cases do cervical disc surgery. With this experience, I present a few of the illustrations here. In the beginning of our career, as probably same with others also, this bone graft fusion and further reinforcement with mandatory plating and screw. This is a very good surgery for relieving features of radiculopathy and myelopathy because of the disc herniation. However, this kind of surgery may lead to some limitation in the cervical spine motion after some time. Similarly, bone cement fixation is very, very popular in our place. Many of us have been doing performing the surgery with the bone cement fixation. Personally, I also like this procedure very much. May it be single level or double level. This is how it looks after the surgery in the dynamic X-ray of the cervical spine. It has been fused with bone cement like this, and there doesn't seem to be any significant restriction in the motion as far as these X-rays. So similarly, as you can see here also, there is a very nice fixation of the vertebral bodies with bone cement. And sometimes even in such cases of the postoperative complications of recurrence of the cervical disc, as you can see, there is a herniation, there is collapse of the vertebral bodies. Even in such cases also, we can do bone cement fixation like this. But this kind of surgery, fixation at the multiple levels and reinforcement with screws and plates will definitely lead to some sort of some degree of compromise in the cervical spine motion. Similarly, in case of traumatic cases, SCTF and fixation with cage and screw also may lead to some degree of the spinal motion restrictions, even though these are very good surgical procedures for relieving the patient because of from the cord compression or spinal nerve compression. Again, in this case of multiple levels disc herniation with severe cord compression and leading to the cervical myelopathy, this kind of surgery definitely is very, very helpful. Again, this kind of multiple level fusion and fixation may lead to some degree of the spinal motion restriction. Then came this type of the cage standard cages. So fixation with this type of cage seems to be very good in terms of symptom relief, and also in terms of the spinal motion. As you can see, since in this type of case we can avoid anterior plating, the motion seems to be well maintained rather than the cases in which we fix with the anterior plate. So these are also very nice procedures, not only for the relief of radiculopathy or myelopathy, also for the maintenance of the cervical spine motion. And finally, this is the era of the technology, and this is cervical disc replacement with the help of artificial disc, which is also called cervical disc arthroplasty. This kind of devices, implants, leads to free motion at the level of cervical spine in all the degrees, wide range of the motion that we can achieve after the surgical procedures. However, this kind of implants are, I think, not available in Nepal, and personally, I also don't have any experience of using such kind of implants. So regarding cervical disc replacement, even though they are found to be superior to the SCGF, even though the cervical motion is well preserved with this kind of implants, there is not yet studies which have shown significant benefit in decreasing the adjacent level disease in the spine. So in conclusion, in the last 2 decades, significant advancements in the motion preservation technology have been made. So cervical disc replacement has gained significant popularity not only among the surgeons, but also among the patients in terms of the post-operative relief. Similarly, the socioeconomic status and locally available medical facilities are the main factors which help to decide which kind of implants that we are going to use in a particular case, because these devices, these implants are very, very expensive, and not all of our patients can afford for that. And varieties of conventional techniques and technologies that we have been using in our place for last decades, they also have been proved to be very effective and beneficial for symptom relief and also for maintaining the cervical spine motion. However, this is the era of technology, so we should follow and learn the newer technologies. We should catch up with the newer technologies so that we do not lag behind. Thank you. Thank you very much.
Thank you very much, Dr. Praveen. Do we have any questions for him? No questions? Well, is he still online? No. Okay. So we move on to the next talk. Dr. Amit Pradhananga will talk to us about challenges and opportunities in starting MIS surgeries.
Good morning, respected chairpersons and members on the dais and the delegates. I'm Dr. Amit Pradhanang. I'm currently a faculty in Trivandrum University Teaching Hospital and mainly interested in spine. So I'm here to present my our experience over the last couple of months. The other this one. It's A6. So we've been, this last couple of days, we've been talking about motion preservation, minimally invasive procedures, UBE techniques. So I'm here to present something which is more simpler, more easy to do, you know, in once you're starting MIS techniques or minimally invasive techniques. So as I go about my presentation, I hope you will realize that this is even a very simpler techniques using the same instruments you are so much familiar with, using the microscope, the bayoneted instruments, the bipolars. You do not require very sophisticated equipments, and the learning curve as well is not very steep. So you can, after maybe a couple of surgeries during MIS, of course, starting with very simple cases, this is very easy to catch up and very much applicable in our part of the world. Are we getting the presentation? Okay, thank you. So I'll be talking on commencement of MIS techniques in our setup, the challenges and opportunities that we are faced with. So, of course, the philosophy of any minimally invasive surgery is, of course, most important is to reduce the surrounding tissue trauma, which will lead into a faster recovery period, while still the most important is to maintain efficacy of the surgery as compared to the open technique. So the goals of doing any MIS surgery is, of course, as in open surgery, is to improve the pain, improve the neurological condition, improve the quality of life, while at the same time shorten recovery and shorten the rehabilitation period. So apart from that, minimally invasive surgery aims to reduce the pain from exposure. This is the most important part. It also helps, studies have shown that it also helps to reduce infection, the hematoma formation rate, the CSF leak, and the nerve injury rate. The most important again is to reduce the injury to the surrounding tissues, and also because we are preserving most of the supporting posterior spinal structures, we reduce the adjacent segment disease as well. There are three main elements of the MIS platform. That is, first of all, we are using very small portal approaches. Second is there is a requirement of magnification and good illumination. And third of all is a supplemental localization using the fluoroscopy and the navigation. We can use the magnification and illumination either with our most familiar microscope. We can use the UV technique endoscope. We can also use an attached camera to the portal, which is known as the vision technique. And with that, you can even avoid the microscope you can just use a screen in front of you. And so the approach related issues, like you can see in open techniques, we have such large incisions, detachment of a lot of muscles, using the bovie and separation of the muscles from the spinous processes, muscles are retracted for hours. So of course, which will lead eventually to a lot of muscle atrophy, scar tissue formation, which will result into postoperative instability to some extent, bleeding, a lot of bleeding, length of stay, of course, of the patient will be increased. The mobility of the patient after a long open surgery, of course, will be more than what you do after minimally invasive technique. The rehabilitation period may be longer, infection rates have been shown to be higher, and most importantly, the pain is more than what we achieve after MIS. So there is a look at the MRI to see. This is on the post-operative open technique, post-operative L4 L5 decompression. You can see you can see the muscle atrophy on the image on the left hand side, on the left paraspinous muscle, a lot of muscle atrophy. While if you compare the image on the opposite side, you can see there's almost same. The muscles they don't show any scar tissue atrophy after MIS fusion. So what is the evidence of doing an MIS? For lumbar disc herniation surgery, they have found in multiple studies that the surgical time, the blood loss, complications, and outcome are the same. However, the pain medication requirements and the duration of hospitalization is significantly less. What about lumbar decompression? In MIS decompression, it is equivalent. The outcomes are equivalent with, however, with less bleeding, length of stay has decreased, there's fewer complications, and produces less segmental motion compared to open in cases of lumbar decompression surgeries. What about lumbar fusion surgeries like TLIF? MIS PLIF is equivalent to open in clinical outcomes, fusion rates, and significantly less bleeding, length of stay, pain, transfusion of blood, and complication rates. There is also good evidence that MIS decreases the infection rate, both in fusion surgeries as well. So what are the MIS techniques that are viable that we can do? First of all, we can do basic surgeries like discectomies, decompression for spinal stenosis, low-grade spondylolisthesis, evacuation of hematoma, and further on, we can slowly move on to more advanced techniques. So here the patient positioning is not much difference than what we are acquainted with. The patient is prone with on the Wilson's frame here. We have the microscope by our side to the left and the fluoroscopy and image displayed in front of us. Incision is usually tailored to the pathology you are trying to approach. Maybe for discectomies, you just require a small, maybe 2.5 to 3 centimeter incisions, 1.5 centimeter off the midline. However, for fusion surgeries, you might require an incision that is placed about 4 centimeter away from the midline. You can have multiple level incisions or single level incisions, multiple level incision with facial incisions below. And after you give the incision of about maybe 2.5, 3 centimeter incision, you go on with the tube placement. This is the most important. The docking, proper docking of the tubes is the most important. Otherwise, you will often land up with difficulty in correct exposure of your area of interest. We initially use the initial dilator directly through the skin and facial incision. Make sure to make the facial incision very generously, because you don't want to struggle with trying to perforate this facial incision. So sometimes I make the facial incisions even more than the above skin incision. Then the first dilator, you go on to palpate. In case of discectomies, first of all, palpate the spinous process. Run the dilator down along the spinous process to the lamina spinous junction. Feel the facet. The facet is usually, you can easily feel the bony prominence of the facet. For discectomies, you can usually dock the, this thing in the lamina spinal junction there. Most importantly, you have to be able to create some space, detach the muscles, sweep the muscles with the initial dilator to and fro from your areas, because you might have to, take the dilator a little bit. You might have to move the dilator a little bit after you place it finally. So the pearl is usually for discectomies, you have to keep it dead perpendicular to the to your disc space in MIS discectomies. And for MIS T-lifts, you have to make sure the dilator is placed right on top of the facet joints. Here is, after you place the initial dilator, you start placing sequential dilators over the initial dilators down to the lamina. We often use a twisting motion to ensure the dilator. You don't press it, you twist it down to all the 4 marks are seen. So if most of the time the resistance is met if you have not opened the fascia adequately. So take it out. If you are facing difficulty, open the fascia a little bit. Muscle is not, it is not very difficult to, negotiate through the muscle bluntly. So do not use a lot of force. That is the main tip there. And once the dilators are placed, you can see the table adapter usually placed on the opposite side, to hold the final dilator, and it connected to the retractor arm. Once again, check the fluoro, for the correct placement. On the above C-arm screen, you can see I'm doing it for the discectomies. The tube dilators is right in the middle. The disc space is right in the middle of the tube dilator. However, for the second one, where we are doing the T-lift there, I'm using an expandable dilator. Once the tube is placed in, the dilator is clicked open. Okay. However, both the facets, both the pedicles, both the pedicles of the level you are fusing above and below should be within the diameter of the dilator there. And these are, sorry, back. So the requirement of instruments it's very simple. You don't need an endoscope. You don't need an RFA. These are just plain serial dilators, adapter. A little bit of bayoneted instruments more than what you may require in open discectomies. That's all. Of course, we have the microscope and the C-arm together. So here we are doing a discectomy out here. First of all, after you have correct, there's always a layer of soft tissue that you need to excise over the lamina. Well, this may be one little disadvantage of what we see in the UB technique. UB technique, you really don't need to take out any tissue at all. But here, there's a very small, thin ring of circular muscle tissue that you need to just remove above the lamina. So the trick is to use the Bowie, coagulate all around, hold it with a pituitary forceps. Do not try to pull it, otherwise you're going to have bleeding. And try to, the edges of the thing, try to shrink it more with Bowie so that you have the maximum amount. You can make use of the maximum amount of what is available to you here. So once you identify the lamina, the procedure is almost the same as what you are doing in open technique. Use the monopolar to visualize the lamina. Do not try to damage the capsule of the facet here. Go below the lamina. And after that, after you expose the lamina margins here, you use the drill. You use the drill. Initially, you can use a burr to thin the lamina. Like it was discussed yesterday, preservation of the ligamentum flavum it protects you from drilling into the dura. So that is very important. The ligamentum flavum should not be excised initially. Preserve the ligamentum flavum all the way till you have drilled all the bone completely. So once again, adequate use of lateral fluoroscopy, at least in the initial stages, to make sure where you are drilling and not drilling excessive of what you really require. And the ligamentum flavum is slowly removed under vision. Here you can separate the ligamentum flavum from the dura using a blunt dissector, and of course the lateral ligamentum flavum is also removed. And once the shelving edge of the lateral most aspect of the ligament flavum is removed, you can of course see the nerve root, which is retracted with there's a special suction retractor equipment. You can retract the nerve root as well as suction at the same time, and then you can remove the disc piecemeal. So after you have done your part, the confirmation, before you remove the tube, it is always the muscles, they fall off as you start removing the tube out. So make sure that you take it out slowly and coagulate along your path if there's any bleeding on the muscles. And they're just the main closure is just 3 facial sutures. After that, subcuticular suture on the skin. So what are the opportunities that we are facing in our hospital here? It is, first of all, there's a large patient flow. There's the charge for the surgery, minimally invasive technique, maybe just nominal, very nominal. And we have a strong advantage of good support from our friends from US, who every year we have our workshops, focus on some aspect of the minimally invasive surgery or spine. We have yearly teaching like in the November Spine Week, we have the teaching learning activities, live surgeries, demonstrations. We also have reinforcement courses, like we just had last week in April, reinforcement courses. And also we have support Nepal Spine Foundation and the required equipments as well. So here are a few moments from our November Spine Week in November, where we had lectures, we had live surgeries, discussions of the patients, and from that onwards, we have picked up really from in MIS. The challenges, of course, we have to cater, because it's a referral center, cater to a long list of waiting patients, limited OR time. So initially might have difficulty because, of course, your OR time in MIS was going to take longer initially. So you have to negotiate really with other cranial cases as well. The learning curve in MIS is, believe initially first 1 or 2 cases, maybe it'll take around 3 hours, 4 hours maximum, but I'm sure after, and even the experts, they say that after 10 cases, you can really reduce the time to, 1.5 hours. That's 1.5 hours of the time it takes us to do MIS discectomies at least. Radiation exposure, again, like the learning curve, it is more initially you want to reconfirm, check, reconfirm, check, reconfirm. But now MIS discectomy is not more than 2 to 3 shots. That's it. Visualization, of course, at least it seems less initially. You just have that little bit of circle you're focusing on, but you will realize that is the only required visual area. Even if you do an open surgery after such a big incision, you cannot move away from that little circle. So ergonomics, you require some little bit more of bayoneted equipments, to do, because you have to be able to just work in that little tube. Surgery, of course, as I said, it will shorten as you keep on doing. And revision surgeries are, of course, more difficult and better to be avoided initially. So most frequent complications, Usually happen, of course, in the learning stages. Most frequent complication here is the durotomy. And maybe sometimes you may not go in for adequate decompression, inadequate hemostasis. So how to avoid the dural tears, which is the most frequent, careful attention to anatomical planes, first of all, that is the most important. Check for dural adhesions. Do not insert your kerison rongers, before you have dissected off from the ligament flavum down from the dura. That is the most crucial step. And do not reach from beyond what you can actually see within the tube. That is another crucial, important step. And better to, do not struggle, if you cannot visualize if you have not reached the targeted area, again, put the last dilator there, shift the tube, confirm from re-X-ray and take it out. Take out a little bit more muscle. Do not struggle, okay? Just because correctly placement of the tube is the most important step here. So what happens if a dural tear occurs? You always have a potential, convert it quickly to an open surgery, and actually you're doing more harm that way. The chances of CSF leak is more after you convert it into an open. Because, if it's a small durotomy, you have already realized it, you have controlled it, and maybe put some Surgicel or a piece of muscle, the muscles will eventually fall back and tamponade that place. So do not convert it, as long as you can handle it within the tube itself. So what are the pearls for a successful minimally invasive surgery? First of all, select your patients very carefully. Do not choose very heavy patients initially. Use fluoroscopy adequately. Do lumbar cases before cervical cases. Do unilateral discectomies before trying to approach the contralateral approach. And if you have to do a contralateral approach initially, use 2 tubes instead of trying to negotiate the other side of the field. So again, avoid revision cases before, do decompressions before fusions, single levels before trying to target multiple levels, use smaller weight patients. Of course, we have to know the anatomy of the open technique before we try to delve on this, and the pertinent anatomy and the of the patients of the scans. So use the largest tube when possible initially. Use whatever tube the largest is, use it first. You can slowly, as you gain more experience, you can decrease the tube diameter later on. And of course, to practice, once you have opened in an open case, put the tube initially after where that open space is, and then try to get used to the anatomy within that circle within the tube. So our experiences since November 2021, we have done 10 MIS lumbar discectomies, 4 MIS T-lifts, 1 posterior cervical foraminotomy discectomy, total of 15, out of which we had 1 patient, 1 complication, intraoperative durotomy. We just managed with a piece of muscle, no suturing of the durotomy. The patient did not have any CSF leak. Blood loss was very minimal. We discharged the patient of discectomies on the next morning. MIS discectomies, we initially, I think we keep it for 2 to 3 days, but our target is to discharge the patient, admit the patient in the morning of the discectomies and discharge them in the same evening. And T-lift maybe 1 or 2 days we'll still keep. Here's one just a representative case of T-lift, very happy patient, MIS T-lift. And a record of the patients we've been keeping here. So this is the trend of the lumbar discectomies at our hospital. The blue ones are the open discectomies. You can see suddenly the paradigm is shifted. All the lumbar discectomies are MIS discectomies unless it is a redo case. So in conclusion, MIS discectomies, MIS techniques for spinal decompression are safe, effective. There's a steep learning curve for these techniques. Complications can be minimized with careful patient selection, awareness of anatomical details, and slowly gaining surgical experience. Thank you.
Thank you, Dr. Amit. That was, I think, a very nice exposition of how to begin and how to continue with an MIS technique. And you saw how the conventional discectomies have kind of just become very little or none at all. So open for the house. Any questions?
Thank you, Dr. Amit. Great job. Please keep it up. Next talk is nobody needs an introduction. Professor S.S. Kale, who have been a very strong supporter to Nepal in all of his fields, whether neurosurgery, spine surgery, from beginning till today. And we hope he'll continue to do that in his best of his capacities. So Professor Kale will be talking on spinal tuberculosis, current consensus and updates. Very important topic. Thank you very much, sir. Please continue.
Thank you. Good morning, everybody. Thank you, NESON and Dr. Amit Thapa for this invitation. It's always a pleasure to be here. And I think this is the second time this year I'm here. And in the last few years, I must have come here at least 8 or 10 times. So I almost feel like home. Anyhow, so by the time we have the slides being set up, I want to go back to the first talk of Dr. Mohan Raj Sharma and the question Amit had asked. What advice do you give to the young people? You know, everybody wants to do research, but how to begin? So I have one tip for everybody, especially the youngsters. The first step is record keeping. I think if you just start keeping a detailed record of every case you encounter, especially the ones you operate, because we are all surgeons. The first step is that just do your logbook properly. Keep a record of whatever happens to the patient, whether he becomes all right or he has a complication. And once you have a record book, then you can review it and then you know, okay, this is what is, you know, something will just pop up like this in front of you. Oh, this has happened to my patients. Why is this happening? What is this happening? So I think the first step is record keeping. If we can improve our record keeping, our data, it will definitely lead to some meaningful outcomes and meaningful research. So the first step for youngsters is to keep data, keep a good record. Anyway, so let us begin our talk. It's a slightly longish talk. However, I'll try to cover as much as possible in the given time. Next slide, please. Or can I move the slide from here? Okay. So, I mean, the subcontinent, the doctors, the surgeons, everybody, they deal with a lot of tuberculosis patients, and so is true for neurosurgeons as well. So I'm going to dispense with all the introduction. We all know what to do. We all know how much to do, but still, as you collect data over the years, you realize that these are the 4 crucial problems which we usually encounter. If not in every case, then at least in some case or the other, after a few cases, you wonder, should I stop the chemotherapy now? Should I continue? Should I continue for 12 months, 18 months, 2 years? Just stop at 6 months? Don't know. Still the jury is still out on that. How much ATT to give? Second is, suppose there are some features of myelopathy. I'm not talking about gross problems, neurological problems, but the reflexes are slightly brisk and the plantar may be upgoing. The patient has spinal tuberculosis. Should I go in and operate, or should I just continue with anti-tuberculosis treatment? The third is the approach. If I have to approach it, say in a thoracic spine, should I go anterior? Because it's not very difficult going anterior in thoracic spine. All you need to do is a thoracotomy and collapse the lung, and you're right away, right on top of the lesion. Or you should do it indirectly. You go from the back, you do a posterior approach. And finally, what do I do if there is resistance? You know, how do I know there is resistance, and what to do if there is drug resistance? And as we go along this talk, we will also encounter some terms which we must know. What is MDR? What is XDR? And all those things, so that it gives us a better understanding of the resistance and how to deal with this. So these are the basic 4 questions which we are going to answer. Now, a few examples, just this, I think we can skip that. So let's come to the diagnosis. How do you diagnose tuberculosis? You know, for us in the subcontinent, you look at an X-ray or you look at an MRI, 9 times out of 10, you will be right. You know, if you diagnose as tuberculosis, you will be right. But that's not accurate. You need to have some evidence, because this is the era of evidence. And what kind of evidence can we get to prove that it is tuberculosis? the old conventional culture, the LJ medium. And alternatively, you have this Middlebrook agar. It takes lesser time, 10 to 15 days. Or you have this latest automated technique, the BACTEC machine, and it can give you a result in 13 days. So that is by far the fastest you can probably diagnose the bacteria, because unless you diagnose or look at the bacteria, most of the times you're not sure whether it is tuberculosis or not. So it still takes 2 weeks. It takes 2 weeks to definitely identify the mycobacterium. And that's a problem, that sometimes you don't have 2 weeks. Another thing which is developed is the DNA line probe assays. It takes about 48 hours. It's a sequencing based PCR and DNA detection. It's called Gene Expert. I don't know, maybe it is available here too. It usually is all over the place. And now the latest we have is the next generation sequencing, and targeted gene sequencing is available, but it is quite expensive and not many centers have it. But that can probably give you a faster result about how to diagnose tuberculosis. So there is an interesting study, a comparative study on the role of expert, that is the gene expert MTBRF, in testing in different types of spinal tuberculosis tissue specimen. So what was the conclusion of this paper? That the yield from biopsy and culture is low and variable, and there is a range. If you look at all the studies published, if you look at the literature, the range is from 36 to 91% accuracy of the biopsy and the culture. And which tissue is the best? Is it pus? Is it granulation tissue? Or is it the caseous necrotic tissue? Which test is the best? Again, we dealt with that in the last slide. What to do if you're in an endemic area like ours? Should you start ATT clinico-radiologically, or should you wait for all these test reports or confirmatory tests to come? Should you always do a biopsy? If you think it is tuberculosis of the spine, should you always do a biopsy and send the specimen? I think the answers to this is what we will look at in the next slide. However, one thing I'm sure of, and that is probably universally accepted, that wherever you can, please do a biopsy preoperatively. You do a biopsy, a CT guided biopsy if possible. Do a biopsy, send some pus culture for culture, or send some necrotic tissue or granulation, whatever you get from the biopsy, or the bone, if it is from the bone itself. But do try and take a biopsy and send it for culture, so that at the end of 2 weeks, at least you have some evidence, if not in 100% cases, at least in the given number in different series. So what's happening in India in the revised National Tuberculosis Control Program, in the latest revision in 2017, they have given a national plan for the next 5 years. And the aim is to eliminate TB in India by 2025, which I think is a very idealistic aim. However, it's good to have these big dreams and big aims. So what does it say, this revised National Tuberculosis Control Program? It says we must detect all cases. So, and in every case which you diagnose as tuberculosis, you must have rifampicin resistance. You must look at rifampicin resistance, because resistant tuberculosis is rampant. For new cases, you start with 2 months of this HRZE and 4 months of HRE. That's the recommendation of the RNT in 2017. If there is a relapse or you need to retreat, again 2 months of HRZE, and you can add streptomycin here, plus 1 month of HRZE, and then 5 months of HRE. But before that, you must know the drug susceptibility. That is for the relapse or retreatment. And you can increase the duration by 12 to 24 weeks. That's what the RNTPC says. It gives you the leeway as a clinician. You can increase the treatment by 12 to 24 in both groups, especially if there is skeletal tuberculosis. And now the second line drug, bidaquiline, is now available. So in case there is resistance to the first line drugs, you use the second line drugs. So this is an interesting book published by the Health Ministry in India in collaboration with WHO. It's called Index TB Guidelines. And they called from all over the country, they called the group of clinicians who who deal with tuberculosis patients. They sat them down together, they discussed, and a consensus approach was outlined. And this book basically tells you the consensus approach of all this group of doctors, which got together and decided on how to advise about RNTPC in India. Now, what does it have? It has working definitions, it has an extensive literature search, and it has a consensus statement on how to deal with different types of tuberculosis. So I would recommend anybody dealing with this to definitely go through this book whenever you are in doubt about how to manage a particular case. So what does it identify, this index TB guidelines? It definitely identifies that there is lack of consensus for skeletal TB and especially time TB, for spine TB, especially for the duration. There are still some surgeons who treat for 1.5 years. There are others who stop at 6 months. There is no consensus, especially in a country like India, which has hundreds and thousands of patients treated by different people all over the country. There is no consensus on the duration of treatment. However, HRZE plus 10 months of HRE, that is what is recommended in this index. So you give 2 months of 4 drugs and then 10 months of 3 drugs. That is what is the recommendation for skeletal and spine TB in this index TB guidelines. And you monitor in the first few weeks for any neurological symptoms which are developing. How do you follow up these patients? You do an X-ray 3 monthly, contrast MRI at 6, 9, 12, and 18 months to assess the treatment response. This is what is the recommendation of the index TB guidelines. And you keep following the patients after the treatment is completed, 6 monthly follow-up till the next 2 years. This is how is the recommendation of the index guidelines. Now, let us look at drug resistance. What is drug resistance? If the bacteria is resistant to one of the antibiotics, it is called as monoresistant. Usually, it is the most common is INH. About 1 in 10 to the power 6 patients have a natural resistance to INH. And the same thing is true, but in a slightly lesser frequency for rifampicin. 1 in 10 to the power 8 bacteria will have resistance to rifampicin. And that is the basis for polydrug therapy, because that is a naturally occurring resistance of the bacteria without even any intervention by chemotherapeutic agents. Naturally, they develop these strains which are resistant to these bacteria. Now, MDR TB is when it is resistant to INH and rifampicin. Polyresistance is resistance to all first-line drugs. XDR, extremely drug resistance, that is all the first-line drugs, that is especially INH and rifampicin, plus one of the fluoroquinolones and one of the second-line injectable drugs. So that is extremely drug-resistant TB. And then you have these 2 new additions to these definitions. Pre-XDR FQ, that is MDR plus resistance to fluoroquinolone, and pre-XDR AM, that is MDR plus resistance to aminoglycoside. So these are the definitions. You know, we generally say, oh, it is resistant TB. But resistance to what? Resistance to how many? That is important to know for us to decide which therapy to give. These are the various drugs. I don't need to go into this. You can get it in any probably standard textbook or any WHO criteria. Now, what are the WHO guidelines for resistant tuberculosis? They are slightly different than the RNTPC guidelines, which were developed in collaboration with WHO. This is again available in any standard reference book. You will find it. The important thing is the duration is 18 to 24 months. So that is even WHO recommends that for resistant tuberculosis, you need to treat for a longer duration, at least 1.5 years and up to 2 years. Now, what about operations? The optimal treatment strategy and duration of chemotherapy remains unknown, as we just saw. And we have some guidelines, but we probably have to go by our clinical judgment and the radiological investigations or the biopsy and the resistance profile which we have of the bacteria. As far as the surgery is concerned, there is no prospective or a randomized controlled trial available. Surgical interventions have been many. The approaches have been anterior, posterior. Some people have gone for very radical surgery, like the Hong Kong operation. I remember in the 70s and early 80s, they used to radically excise everything which looked like infected from TB and reconstruct the spine. And then from there, some people advocated only biopsy to confirm and then chemotherapy. The argument being that tuberculosis is basically an infection. It's a medical problem. It has to be treated with drugs. Surgery is needed only in some cases, not in all. For an infection, you don't need to excise the whole thing. You need to confirm it and to treat it with antibiotics. So the surgical therapy has ranged between these two extremes. Excise everything, the Hong Kong kind of operation, or do nothing, do a biopsy, confirm, and give antibiotics. Now, another important thing which you must remember is what is paradoxical response, or when do you say this failure of therapy? There are two different things, paradoxical response and failure. If there is a radiological increase in the size of the lesion, despite good compliance, you confirm that the patient has been taking therapy regularly, even then the size of the lesion has increased, and there is non-progression of neurological deficits. There is no progression of neurology. It's only the X-ray or the MRI which shows that the lesion has increased in size. And the ESR is normal. You see, ESR or all these blood investigations sometimes are a good marker. You see that the inflammatory markers are not increased, but the radiology is increased. Then you say that it is probably a paradoxical response. And failure of treatment, of course, you will have symptoms. The symptoms will increase. The neurology might increase. All the inflammatory markers may be increased. And the radiology will say that, okay, the lesion is not decreasing in size, or maybe it has increased. Lymphocytopenia is also associated with paradoxical response. That's another thing which you can test, the absolute lymphocyte count, to see whether there is paradoxical response or a treatment failure. What do we do? Suppose there is a paradoxical response, what do we do? Do we do surgery? Probably yes. You need a biopsy. You need to confirm again. And so first step in surgery would be a biopsy. And if the biopsy is inconclusive, maybe for a paradoxical response, you also need surgery. What about the sequelae? You have treated tuberculosis, the patient is responding, but after a few months, there are some sequelae. So the most important and the ones which we are bothered about most is the paraplegia. So if it is early onset paraplegia, the prognosis is good. Prompt ATT and surgery will probably get his legs back. So be careful about early onset paraplegia. And if it is there while the treatment is going on, you need to intervene. You need to operate immediately. Late onset paraplegia, especially the ones which happen 2 years after a disease-free period, these may be due to residual kyphosis. And then the treatment of this is slightly more difficult because you're treating deformity rather than the infection. And the management is different for both. If there is a relapse or there is no relapse, only the deformity. And finally, if it is just a purely deformity, the patient might have had tuberculosis in childhood, but he presents in adolescence or in an adulthood with a deformity. There is no consensus for optimal timing. Some people have changed, like the team from Ganga Hospital, Coimbatore. Now they advocate that do minimalistic surgery. You should not, if there is a grossly deformed spine, don't go in for those big radical surgeries to try and straighten out the spine. Be conservative. And this opinion has changed in the last few years, including Dr. Rajsekharan, who is an authority on spinal tuberculosis. Interesting paper which got published a couple of years ago, 6-month versus 12-month ATT. And this paper seemed to say that 6 months in spinal TB is also enough. And what they did was they did biopsy multiple times to prove, once before and once after the 6-month therapy was concluded. And similarly, on the other arm, they had patients with 12-month treatment. They compared the two and they came to the conclusion that 6-month ATT for spine TB is also good enough. However, not many papers, you won't find any paper which has replicated this. So whenever some startling new evidence which cannot be replicated, I would put a red flag on it. Be careful with this. I would let you go back to the index publication or the RNTPC as a guideline, rather than base your treatment and stop it at 6 months based on only one case report or one article published. However, now there is evidence which says that the bacteria can be killed. All of them can be killed in 6 months of antitubercular treatment. What do you do with myelopathy? Well, there is a randomized trial by MRC. No benefit of surgery plus chemotherapy over chemotherapy alone. So if there is mild symptoms of myelopathy, there is an MRC trial which says that you probably can avoid surgery. With or without functional impairment, most often responds to chemotherapy. However, if the functional impairment is gross and there is paraplegia or the bowel bladder is getting involved, I would rather not wait for the chemotherapy to take effect. Probably you need to go in and decompress the neurological elements. But mild myelopathy, just brisk reflexes, upgoing plantar, you have a good trial which says that chemotherapy without surgery is good enough. What about the index guidelines? They say the monitor the patients for worsening of deficits, and if the deficits are worsening, there is consensus that you need to intervene. However, if the patient is not worsening or gradually improving, you may probably continue only with chemotherapeutic agents and avoid surgery altogether. Well, this is another book which we had, a monogram, which we had put together from AIMS for NSI. And that goes by the name of Current Practices in Neurosciences. And this particular issue was on tuberculosis of the thoracic spine. So because we deal a lot with patients with paraplegia, that's why we focus more on thoracic spine. And this book is, this monograph is also interesting. It gives you a whole lot of evidence and some ideas how to manage your patients properly, including some flow charts. Here is one which is here, which tells you about how to manage these patients. So, I mean, this lecture can go on. So I think let us come to two or three important slides which are remaining. One is indications of surgery. In this current era, when you have these good second line drugs also available, and you can treat these patients with these drugs, what are the surgical indications in this current era? So these are the two broad headlines: deformity, abscess, and instability. If you have a deformity of the spine, or if there is a clear-cut abscess which you see on MRI, maybe intraspinal or perispinal. And third, if there is instability of the spine, and I don't need to elaborate on how do you diagnose instability. We all are very well conversant with those parameters. So if these three, any of these three are present, probably there is no doubt in any surgeon's mind that we need to surgically intervene. So deformity, abscess, instability. These are the three main key. Mind you, you see, it doesn't directly say neurology. It says instability, it says abscess, but it doesn't say neurology. So the fine distinction over here. We must remember that. Oh, there are many publications. You can probably, I can just skip through all this. How about which approach to take in a thoracic spine? Do you go anterior? Do you go posterior? So in this monograph, we had listed out the advantages and disadvantages of each. But however, there is still no consensus. As what I see is, the more you get into this spinal surgery practice, the more you realize that the posterior approaches are safer, they are less time consuming, the recovery is faster, you don't have a chest tube in place, there is nothing, you don't have to worry about the lungs. And so overall, the posterior approaches are less problematic. That is for sure. However, if the lesion is big and pressing, and it is in such part of the thoracic spine which can be easily approached by a thoracotomy, if it is behind the heart or something like that, then it's a problem. But if it is in D8, D7, D6, you can easily get by a simple thoracotomy, press the lung down, and you're right on the lesion, and you can address all the issues. The abscess can be removed, the deformity can be corrected, and the instability can be stabilized, all by one approach. So for some areas of the thoracic spine, I would also recommend anterior approach. However, the consensus was that the posterior approaches are safer, they are faster, they are, you can have good stability of the spine, and the lung is not an issue, so less complications. Here's another flow chart which is there. This is the small study which we had done comparing anterior and posterior, And our results, I think I will summarize in the last slide. This was the outcome. As you see, the difference between the anterior approach group and the posterior approach group was that the local pain alone was more in one group. The motor deficits were almost the same. The bladder involvement was more in group 2. Frenkel grades almost the same. And preoperative Cobb's angle was this in both the groups, almost similar. The level of afflictions, there was slight difference between the two groups. This was the various operations which we had to do, and it spanned all the regions of the spine. And if you see the last column, the p-value, if you see the ones in red, these are the 4 things which we had found significant difference between anterior approach and posterior approach. One was the blood loss. Of course, it will be less in anterior approach. Second was the kyphosis correction. We got more kyphosis correction in the anterior approach. And the last 2, that is the MRI. In the MRI, the cord area, how much percentage change was there after the anterior approach or after the posterior approach? This was much more in the posterior approach. And the MRI sagittal cord diameter change, again, it was more significant in the posterior approach. So these were the differences, but I would still say that I would leave it to you. Both are probably equal. With posterior, you have less complications. Sometimes you have to do a combined approach, especially if there is a gross deformity, you might have to do a combined approach. However, most of the times you can get by with one, either anterior or posterior. So to conclude, neurologic improvement is not dependent on the type of approach or age or the duration of paraplegia. This is important, except in the acute onset ones, in which the patient while on treatment develops paraplegia. Then there is a neurological improvement dependent on the speed with which you address the problem. Good fusion is seen irrespective of the approach. You see, TB is a very forgiving disease. Whatever you do, anterior, posterior, just a biopsy, only stabilization, 1 level above, 2 levels above, 3 levels below, whatever you do, it's a very forgiving disease, because the mainstay of the treatment is the anti-tubercular treatment. As long as that is being given properly, I think all these things will settle down. And the treatment of choice finally needs to be individualized to the patient and also to the surgeon who is dealing with the patient. Because if you're not well conversant with a particular type of approach, I would rather you avoid that instead of being adventurous. You stick to the time and tested ones which you have done before, and believe me, you will have equally good results as any other surgeon dealing with tuberculosis of the thoracic spine. Thank you very much for your attention.
Thank you, sir. What we've just heard is from the working encyclopedia in this particular subject, but unfortunately, we're really running out of time. He's with us for the whole day. So let's please, sir, I'm sorry. Okay. He's with us whole day, sir. We can catch him up, and let's make sure that he's kept very, very busy. Thank you so much. Thank you all the moderators. Due to the lack of time, Dr. Neelam would be present in the evening. So we'll disjoin this particular session now.
With this, we've come to the end of our first session on state of spine surgery. We would like to extend our deepest gratitude to our speakers and our moderators for such an informative session. I would like to take this opportunity to inform you that we've been displaying talking posters outside, and they will be displayed till 6 p.m. So I would like to request all of you to go and watch the posters in your free time. Similarly, the sponsor stall is also set up outside. So in your free time, you can go and see the exhibition. Due to lack of time, we will be merging our tea break with our next session. So you can go out and get the tea and then bring it here, because we won't have a time allocated differently for tea break, but we have decided to merge it with our next session, which we will be starting right away.
Our next session is a collaborative symposium with Association of Spine Surgeons of India. Before heading onto our next session, I would like to invite Professor Dr. Amit Thapa, the Vice President of NESON, to introduce the collaborative symposium and for welcome program by NESON. Thank you.
Thank you. Well, the whole aim of this meeting had been to have a collaborative symposium with our international partners. And the first in league is Association of Spine Surgeons of India, regional leaders in spine treatment, surgical treatment in our part. And we are very fortunate to have the president of ASSI with us, who will also be giving us a welcome speech from the society. Well, it's thanks to my mentor, Professor Kale, who had introduced me to SSI, and I'm also a member of SSI for that reason. And I'm very much pleased to have the top speakers from SSI on this platform to share their experiences. And from our team also, we will have two key speakers who will be sharing their experiences from Nepal. So let me invite Professor Shankar. I think Dr. Shankar is online. Please put him on the display.
Yes, good morning.
Good morning, sir. Over to you.
Good morning, all my friends in Nepal and India and those who are watching us live. I thank the organizers of NewsCon 2022, INSPINE 2022, and especially Dr. Amit Thapa, who has invited us all members of ASSI and our faculty of ASSI for this collaborating session on non-fusion techniques in spine surgery. I think it's a great honor for me and my members of the ASSI and the executive committee and others that the Nepal Neurosciences Society had invited us, and we are always happy to collaborate with them. As you just mentioned, Dr. Shashank Kale, who is also a personal close friend, has always been interested in joining hands with neurosurgeons and orthopedic surgeons. And we in Delhi Spine Society and the Association of Spine Surgeons of India follow the same. I welcome all my co-faculties and I welcome Dr. Amit Thapa. We can go ahead with the session. And I hope we'll have a great interacting discussion. Thank you.
Thank you, sir, for that welcome address. And we definitely would like to see all your members in Nepal soon. Maybe because of this physical problem of COVID, we could not interact physically. But then thanks to you all and your team for having made your presence. I'm handing over the session to the MCs to continue.
Thank you, sir. Now, we would like to jump right into our next session, which is a session of symposium with ASSI on motion preservation in spine surgery. The moderators for this session are, I would like to welcome founder and chief neurosurgeon, chairman at Annapurna Neurological Institute and Allied Sciences, Professor Dr. Basanta Pant. Sir, may I please have the honor of welcoming you on the stage? He will be here with us soon. Moving on, I would like to welcome our second moderator for the session, who is the organizing secretary of INSPINE 2022, Dr. Samir Acharya. Sir, may I please have the pleasure of inviting you on the stage? Thank you, sir. Next up, we have consultant neurosurgeon at Upendra Devkota Memorial National Institute of Neurological and Allied Sciences, Dr. Pratyush Shrestha. Sir, may I please have the honor of welcoming you on the stage? Thank you, sir. Now, I would like to hand over the stage to our moderators. Thank you.
Without spending much of your time, I would like to request Dr. S. Chahal to present his paper. It's on motion preserving technologies for degenerative lumbar spine, the past, present, and future horizons.
It's a recorded talk. Good morning. Good morning.
I think, Rupinder, they wanted live talk if you have the time. Otherwise, because this was only a backup.
I will need to rush into the OT, so I have sent my recorded talk.
Okay. Then they will put the.
Morning. On the behalf of Association of Spine Surgeons of India, we thank the INSPINE organizers, especially Professor Thapa, for inviting us to this conference. I'll be speaking on the motion preserving technologies for degenerative lumbar spine, the past, the present, and the future horizons. So what is motion preservation? It's finding and utilizing a treatment if surgery is needed that does not necessitate a fusion procedure. Like in cervical spine, we do laminectomy, posterior foraminotomy, posterior discectomy, laminoplasty, cervical disc replacement. And all these procedures can similarly be replicated in the lumbar spine along with interspinous devices and facetal arthropathy. Motion preserving devices can be categorized into main 4 types: total disc replacement, prosthetic nuclear replacement, posterior dynamic devices, and facetal replacement. So why do we need prosthesis? It's to maintain and restore discogenic instability and give a pain relief to the patient. And who are the patients for arthroplasty in spine? Patients with proven discogenic pain or instability without advanced degenerative arthritis, and those who have failed to respond to a reasonably good conservative treatment and now are having a significant troubles with activities of daily living. And their pathology has been demonstrated radiographically, both X-ray, MRI, and or discography. What lessons have we learned in the past? The logic of the time says that by 20th century, the spinal problems were very well recognized, and the most procedures performed included discectomy, laminectomy, but they had their own failures. The disc space collapse, loss of mobility, recurrent protrusions, canal foramen stenosis, scarring, instability, dural tears, and neurological sequelae. Fusion was often attended by perioperative morbidity, pseudoarthrosis, stenosis, sacroiliitis, fixation failures, adjacent segment instability. And it became a gold standard of care for a failed spine. Stabilization of spine after discectomy by lucid pegs with ethyl had met no enthusiasm. So looking at how the history of arthroplasty has evolved, you looked at Paul Herman in early 59-61. He had 13 cases, 9 did well, but he had to lose his California license and spent 2 years before he was allowed to practice again. Similarly, Ulf Fernstone had treated 105 patients, and he said he had excellent results in 85% patients. But his critics said the remaining 50% of his patients never worked again, and he was again suspended. Similarly, Ritz and Zobat tried with steel balls, hemispherical and slastic arthroplasties, and had their surgeries suspended. Al Mackenzie had a short-term results of 40 steel arthroplasties and was obliged to suspend the procedure in 1974. So not all good happened. If all the foregoing were true, what happened? What logic shelved the procedure for more than 30 years? The simple answer is spinal fusion had been designated as a gold standard of care in the belief that once it was perfected, all our spinal troubles would be over. In spite of this historical profusion of spinal implants, newer instrumentation, different surgical approaches, use of biological agents, the need for gold standard remained unrequited. So far, the choice of arthroplasty has never been limited to those achieved by the anterior approach, with some of those surgeries producing new kind of morbidity. Though we strive for movement and stability, but at present, we are mostly doing fusion. So the question is, fusion versus movement, what is desirable? If in a hip, the picture on right is right, why in spine, the picture on right is not still accepted as right, and picture on the left is still considered as right and gold standard? So looking at the evolution of disc arthroplasty, although initial treatment options of leg pain, treating leg pain, back pain, preserving neurological function, providing stability were there. So what improved with total disc replacement? It re-established the disc function, maintained motion, obviate the need for bracing, early functional recovery, reduced future reoperations, and brought about improvement. So lumbar disc, intervertebral disc replacement ought to have the same biomechanical properties as body's own disc with regard to segmental height, normal excursion of segmental motion, and degree of lumbar lordosis. So who are the real candidates for disc replacement in lumbar spine? Patients aged 30 to 50, discogenic pain, mostly limited to L4, 5, and 5S1. Significant conservative management trial of at least 6 months, back and or leg pain without evidence of any root irritation, normal electrophysiology, ovestry more than 30, VAS more than 40. Battagnoli and Kumar postulated criteria that define the optimal patient profile. Disc height more than 4 millimeter, no degenerative arthritis in facet joints, no segmental degeneration, intact posterior spinal elements. The first ever disc prosthesis, as we already spoken, described by Fernstone in 1950, now more than 100 types of mobility preserving intervertebral implants have been described in the literature. The modern disc prostheses are firmly anchored in the upper and lower end plates of the vertebral bodies adjacent to the degenerated discs by metal plates and have a sliding central component made of ultra high molecular weight polyethylene. So disc prosthesis can be a constrained, semi-constrained, and a non-constrained. So what are constrained prostheses? The inlay is fixed in the end plates of the lower vertebral body, possesses a fixed center of rotation around which only flexion, extension, and lateral bending movements can take place. Whereas in a non-constrained prosthesis, the sliding central component can move freely. The center of rotation does not have a fixed location. Translation and rotational movement of prosthesis remain possible. SB Charité prosthesis is the most commonly used. It's an unconstrained type, has a biconvex polyethylene core lying between two cobalt chromium or baldium alloy end plates coated with hydroxyapatite to enhance osteointegration. Due to the biconvex shape of the polyethylene core, the disc space must be distracted more. There was a third version of Charité in 1987 with the broadened end plate which minimized fracture and subsidence. In 2007, disc motion replacement was released to facilitate the insertion of the Charité. Another type of disc, the ProDisc 2, this type is second most commonly used, can be described as semi-constrained. Like Charité, it has a chromium cobalt alloy end plates with pure titanium plasma pore surface to improve osteointegration. In contrast to SB Charité prosthesis, luxation of polyethylene core can occur whenever ProDisc 2 is used. ProDisc 2 can be positioned best even if the space is limited due to anatomic conditions or if the course of the vasculature is unfavorable. ProDisc L and Active L are the only two LDR prostheses approved by FDA, and 2 levels were approved in April 20. But nothing new has entered the market for last 10 years now. Other LDRs available which are not FDA approved are from Stryker, Maverick, Freedom, Kinemax. So what are the lessons we have learned? Contact surface must be maximized in order to prevent subsidence, allow for wider load repatriation and less stress on end plates. It mandates interior approach. Ideal implant design, both viscoelastic load distribution and articular motion. Most designs today, namely the Charité 3 and the ProDisc 2, have largely abundant viscoelastic consideration and focused on motion preservation. Some designs using viscoelastic properties of silicon or elastic properties of spring or piston or both, less importance on motion preservation. Still looking for a device which can produce both roles. Experience from joints has shown us that material best suited for millions of cycles of articular motion are hard and have low friction coefficients. These materials such as metals, polyethylene, and ceramic inherently lack additional viscoelastic properties. Thus, the search continues. Prosthetic nucleus replacement. The prosthetic nucleus replacement necessitates evacuation of only the nucleus pulposus through an annulotomy. Otherwise, the annulus remains largely intact. The optimal indication for artificial nucleus replacement is a monosegmental degenerative discopathy. Lumbar pain should be the main symptom. For a PDN prosthesis, the disc height should be at least 5 millimeters. A sufficiently stable nucleus container should be documented by discography. A pain provocation test can be carried out at the same time and disc confirmed as a region of pain. Other indications such as post-nucleotomy syndrome, primary disc prolapse are still undergoing clinical evaluation. Reliable results are not yet available. The use of nucleus prosthesis for these indications therefore cannot be recommended at present. Posterior dynamic devices, there are many types. Dynamic or soft stabilization and rigid are both typically pedicle screw based. The screws are connected by flexible longitudinal member. Currently available devices articulating ball joint to the longitudinal celestic rods. Looking at the meta-analysis of 16 trials with 881 patients with a follow-up around 4 years, says the advantage in terms of operation time, blood loss, complications, and adjacent segment degeneration other than those treated with lumbar fusion. No difference in improvement in ODI, VAS, range of motion of adjacent segments. Superior to fusion to some extent, although some of its advantages have yet to be verified and compared with those of lumbar fusion. However, two interventions were not significantly different in terms of relief in symptoms, functional recovery, and motion preservation. The interspinous distraction for spinal stenosis. Interspinal process devices may also be considered posterior dynamic stabilization devices. These devices consist of an implant that is superimposed between spinous processes. These available in the market are Dime from Medtronic, X-Top, Coflex from Paradigm, and Abbott's Wallace. These are interspinous based implants. Looking at this analysis, they said compared to open decompression, mini open IDD had similar clinical outcomes, but associated with higher complication and reoperation risks and cost. Mini open IDD had a better outcome over non-operative treatment in mild to moderate lumbar canal stenosis at 2-year follow-up, may be a suitable alternative to decompression and interbody fusion for a stable grade 1 spondylolisthesis and central stenosis. To conclude, each design attempt to emulate one or more of the essential biomechanical properties of intervertebral disc. Long-term clinical outcomes continue to be measured. Surgeon must be increasingly circumspect when considered performing a new procedures whose long-term efficacy is not established. The appropriately high cost expectations of our patients will be properly addressed by a prudent clinical judgment in selecting the best as opposed to the newest invention. To conclude, most arthroplasty designs and ball and socket types, it's not physiological. We are still searching for an ideal prosthesis which can mimic natural disc and provide necessary physiological function. The posterior dynamic devices are still in early stage and lack long-term results to prove their efficacy. Thank you.
Thank you, Dr. Sahal, for this very interesting introduction to motion preservation in spine, a very new topic to most of us here. Are there any questions from the floor?
I have one question. So you have talked about this nucleus prosthesis, which is quite interesting. So what is your indication for this nucleus prosthesis? What kind of patient, in what kind of patient do you put this prosthesis? Is it for large disc to prevent the reherniation or recurrence?
These are all on trial basis. I think they are not available in India as such. This is more of a literature review, and they are not marketed as such.
Sir, my question to you is, what is your patient selection criteria for a nucleus, for putting this nucleus prosthesis?
According to what trial do they say, it is a proven discogenic pain with a good amount of annulus. If the annulus is not there, then you cannot use these devices. A good annulus with a degenerated disc and a pain generator being the disc. So there you replace the nucleus with these PTN devices.
Thank you. Next question.
Hello, sir. So my question is, I was very much interested in the prosthetic disc. So my question is, when we can start the rehabilitative process or exercise after the prosthetic disc being changed? Because usually in case of other kind of surgery, we tend to start in maybe within a month or 1.5 months. So when can we start?
What exercises are you talking? Patient is mobilized in a normal 2-3 days, and you don't restrict movements. You don't give him a brace. That's the difference from the fusion. And you don't start the heavy work because depending on, you don't know how much subsidence it can take place. So you play a little safer. So the normal activities are allowed.
Yeah. Thank you, sir.
If you don't have questions, let's move on to the next topic. Let me invite Dr. Soumyajit Basu, who is presenting on cervical laminoplasty or laminectomy plus fusion in multi-level cervical spondylotic myelopathy, the pros and cons. Dr. Soumyajit Basu.
Thanks for asking me to speak on this. Can I have my recorded talk, please?
Yes, sir.
I have submitted a recorded talk. Is it possible to play that? Good morning. At the outset, I'd like to thank the organizers, Nepalese Society of Neurosurgeons and Association of Spine Surgeons of India to set up this collaborative effort. And I wish all success to this conference. Cervical laminoplasty or laminectomy plus fusion in multi-level cervical spondylotic myelopathy is my topic, and I'll be discussing more of the pros and cons of these two techniques. To start with, we know that for CSM, anterior approach is usually done for anterior compression for less than 3 levels of disease in the presence of kyphotic deformity and the absence of congenital stenosis or OPLL. Whereas it is primarily a posterior approach if there are more than 3 levels of disease, if it's a normal or lordotic spine, cervical spine, presence of congenital canal stenosis, no radiculopathy, or the presence of OPLL. Now, if you have to consider fusion in multi-level CSM for posterior approaches, the cervical stenosis-induced myelopathy is treated by expanding the space available for the cord, and the options of laminectomy alone versus laminectomy with lateral mass or pedicle screw rod fixation and laminoplasty as an alternative posterior approach has to be considered in details. Now, some important questions which should be addressed to choose the most appropriate technique would include, firstly, the alignment of the cervical spine. In the spine, lordotic, straight, or kyphotic. Posterior procedures are primarily indicated for lordotic and possibly straight spinal configurations. The next issue to be considered is how rigid is the deformity. Fixed kyphotic deformities are an absolute contraindication to the posterior approach. And if there is a static or mobile subluxation, that means it's an instability. Obviously, fixation and fusion is to be done. Finally, does the patient complain of significant axial neck pain? It has been traditional teaching that laminoplasty does produce actual neck pain and should be avoided in patients with pre-existing neck. The perspective of laminectomy with the concept that on removing the posterior elements, the cord gets a chance to shift backwards, thus producing decompression all around, is based on the fact that the cervical spine has to be lordotic. Laminectomy was considered to be the gold standard initially, but this technique is associated with many disadvantages such as post-laminectomy kyphosis, segmental instability, and subsequent neurological deterioration, including the formation of the laminectomy membrane, has made this procedure quite unpopular. If it is reinforced by instrumented fusion and typically indicated in multi-level CSM, then the question of laminectomy fusion has to be taken into account, and it is also indicating the presence of instability with subluxation more than 3.5 millimeters on static lateral radiographs and more than 11 degrees of angulation, which are noted to be of the unstable type, and this is where laminectomy fusion really. As an example, if you consider this spine in which the patient on extension is quite lordotic, whereas on a straight spine on the CT scan, you can see in the neutral position, it was just about straight. And so this patient underwent a laminectomy fusion so that we could restore lordosis, as has been exemplified here by multi-level lateral mass fusion. And if you can see that there is a multi-level cervical compressive disorder for which a laminectomy fusion is the treatment of choice. The steps of laminectomy fusion would include exposure, putting in the pins or the tracts for C-arm conformation for the lateral mass screws, and then to cut gutters on both sides with high-speed drill, and the entire end block laminectomy is done, including all the levels together, and then the screws and the rods are inserted. It is important that you do the laminectomy first, because if you do not do it, if you put in the screws first, then cutting the gutters might be a technical problem. The laminoplasty as a technique is used to treat multi-level cervical spondylotic myelopathy or myelopathy associated with OPLL and multiple level spondylotic radiculopathy. It was first reported by the Japanese population in 1982 by Shuji, and it is an effective way of maintaining anatomical cervical reduction. It retains a covering of the flavum, or so-called roof over the spinal cord, and thus laminectomy membrane is not formed, has the advantages of minimizing instability, limiting constriction of the dura from extradural scar formation, preserving motion, avoiding complications related to fusion. However, it is contraindicated with more than 13 degrees of kyphosis and severe. Hirabayashi is credited with the first description of the open door laminoplasty with sutures. O'Brien used mini plates, and finally Sheffrey placed a bone graft underneath the mini plate. So who is the ideal candidate for laminoplasty? A symptomatic multi-level spinal cord compression with straight or lordotic sagittal alignment with minimal axial pain, with a relative contraindication of more than 13 degrees of kyphosis, segmental instability, and significant axial neck pain. And the level is usually chosen from C3 to C7, and decompression must extend rostral and caudal. That means we take out the lower half, or lower 1/3 of C2, and put in our burr underneath the dome of the C2 posterior process, and also the cranial 1/3 of T1, so that impinging of C2 once the cord shifts back and T1 doesn't occur. So these are the steps in which you can see that the high-speed burr is cut through unicortically on one side and bicortically on the other side, and then it is hinged open, and that is the area of the dura which is exposed, and the entire canal is expanded. Other techniques like Z+T, open door technique, or double door technique as described. Let us look at this 41-year-old typical patient with virtually a straight spine or a little bit of lordosis, about 10 degrees of lordosis in the neutral position. And as you can see, he's got multi-level OPLL with a large compression, both anterior and posterior, underwent an open door laminoplasty, in which you can see these are the mini plates, and that is the amount of canal which is opened out at the level of the OPLL. And this is the final picture, in which you can see this entire segment of the spine has been pried open, and this is the dura over this which Surgicel has been put, and these are the 5 levels of fixation through mini plates. Other techniques which have been described include double door midline laminoplasty, but I do not have any experience with this. But there are still potential issues with laminoplasty, including wound infections, segmental root level palsy, including C5 palsy, neck pain, loss of motion, postoperative kyphosis, and rarely though, but there is significant number of patients who have progression of OPLL. This patient is a 55-year-old male who had a OPLL at C4-5, for which decompressive oblique corpectomy was done. And after the oblique corpectomy, a few years down the line, he developed a compression lower down, which was not there initially. And here, as you can see, there was a severe cord compression just below or caudal to the area of compression. And for this, a C3 to 7 open door laminoplasty was done, and thus the canal was reopened, and you can see a definite increase in the canal. So let us come down to what makes our choice for lamifusion versus laminoplasty. Several meta-analyses has been quoted, out of which Chen and Fellings are the two most reputed ones, which are very oft-cited. And Chen has reported that laminectomy fusion had a higher rate of reoperation than infection, but Fellings suggested that both have similar effectiveness, similar loss of lordosis. Possibly laminoplasty is a shorter operative time and less C5 palsy. Both can have sufficient decompression and improvement. In both, the muscles are widely dissected. Laminectomy fusion was associated with a higher rate of C5 palsy, and a previous meta-analysis by Lau et al. Found that the incidence of complications was not very different. So this is a paper which is very oft cited regarding laminoplasty. It's a debate in which the topic was laminoplasty is the preferred procedure. And now what is true about laminoplasty is that it does preserve range of motion. There's no possibility of pseudos, lower risk of infection and reoperation, no need to post-operatively immobilize the spine, potential for easier revision. Laminectomy fusion has a higher rate of C5 palsy. Laminoplasty has a less amount of neck pain and it's cost effective. But there are certain flip sides of laminoplasty. Axial neck pain is commoner. 30% patients have kyphosis by the end of 5 years. Progression of OPLL due to motion preservation might happen. And the value in kyphotic or neutral spine is still debated. And mini plates may fail. So example of a 64-year-old gentleman with cervical spondylotic myelopathy, as you can see, the pre and the postoperative MRI at 1 year shows adequate decompression. But the adequate decompression can also be mimicked by a patient who has a laminoplasty, and this is the pre and post 1 year postoperative MRI. So both tend to give equal results so far as decompression is concerned. So the take-home message would be, first decide if you want to use the posterior approach. If it's multi-level CSM with a preserved cervical lordosis, a predominantly posterior pathology, and contraindications to anterior approaches there. Once you decide it's going to be posterior, then decide whether it should be laminoplasty or laminectomy and fusion. If there are no instability or axial neck pain, laminoplasty would be better. If there is a dynamic instability, or if it's a straight cervical spine or a little bit of kyphosis with an achievable lordosis on extension view, then laminectomy plus fusion would be the treatment of choice. Thanks for your kind attention.
Thank you, Dr. Basu, for beautifully taking us through laminoplasty and laminectomy and fusion. A question, sir. Considering the kyphosis would take time to occur following laminectomy, is there an age beyond which you would just do a laminectomy and not fuse, like elder populations?
Thanks for the question. You know, laminectomy is usually done in a similar fashion as laminoplasty, because tidbit laminectomy or piecemeal laminectomy, as we do in lumbar spine, should not be done in the dorsal and cervical spine, because there is a very high rate of neurological deterioration if you adopt this technique. So in laminectomy also, you burr out gutters on both sides, and then you flip the entire posterior elements together. So if just rather than flipping it out completely, you just lift it on one side and put in a few plates. So hardly it's a matter of half an hour or 45 minutes, which makes a difference. For me, I usually prefer a laminoplasty rather than a laminectomy, but I have no objections to doing a laminectomy. I'm really not convinced that a 75-year-old gentleman with a laminectomy or a laminoplasty hardly makes a difference, because many of these CSM patients are quite elderly and frail patients. And it hardly matters whether you do a laminectomy or laminoplasty. It depends on your surgical training and your comfort. For me, it is more of a laminoplasty, because my technique of doing a laminectomy is the same as laminoplasty. In one, I will take out make both the gutters bicortical and take out the entire posterior element together in one piece. And in the other, I would not take it out, but just lift it out on one side. So for me, it hardly makes a difference.
Sorry, so my question was like, is there some age beyond which you would not want to fuse? Like you just do a laminectomy and leave?
So for me, fusion is basically limited to that subgroup of patients who have documented instability, or on their neutral views, on the neutral lateral extra cervical spine, I do find a little bit of 10 degrees of kyphosis, or some straight spine in which the extension view shows me a good lordosis is developing. For these patients, I would rely on laminectomy fusion to maintain the lordosis. But in other patients who have a lordotic spine and who do not have any evidence of instability on flexion extension views, there is no mobile subluxation, then I'd do laminoplasty.
Thank you very much, Dr. Basu. Just to add on to what you have just said, in our institute, if it's an old gentleman like 60 plus, and if we are doing a laminectomy of limited vertebrae, then we just do a laminectomy and do not fuse or laminoplasty. And certainly if it's a younger population and if you are doing a longer segment of decompression, then certainly one of the procedure that you have elegantly described, especially looking at the neck pain and the lordosis, this could be a very, very good information. Thank you. What do you say about, let's say— I
can't hear you. Can you be a little bit louder, please? I couldn't hear you. Can you be a little bit louder, please?
If the patient has got, let's say, 3-level, 4-level laminectomy, and the patient is 60 plus, do you still go for laminoplasty or fixation?
So a patient who does not have instability or who does not have a kyphosis or it's not a straight spine, I would definitely not do a laminectomy fusion. That is a much more larger and it's much more bloody surgery. The operative time is more, the blood loss is more. So I would definitely restrict myself without a fusion. Now, without a fusion means either it's a laminectomy or a laminoplasty. In my training, in my career, I have hardly done a laminectomy just because I am much more comfortable with a laminoplasty. But I have no objections to doing or observing somebody else doing a laminoplasty. As I said, I really don't believe that this elderly population would deteriorate in the near future if you do laminectomy. Lordotic spine, you do a laminectomy and come out, that's fine. I mean, it's an equally good treatment modality.
Thank you very much. Thank you.
Our next speaker is Dr. Binod Patrai from Chitwan, and his topic is adjacent segment disease. Can we prevent it? Unfortunately, Dr. Vinod is not here. Now we move to another paper. Dr. Arvind Kulkarni from India. He will be presenting on artificial disc. Do you have a perfect implant? Please start.
Dear friends and colleagues, it is a matter of great pleasure for me to deliver this talk. First and foremost, I would like to thank the organizing committee for inviting me to deliver this particular talk on a very controversial and interesting topic. So let's go back to the basics. What are the functions of the intervertebral disc, the natural disc? One is mobility, second is load bearing, third is the power of viscoelasticity, which is basically shock absorption, and of course maintenance of foraminal height. Now, what are our expectations from the artificial disc, which replaces the natural disc? In the lumbar spine, the indication is discogenic low back pain, so that should go away, that should disappear. In the cervical spine, it is an alternative to the fusion device, so it should provide anterior column support. Most importantly, the third, that it should move, unlike the fusion device. And most controversial of all three is, to prevent adjacent segment degeneration. I wouldn't say controversial. I would say that was the objective of, that was the trigger behind innovating an artificial disc. So does this prevent minimal, adjacent segment degeneration? So if you go through the studies, there is yes for the first three expectations, but with regards to adjacent segment degeneration, it is still a bit doubtful, still a bit skeptical, still a bit cynical, because most of the papers that claim in minimizing AST with artificial discs, they are generally either biased or are market driven. Now, there is good evidence that you get symptom relief with both the lumbar disc as well as the cervical disc. So there is also good evidence that both the lumbar as well as the cervical discs move. There is also good evidence that both the discs, cervical as well as the lumbar artificial discs, they allow load transmission. Now, one thing I want to point out here is the significance of osteoporosis when it comes to load bearing. So even a soft disc, the natural disc, can sink into the osteoporotic end plates and osteoporotic vertebrae. So this is famously called the codfish vertebra sign, where the disc is biconvex and the vertebra becomes biconcave. So if this can happen with a natural soft disc, it can easily happen with the discs which have metal end plate. So, and the age group in which artificial disc replacement is done is the same age group which is vulnerable to osteoporosis. So it's very important that the osteoporosis part is taken care of before a disc replacement is done. So if there is subsidence as a result of osteoporosis, you blame the surgeon for not treating the osteoporosis and don't blame the device. So the next common reason for subsidence is a mismatch between the disc, between the footprint of the artificial disc and the morphometry of the patient. This we have highlighted in this paper, which was published in the Asian Spine Journal. It won quite a few accolades. So we are the first one to point out that there is a significant mismatch between what is available and what is required. So this needs consideration while devising a device. Now, with regards to viscoelasticity, this is the most important part of a natural disc. So the ability for the disc to deform under load is something which is unique to intervertebral discs. So this is not mimicked by any of the first generation disc replacements which are available. They follow the ball and socket design, which could be either metal on metal or metal on polymer, and basically mimic the hip, knee, and shoulder arthroplasty. However, spine biomechanics is not so simple. It's quite complicated. So here, probably Charlie is not the answer. We need someone who is an outlier, who thinks differently. I would call him a spine Charlie, who can devise a device which would replace our natural discs. So as I said, the disc movement is not that of a ball and socket variety. The disc movement is that of a deforming variety. So what do we mean by deforming? So it is a viscoelastic structure. So it is like rubber. So you can see here with this movement how there is forward and backward movement of the nucleus pulposus, how the anterior as well as posterior annulus as well as ALN and PLL restrain the movement of the nucleus pulposus, and how there is stiff resistance by the superior and inferior end plates. So when it comes to viscoelasticity, it's not that a man has not tried to generate or innovate an artificial disc which can mimic viscoelasticity. So Brian knows a cervical disc which promises viscoelasticity. It is made of polyurethane core with a hollow core. It is lined by polyurethane, and this particular disc did take axial load. However, it went into disfavor because of complications such as segmental kyphosis and heterotopic ossification. So the newer generation discs, which are currently undergoing testing and currently in the laboratory, are mimicking viscoelasticity. But however, in a few clinical studies, these particular discs have been used, but we don't have long-term outcome. Same is the issue with lumbar viscoelasticity. So Acroflex was a design devised by Robert Fraser from Australia with the mindset that this should mimic the viscoelasticity that was natural to a natural disc. So here the core is made up of a silicon elastomer which has axial mobility. Again, this fell into disfavor because of a high failure rate secondary to debris and tears. Again, so the problem with artificial disc is, one is that it's not able to mimic viscoelasticity. Second is the indications. Why do you think we have so much of research, so much of prosperity, so many journals, so many research articles, so much activity around knee replacement and hip replacement? It's basically because of the sheer volume. So the more the merrier in all terms, in all directions, whether it is research, prosperity, growth, academics, etc. When it comes to lumbar disc replacement, there is one sole indication, that is discogenic low back pain. This happens to be one of the least priorities for a busy spine surgeon who generally deals with stenosis, disc herniations, myelopathies, deformities, trauma. So there is a lot of impatience to treat a discogenic low back pain with a solution. So thing is, necessity is the mother of invention. If there is a burning desire, if there is a grave need for an artificial disc, it will definitely researched and innovated. See, look at these papers. The prevalence of contraindications to total disc replacement in a cohort of lumbar surgical patients, only 5% had no contraindications. So 95% of patients who attended the clinic in that particular year when this research was done had contraindications for disc replacement. So this is another study by Auerbach et al. Which shows that the prevalence of total lumbar disc replacement candidates in a community-based spine surgery practice is just 5%. So as I was arguing earlier, so we deal with so many other spinal diagnosis in a practice that discogenic low back pain takes up. Again, the approach is a bit out of the way for a routine surgery. So it is an anterior retroperitoneal approach. It's not a familiar approach. You need to take the help of an access surgeon, especially if there has been scarring secondary to previous abdominal or pelvic surgery. This could be a challenge. So the added cost of inviting a vascular colleague would mean quite a bit for a indication such as dyspogenic low back pain. Again, there have been attempts to put an artificial disc from posterior approaches, posterolateral approaches. I mean, this has failed miserably in the year of inception. So a dream approach would be a minimal access approach. Again, we need to consider the facet joints. So in the seesaw movement of the spine, facet joints take half the significance. So they are like vigilance commissioners. So they check rotations, they check extreme motions. Studies have shown that whenever you put this insert this ball and socket designed disc replacements, there is increased loading on the facet joint, leading to premature facet arthritis. Thus, the entire purpose of treating back pain would be a waste. Now, the newer generation discs, which are called one-piece articulations with with the property of viscoelasticity, have shown some promise of not stress on the facet joints. So, an ideal lumbar disc ideal lumbar artificial disc replacement device should avoid debris. So, ball and socket model needs to be abandoned. It should minimize subsidence. Should have adequate. It should mimic deforming properties of the natural disc, which we discussed a few slides before. It should be a one-piece disc with viscoelastic power. So thus such a model can be seen in this M6L. It's still not FDA approved. Similarly, artificial cervical disc should avoid debris. Again, we should give up a ball and socket design here. It should again minimize subsidence. That is, it should be available in a wide footprint, and again, it should have viscoelastic power. And again, M6C is such a disc which is again there in the market, there in circulation in some countries, not available yet in India, and this is FDA approved. So these two discs, M6L and M6C, have shown some promise. As you see here, there has been a rising interest in this one-piece viscoelastic discs. The earlier ones were all, fixed COR discs, which came in two or three pieces. The current ones are all which are in Boga or which are in the laboratory are all one-piece devices with viscoelastic power. Again, this is a complication that happened with the M6C. So no artificial disc is immune to complications. So we need to take each of these devices with a pinch of. So do we really need one, especially in the lumbar spine, in view of the limited indication that we have? Research should be in the direction of designing implants customized for common conditions that we treat, that is stenosis, disc herniations, deformities, etc. We should abandon the ball and socket design and devise an implant with wide footprint, with viscoelasticity, and high durability. Thank you.
Thank you, Dr. Kulkarni. Again, a very new topic, and with very less indication for replacement of disc in the lumbar spine. Probably it'll be years before we have good evidence on its use. Like, do we have any questions from the floor? Sorry. Okay. Thank you, Dr. Kulkarni. He's not live, but it was a very interesting presentation. Moving on to the next presenter, I'd like to invite Dr. Acharya, Dr. Sankar Acharya.
Yeah, I'm there. Good morning.
He's presenting on, does a dynamic top up in lumbar fusion prevent adjacent level degeneration? And he's speaking with his Gangaram experience. Dr. Acharya, sir.
Yeah, next patient, Vanda Chaparappa.
Good morning, everyone from India. I, Dr. Shankaracharya, on behalf of the Association of Spine Surgeons of India, welcome all who are listening to this 2-hour symposium on motion preservation in spine surgery. And I thank the Association of Neurosurgeons of Nepal and Dr. Amit Thapa to have invited us all lively session. We would have all liked to be there in person, but due to the COVID restrictions, we are doing this on a virtual mode. My talk today is, does a dynamic top-up in lumbar spine fusion prevent adjacent segment degeneration? And I will talk about a very small experience we have in Gangaram Hospital. Let's start with a case. So this is a 68-year-old female with degenerative scoliosis, something which we commonly see every day in our clinics, with back pain and leg pain and comorbidity of diabetes, hypertension, hypothyroid, and osteoporosis. These types of cases we see every day, and this is the MRI findings. You can see that she has an L5-S1 degenerated facet joint, but the disc is more or less all right. She has a L4-5 disc degeneration with right side of annular bulge with foraminal stenosis, and she has a fairly degenerate disc, but facets are okay. And the dilemma always remains as to what should be done after conservative options are all exhausted. Should we decompress only? Should we do a fusion? If we do a fusion, should it be just an L4-5, or should it be L4-5, L3-4? Or correct the whole deformity, because she has flat back, she has degenerative scoliosis, and there's bound to be failure if you don't get the normal sagittal balance and correct the scoliosis. So these things always come to our mind, and we are always in a dilemma, and we discuss with the patients, and it's always up to the surgeon to take a calculated risk and go ahead with surgery, not knowing as to exact long-term outcome. So this is what we did. I did a L4-5 fusion with an L3-4 posterolateral fusion. And I always worry about adjacent segment degeneration and other problems that can occur with such a fusion. And this is a 2-year follow-up. As you can see, I didn't correct the whole scoliosis. And in 6 years, as you can see, that patient has already got an adjacent segment degeneration because of some imbalance and pre-existing scoliosis. And the patient is now again symptomatic with some degree of back pain, but we continue to treat them conservatively. So these things we always face, and we always think, could we have done better? Adjacent segment degeneration is a known entity, and the incidence varies from as low as 5% to 77%, but more or less in a meta-analysis with a pooled prevalence of about 25%. So it is going to happen. It's a known thing, especially if you have a fusion and you're going to get an adjacent segment degeneration. Whether it's a natural history of the patient or it has been accelerated because of fusion, the jury is still out. We still don't know. So is there a predisposed level? And if there is, so what predisposes adjacent segment degeneration? Is it a degenerate disc, or is it a facet asymmetry or sagittally oriented facets? There has to be something which precipitates some patients to have an adjacent segment degeneration earlier than others. So there are varying rates of degeneration, and no one is really clear. If you look at literature, you can find evidence for both. While the top Park and et al. And Etibar et al. Have said that adjacent segment degeneration is more likely to occur when adjacent segment has already signs of previous degeneration. There is another study by Throckmorton which says clinical outcomes were actually worse among patients with normal adjacent disc. So no one is really clear as to what precipitates an adjacent segment degeneration. degeneration. And just an evidence radiologically of adjacent segment degeneration does not mean we should go ahead and fuse this. Are there risk factors? Yes, I think there are risk factors. And we look at these very carefully. If the patient is elderly, there is some genetic predisposition. If the patient has insufficient lumbar lordosis or a flat back, high BMI, if you fused post-operatively, you find a high distraction level at the fusion level. And if you do multiple fusions, these are generally tend to be risk factors for an early adjacent segment degeneration. So what should you do? Can you solve the problem? Shall you fuse the adjacent level as well because you think that is going to degenerate, even if it is asymptomatic? Or should you do something else? There are some top-of devices, which is basically essentially soft fusion, which can be used in such situations. And they can be dynamic, both flexion extension, or they can be an extension blocker like the Coflex, the Diam, and the X-Stop. If you look at literature, definitely fusion causes more adjacent segment degeneration. And in dynamic fusion, there are not enough long-term studies to actually quantify what happens. But there's a variety of studies which shows from 0 to 25%. There could be adjacent segment degeneration or adjacent segment degeneration the level above the top of level. That is also there. So meta-analysis shows that lumbar fusion may result in a higher prevalence of adjacent segment degeneration than motion preserving procedures. So maybe there is a small evidence, but not class 1 evidence to suggest that motion preserving procedures could be done where you are sure that you could have a adjacent segment degeneration. And it's still unclear. And also it's very unclear if radiological changes clinically are significant so as to require surgery. So sometimes it's a puzzle. And this paper looked into adjacent segment degenerative disease. Is it due to disease progression or fusion associated phenomena? And that has not been resolved. And it's very difficult to resolve such things. So we are always in a dilemma, whether we do posterolateral fusion, we do a TLIF procedure, where we do a top of like a transition or a Coflex. So there are different types of interspinous devices or a top of devices. And that dilemma still exists. And I don't think a small study can quantify that or tell us more about it. There are various interspinous devices available, and that has already been covered by Dr. Chahal. And we still, as I said, there is so much literature available about dynamic fusion, whether it's the final option, that the jury is still out, and we are not sure as to what is the correct thing to do in these cases. But there is a predisposed population, and very carefully you can have a select group of patients for dynamic top-up. And of these soft fusions, I think the pedicle rod screw construct-based stabilization device is still the best because it preserves motion with uniform effect through the range of motion. There is load sharing uniformly through the range of motion. It's safe and easy, and you can convert it to fusion in case of failure. And there is not much difference in the technique, and it's a top-loading device. It probably prevents some adjacent segment degeneration because it creates a soft construct from a rigid construct and helps in more cushioning, and the facet degeneration is less. And it can actually also be used as a standalone device for fusion because there is some micro movements across end place. We are not looking into that, but I have also done this procedure for where we have done a pars fracture repair, then we have used such procedures. And it can be used to stabilize posterior destabilizing surgery, especially if there's a laminectomy or facetectomy, and you are worried about whether they will go into listhesis. So this can also be used in such situations. However, our study today is aimed only at looking at those patients where we have done a top-up procedure, mainly for degenerative disc disease or listhesis. And we have used two plans. One is the transition, and the other one is the Coflex. Coflex is an extension stopper, and transition is a soft fusion device. And this is a retrospective study with a 2-year follow-up. We have 29 cases. So basically, degenerative cases are the most common indications for this surgery, and degenerative discs, facet arthropathy, and facet asymmetry of the adjacent segment make us think that this top of
The time
device,
is telling me the
the
nonsense.
calmness level is L4-5, and so the top of is
Fusion
usually
first one
done at L4-5 or L5S1 as L4-5 or L3-4 as required. So you can see that L3-4 is the calmness level of the transition rod. Obviously, these are fusion procedures for back and leg pain, and so the patient outcome has been significantly good. So in spite of doing a top-up device, there has been no adverse effect as such, but we have also a share of complications. And there have been 2 intradural tears, one case had a cage loosening, there was a tilting of a cage, but these are not related to the top-up device. The most important complication is that in spite of using this device, there was an 18%, 3 cases developed adjacent segment degeneration, and even at the level above. So that is still something of cause of concern. Let's look at some good cases. This is a patient with an L4-5 facet arthropathy. You can see the flexion extension, and you can see the facet arthropathy. And I also thought that L3-4, the facets were getting degenerate and likely to go into an adjacent segment degeneration or become symptomatic earlier. And so we have a 2-year follow-up where the patient has done well and there has been no further degeneration. Neither has there been a degeneration at a level higher up, but that may be too early. This is another patient with 65 years old with degenerative dialysis. This is L4-5 with neurogenic claudication. And we done a 2-level, 1-level TLIP with 2-level fusion and 1-level top-up. The complications, if you look at this case, this is a 73-year-old female who had an earlier surgery, and this was a revision surgery. And we have done a L4-5 fusion with the L3-4 top-up with the transition, but the patient developed adjacent segment degeneration at the level above the transition, so that and the level above. So this doesn't stop necessarily adjacent segment degeneration, as you can see in this 5-year follow-up, that all the 3 levels, even the transition level, has developed degeneration. Sometimes we have used Coflex, which is an extensor stopper at the level proximal to the fusion, but gradually we have come off it, and mostly we use in our earlier cases, we had used this. Mostly now we use the transition. So if you look at our result, we still have an 18% incidence of an adjacent segment degeneration, whether it's at that level or the level above. However, as I said earlier, degen scoli or degen lumbar spine fusion have 70-75% better results, and still there were some patients who were worse off and unchanged or were not happy. So in conclusion, I can say in our study, the use of transition rod showed good clinical outcome and decreased chances of developing adjacent segment degeneration. But this is very small to draw any statistical significance. Adjacent segment is known to be a complication of fusion procedures. The role of top-up as a dynamic fixation still needs to be evaluated well with a long-term follow-up. And I hope to someday have a larger follow-up where I can be sure that this helps or doesn't help. There are a few things to ponder out, however. In a total of 8 years, we have done only 29 cases of transition or adjacent segment soft fusion. And normally we do an average fusion of about 100 to 150 cases a year. So it's only 3% who have undergone the soft fusion above a fusion level. And if you can see these 2 cases, in one, there is an adjacent segment. The first case, the post of 21 months already shows an adjacent segment degeneration. Well, the one at 48 months doesn't show any degeneration. And if you look at the MRIs to compare, you can see the first case has a degenerated disc with some facet asymmetry. Well, the next case shows a pure L4-5 disease with no facet asymmetry or disc degeneration. So these are very clear-cut cases where you don't have to worry. However, in the first case, you may have to think, or you may add a top-up if you feel that this may go into the early degeneration, which may become symptomatic. It's important to look for radiological features operatively to preoperatively to look for any features of disc and facet changes to predict the progression of adjacent segment degeneration. Motion preserving procedures like transition may have some good clinical outcome with decreased chances of developing adjacent segment degeneration in select cases, but there is no class 1 evidence about it. So the answer is still not known. When to use a dynamic fusion? Is it the solution? Are all adjacent segment degeneration clinically significant to be addressed surgically? Thank you very much. And I thank everyone for having invited us again. And I'm happy to answer any questions.
Thank you very much, Dr. Acharya, for your nice presentation, especially about top-on technique. Is there any question from the audience? Yes, Dr. Neelam.
Thank you very much, Dr. Shankar Acharya. Do you hear me?
Yeah, I can hear you.
Yeah, I was very grateful 2 years ago that you invited me to your spine conference in Gangaram, if you remember me.
Yes, thank you very much. I think we have a strong association with all the Nepal orthopedic and spine surgeons.
Yeah, and I had a good time there. My question is, I didn't know that what is the difference between this transition rod and the top of instrument or top of device.
The transition rod is a soft rod in the sense it has got a polypropylene tube inside which there is a braided polyester cable. So there is some motion. That cable is inside and the tube is outside, and that also prevents some extension stoppage. So while it shares the load, so it's a load sharing device in an early degenerative disc. While a pure top of device is, both are top of device, the other one, the Coflex, is an interspinous spacer device. So the diam, the Coflex, the one stop, the O stop. So these were all developed as an extension device, but they stand between the spinous process and the lamina. So there is a tendency to erode and cause fibrosis. While this pedicle based soft fusion, which is the transition, or like the Dynasis, which was available earlier, they are pedicle based, so they do not cause, they do not rest on the spinous process, and then can be easily changed to a proper titanium rod in case you need to do so at a later stage. So over the years, after using most, I used a diam, I used Coflex, I used one stop. After using all this, I have realized that if at all one has to worry about adjacent segment degeneration and then discuss with the patient, and he wants everything to be done at one go, then it is worthwhile using a transition system to top up the adjacent segment.
Thank you very much. I have got some comment, about fusion on lumbar spine. Most of the cases in our institute, we do about 400 to 500 lumbar disc surgery a year. And hardly 5% of our patient need any kind of fusion device. And we generally do not do fusion because if you fuse, then there is always a chance of, as Professor Acharya has mentioned, adjacent disc problem. And if you fuse, you take off the motion also. So if you leave it just like that, then the motion is still preserved and the adjacent disc problem is less. So the best is if we can have some kind of artificial disc or the rod, the flexible rod Professor has just mentioned, that will be the best. But most of the cases we do not do fusion unless the patient have a severe back pain or spondylolisthesis. In these selected cases, only we fuse. If you have
I agree with you wholly. So our indications of fusions are also the same, where there is instability or significant back pain. Then you would fuse, or if you have to do significant decompression where you could destabilize. Otherwise, decompression still remains the gold standard where there is stenosis or in a discectomy. So you don't have to fuse. I agree.
Thank you, Professor. Let's move on to the next topic. I'd want to invite
Thank you very much.
Dr. Ajoy Sethi, and he's presenting on retrolisthesis, the etiopathogenesis. Does it signify instability? Dr. Ajoy Sethi.
Hi, I'm there, but I already sent the recording. Can it be played? Or shall I go live? Good morning. At the outset, my sincere thanks for the organizers for giving me this opportunity. I will be speaking on retrolisthesis. Does this signify instability? Before we go into the topic of retrolisthesis, I would like to speak and to make some understanding on spinal stability and instability. We do know that the spinal stability is the ability of the spine under physiological loads to maintain or to prevent not to have any displacement, whereas the spinal instability is excessive displacement of the spine under physiological loads that would result in neurological deficit, deformity, and pain. Of the various causes of instability, the most important one is the degenerative instability. And if you look at degenerative instability, it comes in the stage 2 or the unstable phase of the Kirkcaldy-Willis stages of disc degenerations. And in the stages of disc degeneration, it basically starts with the degeneration of the disc, leading on to end plate changes, degeneration of the facet joints, which can lead to antrolisthesis or a retrolisthesis, or sometimes even a rotational listhesis. And as we all were aware, the majority of these problems happen in the middle decade of life, between the 4th to 7th decade. We can diagnose instability by various clinical tests in the form of early morning dysfunctions, difficulty in getting up from the bed, instability catch. Whereas radiological is much more important, what we see in the static and the dynamic radiographs. Radiological instability of the two common types, the antrolisthesis is the most commonest one. We have the angular, translational, and the vertical instability. We do know that when you take a dynamic radiographs, the displacement could be angular, the displacement could be translational, and in the presence of a complete vacuum sign, it could be vertical. That means when you take a flexion extension radiographs, you see the vacuum sign in extension and complete absence in flexion. And when you look at the White and Punjabi definition, we are looking at an angular change, which goes from 15 to 25 degrees at L5S1, and a translational, which is greater than 4.5 millimeters of mercury. What about retrolisthesis? Is it an instability? As the word implies, retrolisthesis is a backward slippage of one vertebral body over the other. Historically, it was thought it is an incidental finding, later of no consequences. But currently, we do understand that retrolisthesis is associated with back pain and impaired back function. The symptoms can happen because of a nerve root compression, because of narrowing of the lateral recess and neuroforamina, or the facetal arthropathy, which can contribute to low back pain, or because of an instability, it can also cause low back pain. When do you call it as retrolisthesis? When the posterior displacement is greater than 3 millimeters. Uguchi et al. Noticed that of 3259 patients with low back pain, 2.6% had degenerative retrolisthesis. Gian et al. Noticed that there was an equal percentage of the patient with antro and retrolisthesis. Of importance is 30% of the extension radiographs of patients with low back pain had retrolisthesis. Therefore, it's much more commoner than what we think it is. And when the topic was given, when I started reading on it and analyzing it and seeing the patients in outpatient, I also realized that the incidence is much more. We get retrolisthesis in the lumbar spine in 3 scenarios. It could be associated with L5S1 disc collapse. It could be a degenerative retrolisthesis, which you usually see at the upper level or above the level of instrumentation. But whatever it is, it has been associated with increased back pain and impaired back function. What about L5S1? To understand the importance of L5S1 retrolisthesis, these 3 reports are very essential. These are basically an offshoot of the SPORT trial. They looked at retrolisthesis and lumbar disc herniation and to see whether it was associated with increased incidence of disc degeneration, facetal changes, or whatever the end plane changes? No. Did it affect the presentation of patients with L5 disc prolapse? No. The presentation was affected only by the presence of the disc, not because of retrolisthesis. And what about the post-operative outcome? They analyzed it 4 years. The patient with retrolisthesis had more back pain, but no higher incidence of recurrence. Does that mean that these patient groups needed fusion? However, when they looked at the same group at 8 years, there is no difference in outcome. Therefore, retrolisthesis does not affect the outcome preoperatively, does affect the outcome at 4 years. However, at 8 years, they restabilize. What does it mean? That after discectomy, there is a nerve root endings that grow into the disc to cause pain, and that is worsened by associated hypermobility. But after 8 years, it continued micromotion and hypermobility leads to increased spondylolytic changes, decreases the motion and decreases the pain. But however, when you are doing a lumbar decompression alone, removing the midline in a patient with retrolisthesis, you have to be careful. The studies have shown that discectomy can happen, disc prolapse can happen if the midline is not preserved. If not, you have to fuse them. And retrolisthesis in adjacent segment, you do know that because of altered motion, there is an increased motion in the adjacent segment, can cause either antro or retrolisthesis. It's an attempt to maintain a global balance. It depends upon the pelvic incidence. These are various case examples of retrolisthesis following the level of the fusion. Coming to the third important thing, the degenerative retrolisthesis. It's basically an attempt by the body to maintain a sagittal balance. It could be single or multiple level, most commonly seen at the upper levels. There are two types. Patients with low pelvic incidence who develop retrolisthesis. Patients with high pelvic incidence who develop an antrolisthesis. Above that level, you can get retrolisthesis and an effort to compensate that. As you know, the sagittal balance is very important. However, whenever there is a loss of sagittal balance, there are multiple compensatory mechanisms that comes into play. Ankle extension, knee flexion, pelvic retroversion, intervertebral hyperextension. But we have to understand and remember that retrolisthesis is also a compensatory mechanism. Therefore, you have the type 8 variant, wherein all the lumbar parameters are very low. The average degeneration of the firmness grading is significantly lesser. And then what happens is that because the pelvic incidence is low, the pelvic retroversion becomes lesser. And therefore, to cause the balance, to compensate, the retrolisthesis do happens. And that's very, very important to understand. Therefore, the management varies depending on the stenosis. If there is a stenosis, you can decompress, but be careful that you maintain the midline. Okay, one of the best ways you do over the top decompression. That prevents further instability, that prevents a disc prolapse. Whereas type B is an attempt to compensate for a retrolisthesis above the level of a degenerative antrolisthesis. And that's what we see most commonly. The only important significance of this is if you are operating, the question comes whether to include the upper level of retrolisthesis into the fusion mass. Unfortunately, there is no clear answer yet. The factors to be considered are instability on radiographs and stenosis. The stenosis is not much. You treat only the listhesis level. To conclude, retrolisthesis is a degenerative process seen during the stage 2 of cryptadivalis. Retrolisthesis at L5S1 is associated with disc prolapse, will not need fusion. Associated with adjacent segment degeneration should be treated based on the symptomatology. But degenerative retrolisthesis is an attempt to maintain the sagittal balance and do not present true instability. The presence of it makes it difficult for us sometimes to address or to plan the fusion levels. But if there is associated stenosis, significant instability in flexion extension radiographs, you may have to do that. Thank you very much for the patient hearing.
It was quite nice presentation. So my question is, hello?
I'm online.
Can you hear me? Yeah.
Yes, I can hear you. Thank you.
So even in some degenerative spondylolisthesis, patient may not have severe back pain, but when we do X-ray, we can see some degree of listhesis. So even the patient does not have any symptom, but the X-ray looks horrible. In such cases, how do you answer the patient? Which procedure do you like to go? Fusion or only decompression?
Okay. The management of degenerative spondylolisthesis depends upon whether the patient has got neurogenic claudication or not. If the listhesis is less than grade 1, a grade 0 to 1, that means a very minimal, no significant back pain. If you are able to maintain the midline and there is no facetal effusion or a vertical facet, you can get away by only doing the decompression, provided you maintain the midline, probably doing a tubular or over the top decompression. That means you maintain the midline structures, the interspinous and supraspinous ligaments. In the presence of pain, actually Dr. Arvind has got a paper on that. In the presence of pain, significant back pain or the facetal effusion, or if there is a vertical orientation of the facet joint where you decompress, there is chance that you will cause a potential instability, then definitely fusion needs to be considered. I hope I answered your question.
Thank you, sir. So, any questions from audience? Now, we'll move to another
Thank you.
talk. I would like to welcome Dr. Gautam Zaveri. He'll be talking on recurrent lumbar disc prolapse, whether to do discectomy only or we need fusion. Dr. Gautam Zaveri, please.
Good morning. At the outset, let me thank the organizers of INSPINE and the Association of Spinal Surgeons of India for inviting me here today to share my management strategies in recurrent lumbar disc herniation. Let's start with this scenario. A 37-year-old lady, no medical comorbidities. She had undergone a left microlumbar fenestration discectomy about 7 months ago. She was completely relieved of the leg symptoms thereafter, did have occasional intermittent back pain. About 2 days before she presented to us, she lifted her child who weighed about 9 to 10 kgs and suddenly developed severe recurrent back and left leg pain and was associated with pain, paresthesia, numbness. When she came over to the hospital on examination, there was tenderness and spasm in the lower lumbar spine. Movements were severely restricted. The SLR was positive, so was the crossed SLR. The power, however, was normal, but sensations were reduced over the left L5 dermatome. The surgical scar had healed with a primary intention. There was no evidence of any infection or inflammation in this area. So we are dealing with a patient who came to us with a recurrent leg pain following a lumbar discectomy. The differential diagnosis here is the first of which and the most common of which is a recurrent lumbar disc prolapse. But there are other causes which need to be ruled out, which include epidural scarring, facetal synovitis, facial joint arthritis, lateral canal stenosis, instability, infection, and arachnoiditis. What is recurrent lumbar disc herniation? The prolapse of an intervertebral disc at the same level as a previous discectomy, either on the same side or on the opposite side, is called as a recurrent lumbar disc herniation. The time interval mentioned in the definition is controversial. Some suggest that the time interval should be a minimum of 6 months, and if symptoms recur before that, then it should be called as a residual disc prolapse or an incomplete surgery in the first occasion. And others maintain that if you have had a fairly good pain-free interval and then the patient's symptoms recur, then it is still a recurrent lumbar disc herniation, even if the time interval is less than 6 months. The incidence of recurrent disc prolapse is about 2 to 20% in literature. In fact, half of all reherniations appear within the first 1 year after the index surgery, and after 8 years of the index surgery, recurrent herniations are not found to be very common. The typical clinical presentation is intense radicular leg pain. I have always found that patients who have had a recurrence are usually having much more intense leg pain than following during the primary lumbar discectomy, probably because there is scar tissue, less stretchability, less flexibility of the dural sac, and therefore even a small disc prolapse can result in major symptoms. Patients usually also have back pain, and again neurologic deficits for the same reason are more common than with the primary lumbar disc herniation. The diagnosis, of course, rests on an MRI scan. An MRI scan, T1 and T2 weighted images, and usually if it is within the first 3-4 months after a surgery, you would do a gadolinium enhanced MRI contrast. The MRI scan not only helps you to identify the disc prolapse, location, morphology of the disc, etc., but it rules out other causes of recurrent leg pain, and the contrast MRI helps you to differentiate this from an epidural scar. If you see the image on the right, which is a post-contrast enhanced T1 image, you can see that behind the disc, which is a small black dot, the white streak horizontal is an epidural scar which lights up when the contrast is given. But when you consider MRI, you must also consider the limitations of a post-discectomy MRI and the difficulty in interpreting such an MRI. In the post-operative phase, usually the annular deformation looks much worse than before. It is often because you have cut the annulus, it looks deformed, it is thickened, it is hardened or calcified or ossified, there is edema, there is hemorrhage, and this may stay even up to about 12 weeks. A high-intensity band may be seen within the intervertebral disc, which extends from the nucleus to the site of the annular disruption, and this stays for 2 months and can be misinterpreted as an infection. A nerve root enhancement on a neurography may persist for even up to 6 months following a discectomy. The other thing you must remember is there are a lot of things on MRI which can be picked up which may not necessarily be clinically relevant. Liblo showed that 25% of patients who underwent a lumbar discectomy had, on follow-up 2 years later, had what looked like a radiographic recurrence, but less than 50% of these patients were symptomatic. The next test I like to do in these patients is always X-rays. The AP and lateral views tell you about the amount of bone resection that you have done in the previous surgery, but the dynamic views, that is the flexion extension views, help to reveal subtle instability, which if it is not fixed, may result in problems further. Sometimes a CT scan is done. Usually I do CT scans when the patient has associated severe chronic back pain. Why? To look at the status of the facet joints, to look at if there is any pars fracture which is causing instability and pain, and also because it helps me to judge the amount of bone resection during the previous decompression procedure and decide whether I will be able to decompress without or do the discectomy without destabilizing the spine any further. The treatment options, like in a primary disc prolapse, are non-operative, epidural steroid injections, and surgery. There is no definitive evidence about non-operative treatment for recurrent lumbar disc herniation in literature. However, in general, in my experience and whatever literature is available, non-operative treatment results are poorer than with primary lumbar disc herniation. About 50% of patients do respond to non-operative treatment. Epidural steroid injections are very helpful in relieving pain in these patients. Manikanti showed that 65% of his patients with recurrent lumbar disc herniation had significant relief in low back or leg pain. You can give the injection either through a transforaminal route or through a caudal epidural route. I prefer the transforaminal route because it seems to yield better success. However, you must remember that in the revision situation, when an epidural injection is given, the risk of dural puncture is significantly higher. When should you do surgery? So the indications are the same as in a primary lumbar disc herniation. That is, pain not responding to conservative measures or the presence of a significant neurologic deficit. And the treatment options, of course, there are some other newer options, But the traditional options, which most of us follow today too, are either doing a repeat discectomy or performing a discectomy with fusion. These can be done through various visual aids and procedures. You could do it open, you could do it microsurgically, you could do a minimally invasive surgery using tubular retractors, or you can do an endoscopic surgery to relieve the disc prolapse. So, what is the logic behind doing a repeat discectomy? It's a smaller procedure with less blood loss, less operative time, less complications, less post-op pain, allows faster rehabilitation, and requires a shorter in-hospital stay. Besides, the lumbar segmental motion is maintained, and that is a crucial element to a repeat discectomy. Of course, what are the disadvantages? A number of surgeons believe that a second disc prolapse is a feature of instability of the motion segment, and therefore there is a significantly higher chance of a second recurrence if this instability is not addressed. There is a higher risk of low back pain if there is instability, and because surgery involves more bone removal to get to the disc, it may result in iatrogenic instability. The second surgery that we do is a discectomy plus fusion. What is the logic behind doing a fusion procedure? It eliminates the risk for further recurrence. It potentially reduces back pain by immobilizing motion segments. The disadvantages, of course, as mentioned earlier, is longer operative times, blood loss, more post-op pain, potentially more complications during the surgery. Rehabilitation is slower and requires a longer hospital stay. Additionally, adjacent segment degeneration because you've made a rigid motion segment, pseudoarthrosis, and implant failure at the site of fusion. When you look at the results of a revision lumbar disc herniation surgery versus a primary lumbar disc herniation surgery, it was found that in the long term, at 4-year follow-up, the results were essentially very similar. Both patient groups tended to do very well in terms of their back pain, in terms of their leg pain, as well as in terms of their functional rehabilitation. However, patients who had a repeat discectomy did a little worse as far as residual sciatica is concerned compared to primary discectomy patients. When comparing repeat discectomy versus discectomy and fusion operations, at short-term follow-up, the clinical results as far as pain relief, back and leg pain, as well as functional relief, improvement was very similar. However, the fusion group obviously had longer operative times, hospital stay was more costly. There was, however, a slight trend towards a higher reoperation rate in the repeat microdiscectomy group. Who looked at the long-term results? At 7.5 years following a repeat discectomy or a discectomy and fusion for a recurrent lumbar disc herniation, and he found no significant difference in the back pain scores. He also suggested that, of course, the repeat discectomy had less operative time, less blood loss, and less hospital stay. In my book, majority of the patients with a recurrent lumbar disc herniation, especially if the disc herniation is at L5S1, especially if I have done the previous discectomy myself and know the amount of bone resection I have done, I stick to doing a microdiscectomy again. Indications for fusion are pre-existing instability or instability created during the revision discectomy, if there is a focal spinal deformity at that level, or if there is back pain, which is very, very predominant. Here is an example. A patient with a spinal stenosis and big disc prolapse at 4-5 underwent a micro decompression discectomy. A few years later presented with a recurrent disc. You can see the flexion extension views showing a subtle L4-5 instability, and at this stage underwent a fusion to obtain a good result. There are some other surgical options which have come into view in recent times. These are primarily indirect decompression procedures where one raises the disc height and thereby does not directly attack the disc prolapse, but by increasing the disc height, opens up the foraminal height and reduces the pressure on the nerve root. And this can be achieved by doing an anterior lumbar interbody fusion, a lateral lumbar body interbody fusion, or an artificial disc. However, there is very little literature available on this subject. To conclude, what is my strategy for recurrent lumbar disc herniations? I think the key for all of us to realize is that in patients with recurrent symptoms following a lumbar discectomy, there are many different causes. If you can identify a particular cause, like a recurrent lumbar disc herniation, definitively, and attack it, the outcomes of this procedure are very, very good. Non-operative treatment, however, is a valid treatment in these patients. 50% will respond to that. When I like to give epidural injections, I try to give a transforaminal epidural. If the patient has no evidence of instability, no localized deformity, then and no severe chronic back pain, we think of doing a repeat discectomy. If, however, the patient has instability, deformity, chronic back pain, or the repeat disc prolapse involves the higher lumbar segments, then we think of doing a discectomy plus fusion. Thank you very much.
Thank you. Thank you very much, Professor. I fully agree with whatever you have said. Recurrent disc patient have more severe pain. They come running to you, and you need to do whatever as early as possible. And I fully agree that, just simple repeat discectomy is enough. In our institute, we have 4% recurrence rate, and 2% are treated by steroids, as you have said, and 2% needs resurgery. My question to you is, you said that if the recurrent disc is on the opposite leg, it's also called same level but opposite leg. It's also called recurrent disc. And many of our patients, when they come to us with a severe one side, let's say right side leg pain, and they don't complain anything about left, we do the right side, radiologically evidence on right side, you operate, the patient goes home, but then starts saying that they have left leg pain. Many times we hear this, So how to deal with a problem like this? Do you have any idea?
So that's not an entirely uncommon scenario, as you just mentioned. Usually, I find that sometimes the patient has come with a purely right-sided leg pain. I've not seen that very commonly in a microdiscectomy, but I've seen that when you do over-the-top decompression of the opposite side, or because this patient already has stenosis on the opposite side, so you are tempted to do an over-the-top decompression along with discectomy on the same side. And that time you're handling the nerve root a little bit, that causes inflammation. The patient becomes very sensitive to that pain because he has never had leg pain on that side. So post-operatively, that inflammation seems to cause the pain. So if you've done a decompression of the opposite side during the discectomy procedure, for whatever reason, then it seems to cause. But usually when I do a microdiscectomy on the right, it is very rare, and without going on to the opposite side, it's very rare for my patients to have a left-sided complaint.
I've seen many cases like this in our practice.
So how do you handle it, sir?
We try not to operate. We try all simple conservative management. Most of the time they do okay. My thinking is that the patient had both leg pain, but then they don't feel the left side pain because the right side pain is so severe. So maybe now I am thinking, if we suspect a case like this where there is a disc, also lateral recess stenosis, then maybe block the nerve on one side before you go for surgery and see if there's a left-sided pain also. This is just my idea. We have not tried this, but this is what we have been discussing.
We have seen some patients, sir, where patient has a right-sided disc prolapse, but the symptoms are all on the left side. So that is always a source of worry, that if you tackle the right side disc prolapse, will the left leg pain symptoms go away?
No, if it is a big disc, then right side with left side, right side disc with left side leg pain. If you take out right side, if it's a big disc, then the pain will go away most of the time. That's what
So that's what the literature also says. That is also our experience. But what I also do in these patients is that I do use epidural steroids intraoperatively just to, make sure that she gets, because there is nothing on the opposite side, but you need to reduce the inflammatory component to it. And so we use epidural steroids.
Thank you very much.
Thank you, Dr. Zaveri. Now, moving on to the last presentation, as we're slightly behind time, I'd like to invite Dr. Samir Acharya. He is a dynamic neurosurgeon from Annapurna Neuro Hospital and with interest in spine surgery. I'd like to invite Dr. Samir to talk on unilateral laminotomy, bilateral decompression in lumbar spine. Does it preserve spine stability?
Hello. Good afternoon. This is the last topic of today's morning session. So as a neurosurgeon, lumbar disc surgery, lumbar back surgery is a daily work of the neurosurgeon and spine surgeon. And we call it a bread and butter for neurosurgeon and spine surgeon. I hope all of us agree with this. Can you play the slide, please? So today there are different techniques to deal with this lumbar surgery, but different people love to do differently. They have their own style. But I've been doing this surgery since last many years, and what I do is open discectomy. And I was given this topic, which I tried to do in few cases after this. I got this topic, and it was also quite satisfactory. That my topic is unilateral laminotomy for bilateral decompression in lumbar spine. And today's world, it's all going towards the maintaining the stability of the spine. So will this help in preserving the spinal stability? That is what the topic is. So I try to see the literature and try to see what is the reality and what I'm convinced with. Next. Okay. सुरु को लगाइदिनु सुरुबाट लगाइदिनु So the main aim of spine lumbar surgery is decompression of the neural canal and foramen and preserving most of the anatomy considering the biomechanics of the lumbar spine. So in conventional laminectomy, what we have been doing, there's wide destruction of the posterior ligament, posterior part of the spine, and they say some people think that the postoperative back pain due to destruction of posterior component and paravertebral muscle split may lead to need of fusion surgery in future. So less invasive surgery were also tried and were introduced as early as in 1987, explained by Young et al. So in this case, he tried to approach opposite side from the affected side and decompress the spinal canal as well as both spinal nerve root. So unilateral, bilateral decompression with microscope and endoscope is being practiced in many centers these days and is becoming the best option of many surgeons. So to know the basic concept of this, what is this topic is about? This is simply to understand is you go either with microscope or endoscope, you go explore the nerve root, you decompress the affected nerve root, and then you excise the flavum and undermine the spinous process, and you make a window so that you can approach and do hemilaminectomy of the opposite side and decompress the nerve root. This is what it's going from one side and decompressing another side. So what is the best option to reduce post-operative back pain and maintaining the stability of lumbar spine? Is open good, or open that we have been practicing is good, or MIS is good, or it's equally effective in terms of motion preservation? So there are many literatures which says that unilateral lumbar bilateral decompression is an effective as open decompression in improving the function, with the additional benefit of a significant greater decrease in pain, post-operative recovery time, and time of mobilization. Tissue handling, tissue destruction is less in case of unilateral bilateral decompression as compared to open. So there are other papers, many papers, which says unilateral bilateral decompression may be associated with less blood loss and shorter stay with similar complication profiles than open approach. So there are many papers which is for which is supporting unilateral bilateral decompression in the literature. So even in case of small degenerative spondylolisthesis, this was found to be more effective than decompressing the nerve root, opposite nerve root, and it prevents the fusion surgery. It's similar that unilateral bilateral decompression is good for in case of spondylolisthesis cases as well. So there are many papers, and this one is both endoscopic. This is done endoscopic and microscopic TLIF. Lumbar endoscope, unilateral bilateral decompression, and missed TLIF are safe and effective to treat one level lumbar spinal without degenerative spondylolisthesis or deformity. Lumbar endoscope is more minimally invasive option and less economic burden compared with missed TLIF. So decompression plus instrumentation fusion may not always be necessary for one level lumbar spine stenosis without degenerative spondylolisthesis or deformity. So there are many papers that has explained the effectiveness of the unilateral opening. These days, in the past, they used to perform with the operating microscope, but these days, with good quality of endoscope, this endoscope technique is being more popular. So in lumbar stenosis has the advantage of less trauma if we go by endoscope, a shortened operation time and rapid recovery, and is effective alternative for the treatment has been explained. So all of this suggests that and this is another topic, another paper which says endoscopic techniques and microscopic can provide favorable outcome for lumbar central canal stenosis. However, compared to microscopic unilateral bilateral decompression, endoscope has advantage in terms of post-operative segmental spinal instability, pain control, and serum CK and CRP level. So many of if you go to the literature, you find this as it's been explained as like this is the gold standard for these days. So yesterday also we had a workshop in KMC, and Professor Malcolm showed us a very nice endoscopic techniques from where we can approach from one foraminectomy, we can approach the another side as well. So, but in that case, for us who are doing many cases and open surgeries, there was lots of 5 or 6 exposures was performed during the procedure, and the patience of us was quite less because it took quite a little bit more time. So this is a microscopic view. You can see the opposite nerve has been decompressed. So there are some of the scan. This is post-op, pre-operative CT scan where the lamina is intact, and this is post-operative CT scan of bilateral decompression. So the advantage of this procedure surgical trauma is reduced and it's less invasive. So it reduces surgically induced instability. It spares the important system of the facet joint because only the hypertrophic and compressive medial part was dissected, has been explained, preserves the integrity of the contralateral support lumbar musculature as well as the midline structure, avoid the need of additional instrumentation to treat the local instability. However, it has got some limitation. So it's a step learning curve and it's lots of practice because what you see in the open surgery or microsurgery, microdiscectomy is quite different from what you see in endoscope. So small access and visualization. So in case of severe spinal stenosis in opposite side in elderly patient where there is hypertrophied facet, with the endoscopic unilateral approach, it might be very difficult and the chance of dural tear and incomplete decompression is quite high. So what defines the lumbar stability? So to talk on the stability, what maintain the stability of lumbar spine, there are passive system which include vertebral bodies, intervertebral disc, zygofascial joint, joint capsule, spinal ligament. And the muscle is the active system. And the neural system is that interacts between these two systems. So in normal stress loading to the passive system, the active system comes to play and prevent abnormal deformation. So the inability of active system to maintain the relationship between different elements of the passive system during physiological loading can lead to spinal pain. So clinical instability can be defined as the abnormal displacement that occurs within the motion segment when a normal physiological load is applied. So these three systems work together to maintain the stability. And range of motion in the spine is neutral zone, central zone, and neutral zone and elastic zone. So in lumbar instability is the ability to maintain the spinal neural zone with activity without causing neurological deficit and significant deformity and incapacitating. So evidence suggests weakness of muscle can lead to segmental instability and cause back pain, even in the absence of structural deficit. So talking about the biomechanics, so intervertebral disc is exposed to about 67% of the applied load and during shear loading, but less inflection, extension, and axial rotation. So the facet joint capsule are main stabilizer in anterior axial rotation with 49%, but provide only 10% of stability in extension. So IBD, intervertebral disc, takes the main load in lateral bending. Facet joint and facet joint capsule stabilize the anterior rotation. Anterior longitudinal ligament resists extension. Ligament flavum and posterior longitudinal ligament stabilize flexion. So this was the study performed in the cadavers, and the major component was found that the intervertebral disc, facet joint, and FCC, facet joint capsule, and muscle strength and endurance plays key role in spine stability and degenerative pathology. So when talking about the procedure that I mentioned earlier, so when we go to our tunnel on opposite side, the resection of the interspinous ligament, supraspinous ligament should not generate large instability. So however, the role of interspinous ligament, superior spinous ligament as an end top inflation remains unclear, and the resection could possibly generate vulnerability to extensive flexion loads. So the interspinous process, interspinous component will actually play the role in hyperflexion. So the role in maintaining the spinal mobility of these structures are less. So my conclusion is, although our less tissue injury, proper decompression of nerve root and spinal canal, maintaining the stability of spine should be, and minimize post-op back pain and early recovery should be our motto. MIS with endoscope, microscope, unilateral laminotomy with bilateral decompression is the best option that have been practiced recently. However, this needs lots of practice and there is a learning curve. So based on clinical outcomes, there is no proper evidence that stability of spine depends on which kind of surgery we perform for lumbar canal stenosis. And we have been doing open laminectomy and minimal fascectomy with adequate decompression of root and spinal canal, and clinical outcomes are very satisfactory. So in last 6 years, we have done around 1,856 cases, out of which 174 account for bilateral, and the clinical outcome is very satisfactory. So preservation of facet joint capsule is what determines the major stability of spine. Either we go open laminectomy or bilateral hemilaminectomy or minimal invasive surgery. Thank you.
Thank you, Dr. Samir. As we are behind time, we could probably take one question from the floor, if we have any questions from the audience. If we don't have, we can catch up with Dr. Samir in the lunchtime. It was a very interesting session. I'd like to thank Dr. Sankar Acharya and the team of speakers, specialists from ASSI, for enlightening us with a very interesting topic today, motion preservation in spine surgery. I'd like to invite Professor Pant to say some ending remarks.
Thank you very much, everybody. This was a very, very interactive session, and especially there was presentation from neurosurgeons who are doing spine surgery and orthopedic surgeons who are dedicated in spine surgery. So, you know, I think this symposium is well designed and very difficult, you know, motion preservation, very difficult topic, but well thought of. And I think we could
Dr. Shankar.
get good information from both sides, and we should not take bad information from both sides also. And we should learn. I think spine surgery is going to be arena for both neurosurgeons and orthopedic surgeons, and there's a lot of, you know, strength on both sides, and this should be shared from different colleagues. Thank you very much. Thank you.
Professor Sankaracharya, would you want to say anything?
No, I think it was a wonderful session, and thanks everyone and the organizers
Sorry,
of the
sir,
conference.
we're not able to hear you.
Okay.
Yes, we can hear you, sir.
I thank everyone, really. This was a fantastic session, and I look forward to such tie-ups in future. And thank you all the chairpersons on the dais. I'm really missing the fact that we could not go and to Kathmandu and meet you all in person, but surely next year we are going to be there. Thank you. Namaste.
Thank you so much, sir.
Thank you, sir. I would like to extend my greatest thanks to all our magnificent speakers for the successful completion of our next session, Symposium with ASSI. Also, the exciting part of our program, talking posters, has been kept outside, so please have a look in your free time. Along with that, sponsor stalls have also been installed outside, so please have a look at it in your free time. I would now like to announce for a short lunch break. We will again assemble for our next session of INSPINE 2022 at 1 p.m. Please take the coupon from reception desk, and the lunch is being served at the Lan Cafe downstairs near the pool. Thank you.
The next session that we have planned for today, I would like to announce the name of the moderators for the consensus meeting. Our first moderator is Professor Dr. Mohan Raj Sharma, Head of Department of Neurosurgery in Tribhuvan University Teaching Hospital. May I please invite Sir on the stage? He will be here with us soon. Similarly, our another moderator is Dr. Bal Gopal Karmacharya, Head of Department of Neurosurgery, Manipal College of Medical Sciences. May I please request Sir to be on the stage? Thank you, sir. Similarly, our next moderator is Dr. Sandeep Bohra, Lecturer of Neurosurgery at Kathmandu Medical College Teaching Hospital. May I please request Sir to be on the stage as one of our moderators? He will also be here with us soon. We will begin today's session. Sir, the floor is yours.
Good afternoon. So we are here for the next session. This is on consensus meeting on spine care, and we are doing this session in collaboration with this World Spinal Column Society, so and WFNS. Like to call Professor Salman Sharif from Pakistan to give a talk on cervical spondylotic myelopathy.
Hi, Mohan. Hi, dear friends. It's good to be here. I'll just clarify, this talk is in collaboration with the WFNS Spine Committee, because all the consensus up till now have been done by WFNS and not World Spinal Column Society. So without delay, I'm going to move on. First of all, I'm grateful to Amit and NESON for inviting us and getting us involved in this. It's really our pleasure to be here. This is the committee that we work with, and this is a committee that's been working from 2021 to 2023, and all are very diligent, hardworking people. And already we were able to achieve loads, which is already documented in the newsletter that we have just published. Well, I'm going to be talking about procedures that on CSM, how, where, and why which approach we should take. Generally favored is anterior approach, where CSM is due to direct anterior decompression from disc ossified complex or OPLL. Cord compression that is exacerbated by cervical kyphosis can be addressed using an anterior procedure that may readily restore normal cervical orthosis. It's easier if there's a deformity, you can correct it from anterior approach. ACDF of 1 to 3 levels have been reported to be safe and effective, and up to 4 level people routinely do decompression from front without any problems. It's generally considered for pathologies restricted to or just at the disc margin. Corpectomy is considered when pathology goes beyond, including OPLL, including some other conditions. Well, this study from our friend Nasil Gandour back in 2020, and they looked at safety of anterior versus posterior decompression in degenerative cervical myelopathy. They did a prospective randomized trial. And what they did was they found that anterior approach was significantly better regarding postoperative pain, NDI, and hospital stay compared to posterior approach. Well, there are other people who are going to say they have brilliant results with posterior approach. So, I think both are pretty reasonable. This study from Michael Feeling, looking at the prospective multi-center AO North American trial, 278 subjects from 12 sites, and they looked at these outcome measures. And they had 169 patients done anteriorly and 95 posteriorly. Anterior surgical cases were younger, had less severe myelopathy, no baseline difference in NDR SF36. JOA was significantly lower in anterior group than posterior group, although the group started at a different level of baseline. The extent of improvement between the two groups did not differ. Another study from Zohar Gogawala from US, and non-randomized prospective clinical pilot trial in which a small number of patients were taken. and they showed greater improvement in quality of life with the anterior surgery. Dorsal fusion surgery was associated with longer length of hospital stay and higher hospital cost. This pilot study demonstrated that you can do a big study out of it. This study looking at cervical anterior approach and laminoplasty in management of CSM, 150 consecutive patients and 102 patients receiving laminoplasty. Both anterior and posterior were effective. Anterior approach with relatively lower incidence of postoperative complication, and thus a better choice for this group of patients from US. Then there's another study in which they looked at degenerative cervical myelopathy, and they said anterior and posterior decompression resulted in similar postoperative outcome and rate of complications. So they had no difference among their group. Then there's this K line that was recently put forward, that if you have OPLL, which is less than the midline that you put it from C2 all the way down to C7 midline, then you call that negative, whereas, sorry, it's positive, whereas if it crosses the line, then you call that negative. And according to that, you could consider that the outcome will be different. So K-line positive patients are those in which OPLL does not cross the midline, whereas negative is where they cross. And how do you measure that? You take the OPLL and the total length of the canal, and then you divide that and then multiply by 100, you get the percentage. So this concept was put out by Takayuki, and they looked at 27 patients who had cervical OPL and event posterior decompression, and they classified into two groups, as we just talked about. And they showed that ultrasonography showed that the posterior shift of the spinal canal was insufficient in the K-line negative group. That is the group in which it crosses the midline. And they felt that the decompression from posteriorly may not be as sufficient and not give better results. Again, another study looking at 81 patients retrospectively who had undergone posterior cervical single door laminoplasty, and they looked at all these parameters, and K-line negativity and lordosis may predict kyphosis after laminoplasty with OPLL. And their thing was that if you have that kyphosis and the lordosis is less than 7, K-line negative, you should think about coming from anterior approach, whereas posterior approach may not be a very good option. Another study looking at K-line on the basis of extension as a predictor. So they put the patient in extension, and then they looked at is it crossing the posterior elements. Then you can think about that, this may cause serious problems if you operate from posteriorly. So post-operative JO score recovery rate was significantly lower in K-line-B than in K-line-F, as shown before. So basically, if you're going to be approaching this from front, you will cause serious neurological problems. What about laminectomy, fusion, and laminoplasty? So this nice review article by Kevin Fan, in which they looked at these approaches, and they found there was twofold higher complication was found in the laminectomy and fusion group, and you can expect that, and including significantly higher nerve palsy complications. A prospective randomized trial comparing expansile cervical laminoplasty with cervical laminectomy and fusion for multi-level cervical myelopathy, published in 2012. Total of 16 patients were randomized, very, very low numbers. And they said that, this could be the expansile cervical laminoplasty is a favored technique compared to fusion, although numbers were very, very small in this group. Another study with 64 patients, CSM undergoing laminectomy versus laminoplasty. And they said that, the JOS score improved in both groups. At 12 months, the JOS score Neurosc rating showed higher improvement following laminoplasty. So they thought the laminoplasty had better results. It may well be that those guys are doing more laminoplasty compared to the anterior fusions. Then we look at safety of open door laminoplasty versus French door and fusion and laminectomy alone. And none of the procedures showed the best outcome with least complication, although they said that this open door laminoplasty is suggested because of JOA improvement and range of movement reduction. Then recently we have come up with this anterior controllable anti-displacement fusion, in which we basically cut off the vertebra from front and then move the whole thing forward. So the OPLL remains, but we just move it forward. And so this study looked at 34 of these patients comparing to 36 with ACCF, in which the corpectomy and fusion was done. So post-operatively, decompression of the anterior canal and anterior posterior cord diameter they measured. At 6 months, they found the results were significantly better when you had anterior displacement fusion. Another study looked at it with 80 patients and randomizing them. And compared with laminoplasty, they found that ACF was more effective when the K-line was negative, that is, it is crossing the midline. Again, another study with 53 patients, operative time was longer in ACF and less complications in ACF compared to laminoplasty group. Notably, curvature is an important factor. So if you look at this, anterior approaches have similar outcome to posterior approaches in patients with CSM in terms of modified JOA, NURIX, NDI, SF36. This is a level 2 evidence. Anterior approaches are better in terms of lower complication rate and post-operative pain from posterior approaches, but overall outcome remains the same. There's a level 3 evidence at the moment, and that anterior approach is preferred in K-line negative, and posterior approach is preferred in K-line positive patients with CSM. Again, level 3 evidence among various posterior procedures such as laminectomy, laminoplasty, laminectomy infusion, laminoplasty alone has better outcome, both clinically with less complications. ACF recent innovation is better than multi-level ACDF and ACCF in terms of overall clinical outcome. And again, because of a small number of cases and small number of results at the moment in studies, it's still level 3 evidence. So WFNS Spine Committee this is its webpage. We have all these guidelines available on the website. I will take you through the CSM guidelines. The guidelines that we have already done are on the thoracolumbar fractures, spinal cord injury, upper cervical trauma, subaxial cervical trauma, and CSM. And recently we are starting to publish our osteoporosis guidelines. In a couple of months, we are doing guidelines on back pain, and hopefully we should be able to publish that by end of this year. So these recommendations, they are already on our website and already published. There are many options for anterior decompression, such as anterior discectomy infusion, oblique corpectomy, skip corpectomy, and hybrid surgery. Corpectomy is a good option for ventral compression of less than 3 segments, whereas a single level disc and osteophyte are inadequate to decompressing the cord in patients with CSM. In patients with kyphosis, corpectomy can restore the normal lordosis. In cases of multi-segment disease with contagious multi-segment thecal compression, alternative segment discectomy, osteophyte removal, while keeping the body of the intervening vertebra intact, is biomechanically more stable than a complete corpectomy with contiguous segmental discectomy. For anterior approach, factors that should be considered for selection of surgical approach include sagittal curvature, location of the compression, pathology, number of levels involved, and patient comorbidity. For posterior approach is an effective technique in improving the neurological function of patients with CSM. Posterior techniques for CSM consist of laminectomy, fusion, and laminoplasty. Techniques are often used if there are 3 or more level compression. In cases of significant posterior compression at 1 or 2 level, posterior compression surgeries are mandatory. The relative merit of different posterior decompression have not been determined, and kyphosis, especially in flexible kyphosis, laminectomy and posterior fusion may be chosen. In rigid kyphosis, an anterior surgery combined with posterior decompression should be preferred. In patients with preserved lordosis, laminoplasty is a good option. Cases with severe axial neck pain are not to be a candidate for laminoplasty. However, there are gray zone cases such as straightened cervical spine that we do not know which approach is better. So I'm grateful that we were part of this wonderful educational feast. We are planning a educational course for Africa, a basic course to start with for 100 neurosurgeons in June. And then we'll select about 40 participants out of that, and we're going to do an advanced course with them by end of this year. And we'll continue to publish what we have been doing. So I'm grateful and thank you for listening. It was wonderful having you here.
Thank you, Professor. Are there any questions from the audience? Okay. Thank you, sir.
Thank you.
So now we move to the next topic. This is on Bachelor in Vagination with AAD, Professor Jane Chen.
Well, it's my pleasure to join this conference. I'm Dr. Chen from Beijing Xinhua Hospital. I share my slide. Okay. And this is the photo of my hospital. One is in day and another is in evening. So we work day and night. In this hospital, we perform neurosurgery operations 10,000 per year. And I am a neurospine surgeon. I only do spine surgeries. Today I talk about basic imagination. It defined that the odontoid come upward above the chamber line. There is a lot of region for the this kind of deformity. Some comes from skull-based deformity, such as plantar fascia or the deformity of clavers. This deformity may leading to the basic imagination. And also, if hospitalized of C1 is a more common region for basic imagination, and sometimes the skull-based deformity and hospitalization of C1 is combined and may lead to more severe basic imagination. And there is some patient suffered secondary from rheumatoid arthritis. This kind of disease can destroy the bone graft, bone structures of C1, and also lead to the basic imagination. And in 2004, we classified this kind of basic imagination into two types. Type 1, type A is basic imagination without with instability. So with dental axle dislocation. Type B is very stable based on their imagination. And this kind of patient also always suffered spinal cord compression and accompanied with tremor fixation or also syringomyelia. And for the type 1 basic imagination, internal fixation and restore the basic imagination and dental axle dislocation is performed is recommended. For type B basic imagination, posterior decompression was recommended. But later, Professor Gore have some further idea about type B basic imagination. He think it's a kind of a fixed dental axle instability. So he recommended C1C2 fixation for this kind of patient. Talk about if the technique, Professor Gore invented the C1C2 internal fixation, and also he recommended extract between the face joint and the plant cage in the face joint. But for the type B basic imagination, there is still a lot of controversy. Dr. Solanki have do clinical research. He found that C1C2 fixation and fusion does not give more better result compared with posterior decompression. So to talk about the surgery technique, for the basic imagination and dental dislocation, first we should push the C2 downward and with this manner, with this technique, we can restore the basin imagination and then push the odontoid anteriorly, and then we can get a total reduction of this kind of dislocation. But if we want to push the C2 downward, the anterior tendon band will give us a lot of difficult. So in the beginning, usually we will cut the tendon band anteriorly, but other doctors give the first joint comprehensive drilling to remodeling to the first joint and make it more easy to reduct. And also control plant cage in the first joint and use the cage like a pellet to compress posteriorly then reduct the dislocation. In our technique, we first distract in the first joint and we plant cage in the first joint. And later we use the internal fixation system to reduce basin imagination and C2 dislocation. It's very effective method to reduce this kind of dislocation. First, when we distract between the first joint, we can separate the first joint. We do not need to drill the first joint, and we can also release the anterior tendons. This is some device I designed to do the operation, and this is intraoperative CT scan showed the device in the first joint, and also the first joint cages for this kind of patient. We can use this kind of technique for to reduce most of basin imagination cases. For this patient, he suffered rheumatoid arthritis, and I plant the cage in the first joint. I can reduce the basin imagination. Satisfied, and it's a very rigid dislocation between C1 and C2. And with our technique, we can release the first joint and plant the cage in the first joint. It's very suitable for this kind of type 1, type A, and basin imagination. For if we plant a cage in the first joint, we can push the C2 downward and reduce the basin imagination. And for some revision surgery, for this patient, he suffered a posterior decompression. And we can plant a cage in the first joint, and with this technique, we can reduce both basin imagination and C1 C2 dislocation. With the cage planted in the first joint, we can got a very solid bone fusion between C1 and C2. For this patient, he suffered ER and AED, and after operation, we can get a very solid bone fusion in this area. And this is another patient, 11-year-old boy. He suffered C1 C2 dislocation. In the first surgery, internal fixation was implanted and get a satisfied reduction. But 6 months later, the reduction the reduction was the dislocation come again. And so in the revision surgery, I planted the cage in the first joint. After 1 year of the revision surgery, we can get a very solid bone fusion in this area. So I just remove all of the screws. For type B, basin imagination is still controversy. For this patient, he suffered a type B basin imagination. With our technique, I plant cage in the first joint and distract between the first joint to reduce the basin imagination. We can see the decompress is satisfied and the sphincter shrinked, but not all patients we get this satisfied result. In this patient, also a type B basin imagination, and in the operation, I plant the cage in the first joint, and so the syrinx shrink a little, but the symptoms did not totally relieved. So later we performed the anterior decompression and get totally relief of the symptoms for the patient. To conclude, the manipulation in the first joint can be very helpful to reduce basin limitation and accidental axial dislocation. Cage implantation is a key for reduction and fusion. And there is still a lot of controversy in the treatment of type B basin limitation. Posterior or anterior decompression is still needed sometimes. Thank you for your attention.
Yes. Rafsha, there is a question for you.
Good afternoon, sir. I have two questions. One is, what is your indication or guidance to us to when to include the occiput and when not to include the occiput in this kind of basal invagination? And in your practice, how often nowadays do you go anteriorly to remove the ornamented peg? Thank you.
In most cases, we just use a posterior approach to plant the cage in the first joint, and I think in these 3 years we have about 400 cases, and about 95% at least only posterior approach can get excellent result. And very few of the patient we need anterior decompression. Usually after the posterior procedure, if the posterior procedure that does not get excellent, it does not get totally relief of the patient, we may get a second procedure from anterior. Thank you.
Good afternoon, sir. So I have one question for you, sir. So do you use neuromonitoring while doing the surgery, like while distraction?
Yeah, skull traction is very useful for this kind of operation. With skull traction, we can make it easier to release the first joint.
So one more question, sir.
Thank you. Thank you, sir, for your presentation. So do you remove the C1 posterior arc in when you do the fusion?
In our patient.
Yes, because many times I see that while putting in the screws, the C1 arc tends to press on the already compromised spinal cord. So for prophylactically, do you try to remove, this C1 arc?
Yeah. In our patient, about 90% of the patient comes from have hospitalized of C1, so there's no C1 arc. And if there's no hospitalized of C1, I think most of patients we do not need to remove the arc of C1.
Thank you, sir.
Thank you.
So we have one more question.
Yeah, thank you very much, Dr. Zan Chen. In 2012, I was there in your institute for 1 month fellowship.
Hello.
Yeah, my query is, your technique, is it similar to P. Sarat Chandra's DCR technique, or it's different? And the case you use is the same or the different one?
There's a little difference. For I do not drill the first joint because I think the most problem comes from the anterior tendons. if we release the anterior ligaments, the first joint will separate it. So the remodeling technique is not necessary, and we just with the post approach to distract in the first joint, we can release the tendons and separate the first joint, and it's very safe and effective. Thank you.
Yeah, do you use C1 C2 fixation or occipital cervical fixation in your cases?
Because most of our patients suffered occipitalized of C1, so there's no C1. We just use occipital to C2 internal fixation.
Thank you very much.
Thank you so much, Professor. So due to lack of time, we'll move to the another presentation by Professor Nicolai P. from UK on lumbar disc and back pain.
Hello, everybody. Thank you so much for the invitation. Glad to be with you today. I'm going to share now my presentation. Can you hear? Can you see?
Yes. Hello, Dr. Nicolai.
Hello. Hi, Mohan. How are you?
This is Mohan. Yeah, welcome. Welcome to Nepal virtual. Please start your show.
Thank you. Thank you. Back pain, one of the most common things that you will meet with patients with. If you go and read the WHO bulletin, you will read that every living now will meet the spinal specialist by the end of their life. The spine is the second reason for sick leave after the flu, and now maybe after COVID, and the third most common cause for surgery. So some statistics from UK, about 7% of the population will attend each year, and the cost of that is about $500 million. About 80 million working days lost. But as you can see here, we operate only about 24,000 per year because of back pain issues. So speaking about back pain, we have to talk about the biopsychosocial model. Your patients will have nowadays unrealistic expectations. They would like to be completely pain-free. They would like to have unrestricted activities, even if they are 60, 70, 80. There is a great interest in back pain from patients, media, lawyers. You have to consider the individual medical profile of the patient, individual psychological profile, and also social profile. There will be patients, especially in the Western countries, which consider back pain as employment. Unfortunately, we still cannot heal the spine. We can treat the spine, and I tell this to my patients, and I would like to be on the same page with them. So I tell them, I cannot send you back to your youth, and we have to be realistic. So why this is happening? After the birth, we start aging. So we start losing water, and the loss of water in the disc is giving you loss of tension. Then the loss of tension is giving you instability because of bigger freedom of movement. Then that will give you non-physiological loads, cumulative damage after that, and then finally herniations and stenosis and problems, and that will result eventually in pain. So most common cause of pain would be mechanical pain, degenerative pain, mechanical pain, neurogenic pain. Non-mechanical spinal conditions will be about 1-2% of all. Talking about the mechanical degenerative pain, unfortunately, we still have a significant amount of patients where we will not be possible to get a pain generator, but we will find degenerative discs or joints disease. We will find congenital deformity. We'll find spondylolysis and instability, and then we can address that specifically. The neurogenic pain is mainly because of herniated disc or spinal stenosis, osteophytic nerve compression. and because of disc changes like internal disc disruption, chemical irritation of the nerves. So other causes, other causes of pain, of back pain, would be neoplastic, infection, inflammatory, some rare diseases, some referred pain, and some psychological conditions. And however, this will be about 1–2% of all the patients that you will see with back pain. So please don't, seeing patients with back pain, we have to make sure that we do not exclude and miss the red flags. We have to constantly think about the malignancy, fractures, coda equina, infection. And if that is not there, we can just consider pain management. But if the red flags are there, we have to consider investigating further. If it's only neck, back, and limb pain, usually it's self-limiting. It will resolve in 4 to 8 weeks in more than 50% of your patients. High recurrence rate, it will come back at some point, and you have to tell that to your patient. And if you're not worried, if you don't have red flags, you can wait. At least 60% of these patients will get back to work within 1 month, and about 90% will go back in 3 months. Again, think about the red flags. I like the mnemonics, and that's why I'm giving you these mnemonics. It's tuna fish, so it's trauma, unexpected weight loss, neurological complications. If your age is below 20 or over 50, if your patient has a fever, if the patient is drug user, if the patient takes steroids, or if there is history of cancer, HIV, then obviously you have to investigate, and you should not be satisfied to just wait the pain to self-limit itself. Even if you don't have these red flag symptoms, sometimes you need to investigate further if your patient has very prolonged and intractable pain for 6+ weeks, or if the patient is debilitated by pain for 6 out of 12 months each year, if the patient is young, highly functioning. And the goal is to diagnose a specific pain generator and then to treat it. You do that by history examination, imaging, and in my hands, I do quite a lot of diagnostic steroid injections because most of my patients will be with multi-level degenerative changes, and I'm trying to pin the level to 1 or 2 levels. So I do a lot of injections. Unfortunately, not always possible. So speaking about back pain, facet joint injections, facet joints are quite often involved. Epidemiological studies show that about up to 45–50% of the pain is due to facet joints. You can see cadaver studies, 100% of the facet joints over 60 are involved. Unfortunately, we don't have pathognomonic test or maneuver to diagnose the facet joint as pain generator. It's indirectly diagnosed with history examination, imaging, and injections. Injections are important in my practice, and that's why I'm emphasizing, because there is, as I said, there is no gold standard to confer facet pain. The nerve supply of the joint is quite robust, and it's causing same pain of overuse like the other joints. Many compensation mechanisms as well, like muscular spasm, altered movement, pain referral patterns. So injections are accepted standards of diagnosing back pain, and it's going together with the other imaging as diagnostic tests. If we're talking about discogenic back pain, you will have degenerative disc disease like the one which is shown on that image here, disc internal disc disruption. You can see the hyper intensity here on that picture. And then disc herniations, we have a lot of disc herniations in our practice. How the pain would be generated because of the disc, it will be a mechanical compression It could be a vascular component. It will be inflammatory response. It would be biochemical agents that will be released. And sometimes you will have a sagittal disbalance, and then you will have claudican back pain. We'll mention this later on. So this is a good picture of a disc. It's a drawing of a disc that is depicting the nucleus, the lamellae, and the innervation. You can see here basivertebral nerves which are going towards the disc and are innervating the disc. And if there is a disc disruption, for example, or disc herniation, you will have these nerves activated, and then you will have back pain. You can have also referred leg pain, and your patient will struggle. The patient will come to see you, and you have to do something about that. So back pain generation will be in this discogenic type of pain due to the change of disc loading and shape and biomechanics, also loss of the viscoelasticity. And a lot of your patients, together with the radiating leg pain, will suffer with back pain, and there will be a history of back pain before that. This is interesting diagram that is showing how the disc intradiscal space, intradiscal pressure is changing with different activities. So this is the main reason why your patient will complain of back pain in specific positions like sitting or driving car. This is because of the change of the biomechanics and change of the pressure in the disc. Again, injections for the discogenic pain is something that will help you to diagnose, to treat. You can use that as a window of opportunity. After the injection, you can send your patients for more physiotherapy. This is not standalone procedure. You can use the injections to break the vicious circles which the pain created. And like that, you can wait until the pain self-limits in case there is no other serious conditions that you have to treat. I wanted to show you this, this video. This is one of my patients which came to see me only with back pain. You can see how she works stooped forward. So she had multi-level degenerative spine, and you can see her posture is not great. She is quite positive with her sagittal balance. She's doing that because she is stooping forwards because she is trying to compensate. She's trying to open the foramen that is stenotic. And by stooping forward, she's opening the foramen, and like that, she's alleviating her back pain. Sorry, she's alleviating her leg pain, but she is creating quite positive sagittal balance. Her muscles, the anti-gravity muscles, have to work more, and she's paying for alleviation of the leg pain with back pain. So you have to consider that the back pain could be a dynamic phenomenon. You see the patients in that position lying in the MRI scan, but when the patient is upright, you will have this picture or this picture. So that is, you have to think about the dynamic differences. So majority of the patients will self-limit, and that's why you have to rely on a history examination. If there is no red flags, you can discontinue. So if the pain is still there in 4 to 6 weeks, you have to obtain more imaging and treat accordingly. This is one flow chart from NICE. In UK, and you can see here that you basically, if you don't have red flags, you entertain the patient and you wait the pain to self-limit itself. And finally, take home, extremely high in incidence. Think about the red flags, wait, and 90% will settle down in 4 to 6 weeks. Reevaluate if the pain is still there in 6 weeks, and then obtain more imaging. Look for specific biomechanical causes, try to identify the pain generator, Consider injections. They will be helpful in your practice, and your patients will be happy that you do something about them. And then include sacroiliac joint injections in the evaluation. About 1/3 of the patients will struggle with pain because of sacroiliac joints. And that's it from me. Thank you so much.
Thank you, Dr. Piv. Excellent presentation. Your talk is not only educational but entertaining too. Thank you so much. Any question? Maybe 1 or 2 questions we can allow. Mike. No?
Thank you, Dr. Nikole, and it was very pleasant to hear you again. And first of all, congratulations on becoming a father. I know you were trying to come to Nepal, but because of this problem, you could not come, but then we definitely expect to see you soon. This lecture of yours is very pertinent, and in global disease burden in Nepal also, low back pain actually ranks the first. And that's why yesterday we had a meeting with World Spine Care regarding how to classify the diseases, particularly the low back pain. And as per what your recommendation, it is very similar to it. So we are coming down to 10 questions, which we can ask to patients at very community level, so that even the people who are in far flung areas can be posed these questions. And it actually follows your same protocol, but then not to as extensive treatment approach as what you have explained. So this will definitely be a very good guideline for us. Thank you once again.
Thank you. Pleasure to be with you even online. Hopefully next time face to face. I have a lot of friends in Nepal, been so many times in Nepal, and I would like to be there again.
Okay, thank you. Thank you. Now, we'd like to invite another speaker, Professor Mohammad Zeli. He's talking on lumbar canal stenosis. Is he live online or recorded video? Please.
Yes, I'm here.
Thanks
a lot for very nice invitation. I could not make it to come to Nepal this time, but I wish to be with you in the next meetings. This is, I call it a lumbar spine stenosis, when to decompress and when to fuse. The main issue is this. Is it there, my slides?
Yes.
Yeah. Actually, stenosis is a term coming from the myelography area, a fluid going on and has been stenotic in some segments. But probably narrowing is a better term. It is more often in older ages. Pathophysiology is the area for neural and vascular structures are reduced. And the main problem is mostly a neurogenic claudication. It may be together with a low back pain or not. There are congenital reasons like idiopathic or achondroplasia, but most of them are acquired or degenerative spondylolisthesis, spinal stenosis. According to the site of stenosis, there are central stenosis, lateral stenosis, or foraminal stenosis terms we use. Most frequent it is on L4-5 and 3-4 levels. L5-S1 level is not common. And to understand the problems, we must understand the motion segment issue. Actually, this is a disc and 2 facet joints comprise a motion segment. And this motion segment can have degeneration in these 3 phases. The first is dysfunctional phase, then unstable phase, then stabilization phase. So then our actions in this functional case, like Nikolai Pev has explained, it may be just some injections or some back pain problems. In the unstable phase, the patient may need some stabilization or not. It depends on the degree of complaints. And the rest stabilization phase, mostly a static stenosis of the lumbar spine. So normal mobile segment is like this, and degenerative mobile segment is like this. degeneration process ends with spontaneous fusion mostly. If you look at the pathophysiology, then at the beginning in dysfunctional phase or unstable phase, it may be soft stenosis. Then by subluxation, the dynamic stenosis, and in the restabilization phase, it may be a hard stenosis. Most of our surgical indications are for neurogenic claudication only. It's very uncommon to have a cauda equina syndrome. But this patient, a young patient with a very short pedicles, had a cauda equina syndrome when he come to me. And then this was an absolute indication for surgery. He had a sensory loss and a sphincter problem. Surgical techniques we use are decompressive techniques or decompression plus fusion. In the past, we used to do large laminectomies for that. And then we turned to the fenestrations by unilateral hemipartial laminectomies. And then this is a typical fenestration case. Then we turned to recent trend to look at the level unilaterally and decompress it bilaterally. It can be done by a microsurgical techniques or tube-guided surgery, which I'm using most often, tube-guided surgery. You can use endoscope or microscope, and you can get a very nice decompression. This is preoperative, postoperative films. You can make even 4 levels cases, 1, 2, 2, 3, 3, 4, 4, 5. And this is the incision lines, 4 small incisions with dilatation of the muscles. And this is pre-op and post-op films of the same patient, unilateral approach and bilateral decompressions. What are the facts about the minimally invasive surgery? They are not superior to the open decompression in terms of clinical outcomes. However, hospital stay and return to work are shorter and infection rate is less. What about fusion? When is it necessary? Is it necessary only if there is instability or if there is only back pain? There are certain problems in making a good decision making. Probably we must use complex lumbar spinal stenosis if there is a degenerative listhesis, scoliosis, kyphosis, or previous surgery at the level together with spinal stenosis. Typical syndrome is the flat back syndrome. This lady has got it, and she is not able to stay straight. And on the lumbar spine, you can see a kyphosis instead of a lordosis. So suggestion is that L4-5 osteotomy and TLIF and instrumented fusion. So then the surgical options are those. This is still, there is an option of decompression alone, but sometimes we have to do decompression plus fusion. Decompression alone is possible if the stable segment with osteophytes, if the disc height is very narrow. So those cases, even if there is some degenerative listhesis, you can make just decompression. However, instrumented fusion should be indicated if there is anterior listhesis more than 3 millimeters, if there is a mobility in dynamic films, if the disc height is preserved more than 2 millimeters, if there are sagittalization of the facet joints, no osteophytes, and osteoporosis. What are the techniques? Interbody fusion, posterolateral fusion. There are also certain problems about what type of surgery is necessary. Some surgeons even recommend to avoid the problems of fusion, especially adjacent level disease. They apply dynamic fixations instead of fusion. What about the evidence for surgery, conservative versus surgery? First, this study from New England Journal of Medicine probably is the only study that the Weinstein group from 2008 saying that surgery is superior to non-surgical treatment. And 1 year recurrence of stenosis is approximately 1.3%. This is a systemic review, 5 studies saying that side effects of surgical groups are between 10 to 24%. So no conclusion regarding which treatment is better. This study is looking at the natural course of the disease and saying that 30% of the patients may have subjective improvement of symptoms with conservative treatment, no surgery. So why do we operate all the cases? We can try to make conservative treatments. This is our publication about the WFNS Spine Committee recommendations. We are also saying that if there are no predictive signs of symptoms that they will worsen, these are the predictive signs, we can follow them, and 30% may get benefit from that. Evidence for fusion surgery, the compressive surgery or fusion surgery. This is a meta-analysis saying that the compression plus fusion is not more effective than the compression alone. This is another study, but a retrospective study from United States saying that non-instrumented 1 to 2 level fusion is better than instrumented fusion by placing the graphs on the posterolateral sides. This is one of the most cited publication, a level 1 study from Sweden saying that the compression plus fusion surgery did not result in better clinical outcomes at 2 and 5 years than the decompression surgery alone. So after that, many conservative approaches have been implemented by many surgeons. This is a meta-analysis that's saying that instrumentation for low-grade degenerative listhesis did not result in superior results to decompression alone. And we collected in the WFNS Spine Committee recommendations mainly 3 high-level studies, and these are the recommendations. I will not give much details, but you can arrive them from wfnspine.org recommendation site. There are even some surgeons who are looking at the clinical and radiological factors and then making a staging system to facilitate our decision making. For instance, if there is mechanical back pain, score is 2. If there is also segmental kyphosis, score is 1.5. And if total numbers are more than 5.5, this indicates instability and fusion surgery is necessary. In conclusion, non-surgical treatment for lumbar spine stenosis may still be a good option for many patients. Decompression is the basis of surgical treatment for lumbar spine stenosis. Indications of surgery for spine stenosis are mostly relative, just claudication, and to increase the quality of life of the patients. Unilateral approach and bilateral decompression is currently most popular surgery, but its value is not validated yet. We cannot say it's better than bilateral surgeries. MIS techniques have significant advantages, but in the long-term outcomes are not much different. Fusion is an option, especially when there is listhesis or instability, but indications still remains controversial. In degenerative listhesis, decompression without fusion is still possible. Decision making for complex spine stenosis is difficult, And fusion indications are probably additional back pain, overt instability, preserved disc height, and facet degeneration. And not only one of them must present, actually 2 or 3 of them must present at the same time. And we must better make short fusions, and then we must accept approximately 25% complication rate. This is my algorithm. If there is neurogenic claudication because of lumbar spine stenosis, if there is no back pain, just make decompression alone. Consider to avoid iatrogenic instability and use MIS techniques. If there is back pain without instability, try to make conservative things like facet injection, sacroiliac joint injection, brace and exercises. If no benefit, you can consider decompression and fusion. Significant radiologic instability together with back pain may go to decompression plus fusion. This is my talk, and I thank you for your attention.
Thank you, Professor Zilili. Excellent talk. My question to you is, now you showed many data, randomized control trial, meta-analysis, and systematic review, not suggesting that much role of surgery, but the surgery for the low back pain is on the rise. How do you explain this? Your experience.
Yeah, actually, it's interesting. If the number of surgeons are too much, the number of back surgeries are too much. So this is a correlation, direct correlation. So then I believe many surgeons do not look at the indications for surgery, just love to make surgeries.
Thank you. Maybe one question. Yeah. One more question from Dr. Krishna Sharma.
Sir, greetings from Nepal. A very basic question, actually. Now, we used to understand that fusion means bone fusion. And when we put instrumentation, we used to call it fixation. So nowadays, are they used synonymously because you're not using any bones for all this fusion, only the instrumentation is being done. Can you, sir, please kindly clarify?
Sorry, the voice is coming from very deep. I couldn't understand the question.
The question is, when do you use the term fusion as opposed to fixation? I paraphrase the question.
When do we use
the word fusion as opposed to fixation in spine?
Yeah, it is actually, there are many surgeons who are doing just fixations without placing grafts on the posterolateral part or interbody. So then the fusions fail, pseudoarthrosis develop, and then the patient may become more painful after that. Okay. This is the reason of failed backs. I do interbody fusion together with pedicle screw fixation, and I try not to do that more than 2 levels. If you do longer fixations, then you are having more often adjacent level diseases.
Thank
you. Is
you,
it
sir.
the answer to your question?
Yes, it did. Thank you so much for your nice presentation.
Thank you. Thank you.
Thank you very much.
Now we are calling on Professor Sandeep Baisya. He will talk on early surgery versus timing of surgery after spinal trauma.
Yeah, can you see my screen?
Yes, we do. Yes, we do.
Okay, so good afternoon, everybody. So I will be talking on the timing of surgery and whether it impacts the outcome of the patient. So as we all know, the traumatic spinal cord injury is a devastating event, usually occur in younger people, and it can lead to death or lifelong instability. They have loss of productive life years with enormous economic and social impact. And cervical spinal cord is the most commonly affected. Many of these patients are quadriplegic. So we have to answer the question that whether early surgery can improve the outcome in these patients. For these patients, the ability to walk again is of extreme importance and the desired result for both patients and physicians. Again, the improvement of motor power has become the main goal of pharmacological and rehabilitative interventions in the modern era, whether it is robotic devices or implanted chips. Everybody is looking at improving the mobility. So based on parameters from the international standards, physicians may be able to inform the patients about the predicted long-term outcomes, including their ability to walk with high accuracy. MRI, biomarkers, and electrophysiological examinations can further provide useful diagnostic and prognostic information. Particularly aggressive cardiopulmonary management and early surgical intervention of patients with spinal cord injury have also been shown to improve the outcomes. So now we have to answer the question whether the timing of surgery matters or not. So I'll just take you through the published literature, what is available. So Fillings in this early publication mentioned that 10 to 15% of individuals with Asia A grade lesions will convert to Asia B to D, but only about 3% will regain functional strength below the lesion level. Again, 3% seems small, but even if you are able to provide some functionality or movement to these patients, it is a great job that we can do. So about 54% of patients with Asia B can convert into Asia C or D, while 86% of those classified at Asia C or D at 72 hours of injury can regain useful motor function and can ambulate. So evidence suggests that persistent compression of the spinal cord after the primary injury represents a reversible form of secondary injury, which if we can take care of, can lead to reduced neural tissue injury and improved outcome. You can just take this analogy to the in head injuries when there's a large hematoma, and if you decompress the brain, then the perfusion pressure in the brain will improve. And similarly in spinal cord injury, the perfusion can improve if you can decompress the spine. And early patient mobilization in institution of physical therapy is an added advantage in these patients. So based on the biology of secondary injury in spinal cord injuries, the Spinal Trauma Study Group has defined early intervention as occurring within 24 hours. Though various surgeons have used different definitions, some people have used less than 72 hours, some have 36 hours, calling it early surgery, while others have used very early surgery within 8 hours also. That early stabilization can help in those patients who can have worsening in spinal instability and then associated neurological deficits with that. So you can do an external immobilization or can do a surgical decompression in such patients. So what is the published literature so far? So I'll just take you through that. So in this paper published in 2014 in Journal of Trauma and Acute Care Surgery, so they looked at whether the early or delayed surgery affected the outcome of the patients. So the authors analyzed data from the trauma registry, German Trauma Society registry, and looking at the polytrauma patients with spinal injuries. And they compared early, that was less than 72 hours, versus late surgical treatment, and found that early stabilization was associated with a shorter length of stay in the hospital, shorter ICU duration, and reduced rate of sepsis compared with those with late stabilization. This Morio et al. Again observed significant benefit of surgical decompression within 24 hours. And they had at least one Asia grade improvement in almost 2/3 patients, as in 14 patients, 9 patients improved, as compared to none out of 6 patients in the late group. Similarly, Hesbaut et al. Evaluated the effect of early surgical decompression. And they also combined it with perioperative regional epidural cooling and within 8 hours of injury. And 2/3 patients out of 14 completes a cervical spine injury, improved to at least one Asia grade. Again, in a recent meta-analysis, benefit of early surgery within 24 hours was investigated. An increase of 2 Asia grades was regarded as successful. Improvement in the early surgery group was 22% as compared to 10.4 in the late surgery group. So there was a statistical significance in early surgery in this study. And this indicates a paradigm shift in the surgical management of patients with complete spinal cord injury, which should not be treated less urgently than patients with incomplete spinal cord injury. Many times, complete spinal cord injury patients get relegated to next day or theater whenever it's available in next 2-3 days. So people don't really take them as urgently as incomplete spinal cord injuries. Again, this paper studied the impact of timing of intervention in thoracolumbar spinal cord injuries. So there were 3 studies. In one study, the patients were evaluated within 8 hours, surgery was done within 8 hours, and 5 out of 6 patients with complete Asia A improved neurologically, 1 improved to Asia B, 1 to Asia C, and 3 patients improved to Asia D, which is a significant number. So, and this is a chart showing the comparison of early versus late surgeries in both cervical, thoracic, and thoracolumbar trauma. So, role of ultra early surgery versus early surgery on functional outcomes. So, Nasi et al. Observed that patients in more severe grades, that is grade Asia grade A, benefit more from ultra early surgery, which was defined as less than 12 hours by them, while others are defined as less than 8 hours. So for patients with cervical spine injury, better outcomes were observed following early cervical, ultra early surgery. Similarly, lower complication rates were seen in ultra early surgery as compared to early surgery group. The STASIS trial in 2012 recommended that decompressive surgery prior to 24-hour spinal cord injury could be performed safely and was associated with improved neurological outcome, which was defined as at least a 2-grade Asia score improvement at 6 months follow-up. Again, this study published in Journal of Neurosurgery Spine looked at the surgical timing for cervical and upper thoracic injuries. And all patients they took patients only with the injury severity score greater than 16, and they termed their protocol as early appropriate care. That means they tried to operate all the patients within 36 hours of injury after stabilizing the patient. And they noted a better outcome in this group of patients. In this landmark paper, Feelings and his group, there was a timing, and they did a systematic review of the timing of decompression in patients with acute spinal cord injury. They found definite improvement in the cervical spine injury when the surgery was done within 24 hours, but the evidence regarding other spinal cord injury population was inconsistent. And that is particularly because there are no large studies and there are not too many studies on this. Again, in this complete spinal cord injury study, they found that surgical decompression within 24 hours had a beneficial effect on the neurological recovery in patients with complete cervical spine trauma. They also found that in thoracic and thoracolumbar, the effect was less clear. In this study, they found that early surgery improved the sphincter and the functional mobility in the patients at 1 year of follow-up. So are there good randomized control trials on this? There are none. So there were 2 randomized studies in the literature comparing early versus late stabilization and at small sample sizes, and they were not designed to answer questions about the management of polytrauma patients. And the confounding variables included surgeons' expertise and scheduling conflicts, as well as the individual surgeon bias regarding preference for early or late stabilization in these patients. So we actually need good randomized control trials on this. Now, what to do? One should be aggressive, but one should be sensible. According to best available scientific and clinical evidence, we believe that surgical stabilization, if needed, should be performed as soon as possible, particularly for unstable cervical or thoracic spine trauma, within the constraints of the patient's overall medical condition. See, if the patient is particularly, many of these patients have polytrauma, and if the condition of the patient is sick, has lost a lot of blood, and he's significantly hypotensive, then that takes priority over the spine surgery. But once the patient is stabilized, surgery should be performed at ASAP. Now, the factors that one needs to consider in this situation is the hospital setup. Not all hospitals may be geared up to take up such kind of emergencies, and the availability of the general surgeon to take care of the polytrauma part, and intensivist, emergency ICU, and the operation theater availability. And the good quality nursing care is also very important. And particularly the experience of the surgeon in management of such complex patients. So what is the future for this? The prospective and randomized multicenter clinical trials are warranted in future in order to gain valuable data and helpful therapeutic management algorithms for these patients with fractures and polytrauma. I'll just speak, this is a different talk, but I'll just mention one thing, that most of these studies have shown that systolic blood pressure less than 90 should not happen. That will affect the functional outcome significantly. And ideally speaking, mean arterial pressure should be kept 85 or above to improve the perfusion of the spinal cord. And in many studies, it has been shown that that has improved the neurological outcome in these patients. Thank you.
Any questions? Dr. Amit, yes.
Dr. Sandeep, that was a very lovely presentation and very enlightening references which you have actually put forward. I would just refer to the last slide which you put up, and this is very pertinent for our scenario because we tend to maintain the blood pressure and start the patient inotropic support as soon as possible, if in case there's no hypovolemic element in the patient. But then that brings in a question of anesthetic advice to wait for the patient's hemodynamic instability to form before you operate. And because that's why the conflict of interest between the surgeon and anesthesia arises. We do still profile for early surgery, even though the patient is on an inotropic agent. What has been your experiences over this?
See, unfortunately, I don't get too much of acute trauma because we are in a tertiary care private center. So most of the trauma in our part goes to government or public hospitals. I have had experience of treating 3 thoracic trauma within 24 hours. And one was very recent, actually. This lady came, fell down from the stairs at her home. She came around 8 a.m. She was Asia A, and she was found to be COVID positive. So again, as you said, though the hypertension was not the problem, but the anesthetists were very reluctant to take a complete injury patient with COVID positive. But we insisted, and we were able to operate the patient within 8 hours. And I'm glad to tell you that patient converted to Asia D by the time she was discharged after 7 or 8 days. And other 2 patients that I operated, again, within 24 hours, both of them converted to Asia D. So this is my limited experience of 3 patients. I have not had any experience of cervical trauma operating so early, because we get re-referred trauma, and usually by the time they come to us, it is a few days late. So I hope that answers your question.
Thank you. Thank you very much. Our experience is, whenever there is feasibility and patient is stabilized, we should take the patient to the operation theater if the decision has been made to operate. So
yes,
our logistic issue are also there. The OR time available and patient is off the inotrope, then the patient should be operated earlier. That's our protocol in our university.
Sure.
Thank you very much, Dr. Baise, for your presentation.
Thank you so much. Thank you so much, sir. Next, we move on to the next presentation by Professor Artem Gustav from Russia on thoracolumbar fracture.
Dear gentlemen, thank you for inviting me to be the part of your faculty. It's okay with my slides?
Yes, sir. Yes, sir.
Oh, thank you. So my topic is thoracolumbar fractures, which is actually well published in the literature. And as the part of the WFNS Spine Committee, I would like also to present some investigation which was made by our group, and the publishing in last year. The information regarding thoracolumbar fracture is included. The incidence of this fracture among the inhabitants, about 30 per 100,000 people, including osteoporotic fracture, of course. And the mortality of fracture among the elderly is quite high, as the fracture among the children is usually multiple. And some other points which were important and published well in Neurospine journal last year. We all know that thoracolumbar fracture is classified by Davis according to 3-column anatomical biomechanical model, and based on mostly guidelines for the treatment. I also have Magyar classification, which mostly mechanical model and subdivide the fracture for compressive, destructive, rotational. But till now, our spine classification is well established in literature, and it subdivide fracture for the type of fracture according to forces, including burst fracture. The disruption forces also included in our spine fracture, and it's classified as B. And rotational mechanism also included there is C, our type of fracture. We all know this classification, but now the TLICS injury classification and severity score, which include fracture morphology, neurological deficit, and posterior complex status, is well established and used for the algorithm of certain surgical type of treatment. So it's very convenient to summarize the points according to this TLICS classification and to make decision if surgeon have to perform surgical treatment if it's more than 4, and use the non-surgical therapeutical treatment if it's less than 4 points. Of course, as we learned from the previous speaker, ASSI scale is well used in all over the world, and conclude all kinds of level injury of the spinal cord, from the complete motor and sensory deficit and normal function of spinal cord after the injury. And we also use the Frankel classification, which mostly orientated the specialists to level and degree of damaging of the certain segments. Based on the investigation of WFNS Spinal Committee, there were published some tricky clinical and radiological factors which could be pointed in case of decision-making regarding the treatment options. And it's underlining the decreasing of vertebra high, less than 50%, which should be pointed as the risk of the kyphotic development. We also found that that's the increasing of the distance between spinous process, more than 20%. It's also well-known indication for instrumentation due to possible posterior complex instability. The COP angle more than 10 degrees, also the indication for correction of the deformation. So finally, the surgeon coming to the decision in case of spinal thoracolumbar fracture. What's the mechanism of the injury, of course, the level and the elongation of the injury and degree of instability, of course, and if to use the brace, what kind of surgery should be used. So the instability factors described in several papers, including the German paper from Jerry Koster-Hoff, and instability is subdivided on 3 types: mechanical, neurological, both kind of instability. And normally the criteria which already mentioned, it's loss of vertebra, high loss less than 50%, angulation more than 20%, and of course the canal compromise, which means the high incidence of neurological deficit and progression of kyphosis. So again, the article which published as the recommendation of the WFNS and the indication for the surgery recommend in case of B and C fracture, based on our classification, treatment conservatively. In case of A2, A3, and 4, it could be based on the decision if the body collapse is severe and kyphotic angulation is high, so it can be done surgically or also therapeutically with bracing. But actually, the bracing as conservative treatment is quite low incidence of effectiveness of treatment. Burst fracture without neurological deficit can be treated as conservative and surgical technologies. So it's based on the preference of surgeon and decision regarding the possible kyphotic incidents. The fracture management, it's created several goals. Of course, the first, it's decompression. The second is mechanical stabilization and prevention of secondary neurological injury. It can be include instrumentation, but of course it's not 100% indicated, especially remember the such type of complication which can be founded after the instrumentation. So the correct instrumentation is very important and should be indicated only in case if it's really necessary, in case of mild fracture, reduction of the vertebra height. So just several cases. For example, this vehicle accident with mild neurological deficit. From the TL-ICS point of view, it's 5. So the surgery performed in 2 stages. First, it's posterior instrumentation, decompression, and fusion. 2 segments high, 2 segments lower. And then second stage, it's lateral cortorectomy and the cage insertion. This is postoperative result. Another story, the decreasing of the high vertebra less than 50%, but based on instability rate, it's TL-ICS 7. So also the surgical way, because of the compression of spinal cord, quite severe, hematoma inside the canal, and performing the posterior lateral fusion, T11L2 instrumentation. And the last, not least, clinical case, very severe damaging of spinal cord with minimum neurological preserved function. In this situation, the first attempt, it's very high TL-ICS, till 9 classification. Because of the surgery should be interrupted due to sacral hemorrhage. The surgery was postponed, and the final result after the instrumentation, it's L1, L5 instrumentation with posterolateral fusion. Just based again on the article published by WFNS, the burst fracture could be treated with short screw fixation. It don't need long instrumentation, and there is no evidence that long fusion is needed in case if it's not a real incidence of the kyphotic deformation. And also the minimal invasive techniques can be considered in treatment of the mild reduction of the height of the vertebra. We always used in nearly 20 years correcting vertebrotomy in case of avoiding of kyphotic deformation, and also some kind of reduction table and reduction screws can be used for this for these reasons. In case of mild deformation, the thoracoscopic procedure can be used also. In this case, we can perform immediate one-stage surgery instrumentation with insertion of destructible cages and reduction of kyphotic deformation. Of course, it's surgery only available in case of low incidence of neurological deficit. Finally, the treatment for the algorithm for treatment of thoracolumbar fracture is quite easy. The algorithm widely known and made by team of Alex Lacar, and mostly subdivide the damaging on a stable and clear unstable. And the case of avoiding of neurological deficit can be performed therapeutically or the surgery indicated. The same algorithm, but more wide way with presentation of AO types of classification with existing or excluding a neurological deficit can be presented, and also non-operative management or surgery with correction of kyphotic deformation could be presented here. Sorry. Of course, as also presented by Sandeep, the acute fracture, it's always the situation which could be cared by the multifunctional specialist and the situation for ICU unit, and all the somatic problems of the patient could be avoided, and blood pressure and all possibility of damaging internal organs could be checked. And normally patient come into intensive care unit is first. And it also pointed that's very important, the time of the surgery. We try to perform the acute spine fracture management in first 8 hours. But anyway, according to well-known classification, the time periods of the spinal trauma subdivide on early, intermediate, and late. So the first 72 gold hours, it's the most important time when the surgery could be performed to avoid the complete neurological deficit and to return patient to the normal functioning. Thank you.
Thank you so much, sir. That was a wonderful presentation. Do you have any questions for him?
In terms of conservative management, do you use methylprednisolone still, or what is your protocol?
Oh, can you please repeat? Sorry, it's not.
Do you use steroids in spinal cord injury?
Yes, of course. We always use steroids, and high dose steroids, methylprednisolone is as the prevention of spinal shock. Yeah.
You do use, okay. No other question. Thank you very much.
Thank you. Thank you.
And now I'm requesting Professor Krishna Sharma to talk on osteoporotic spine fractures.
Namaste and good afternoon. Can I have my presentation, please? Respected moderators and friends, I'm talking on management of osteoporotic fracture of spine. Yeah.
Yes,
Sorry. Osteoporosis is a systemic skeletal disorder characterized by low mineral density and microarchitectural deterioration of bone tissue, compromising the bone strength and leading to enhanced bone fragility. And it's a consequence of increase in fracture risk. Osteoporosis is associated with high morbidity, mortality, and social cost, making osteoporosis an important public health problem. The annual direct medical expenditure of more than $1 billion is estimated in the United States alone. Vertebral compression fractures are the most common type of fracture secondary to osteoporosis. In the United States, of the total 1.5 million fractures attributed to osteoporosis, half of them involve vertebral fractures. With increasing in life expectancy, the incidence of osteoporotic fracture has also increased. The prevalence in both sex and age is sex and age specific, affecting 25% of the postmenopausal women older than 50 years old, and 6% of 50 years old. That increases to 40% by the 80 years old. Worldwide, a new vertebral compression fracture occurs in every 22 seconds. Many theories are there: disturbance of the nutrition to the bone, vascular disruption, and biomechanical failure. Vertebral collapse is a consequence of a vascular insult at the anterior segment of vertebral body, which is supplied by the anterior metaphyseal and peripheral arteries. The disruption of the network of feeding arteries, leading to ischemic necrosis that forms vacuum, cleft, and collapse. Osteoporosis is a common disease with a strong genetic component characterized by reduced bone mass and increased risk fragility fractures. The genetic factors contribute to osteoporosis by influencing the bone mineral density. Other phenotypes that are associated with fracture risk, although the heredity of the fracture itself is modest, the causal gene remains to be identified. Many are asymptomatic, usually painless until a fracture occurs. The spine fractures can cause from a minor trauma during daily lives or may remain unknown. It causes pain, deformity, progressive loss of height. It says post-menopausal women with a height loss greater than 6 centimeters are supposed to have osteoporotic fractures. There's a history of fragility fracture elsewhere in the body, especially hip. There is neurological deficit. This is functional loss in activities of daily living. There is reduced mobility and independence. There is psychological distress in more than 40% cases. There is increased mortality, 15% increase in compared to the general population. The X-ray is the first and the most informative investigation. It shows the location of the fracture. It commonly involves the thoracolumbar junction and mid-thoracic region. Remain the best method of assessing the presence of the fracture, kyphotic angles, height loss, intervertebral clefts, and deformities. And it can be shown better in the dynamic instability. Fracture lines are difficult to recognize owing to the severe osteoporosis changes in radiograph. CT scans can show these findings better. The MRI is the technique of choice because of the characteristic morphological features, enhancement patterns, and signal intensities. Nowadays, there are chemical safe, dynamic contrast enhanced imaging, and diffuse weighted MR imaging. They are more important to rule out other pathologies or differential diagnosis. PET and SPECT can be done again to rule out malignancy and other differential diagnosis. The bone mineral density measures how much of calcium and other types of minerals are in an area of bone. It is measured using dual energy X-ray objectometry scan called DEXA scan and is measured as a T-score. This compares the bone density with a healthy young adult of similar gender. Nor the osteoporosis is defined when it is less than minus 2.5. It is a useful diagnosis as well as prognosticate and as well in follow-up and monitoring of the efficacy of treatment on improvement of osteoporosis. It assesses also the adherence and response to therapy. Whenever possible, the patient's initial and follow-up scan should be done in the same instrument using the same procedure. This is just a tabulation of what I've said. Tumor turnover markers, these are the enzymes and proteins released during bone formation or degradation, allows specific and sensitive assessment of the rate of bone formation and bone resorption. These are complementary to BMD measurement. Increase in bone resorption markers are associated with increased vertebral and non-vertebral fractures independent of BMD. There are markers for resorption, there are markers for formation, and the use is to monitor again treatment and adherence to the treatment and modalities. Okay, sorry. Back question answer. Okay. There are some differential diagnoses which should always be considered. All degenerative changes, traumatic fractures, usually they go side by side. Oncological deformities like metastasis, multiple myeloma, and nowadays even infections. Usually those infection under treatment, they can present with osteoporosis, fractures. This classification is basically a X-ray classification of different types: swollen, bow-shaped, projecting type, concave type, and dentate type. Basically, these 5 types show you which one will progress, which will not. So the swollen front, bow-shaped, and the projecting types have got a poor prognosis, which are prone to collapse. Whereas concave and dentate, they do not collapse much. Depending on the time duration, it can be divided into acute, subacute, and chronic types. When one BCF is there, there is 2 to 3 times increased risk of experiencing another osteoporotic fracture elsewhere in the body. 20% of villages with a VCF, that is the compression fracture, experience a second compression fracture in the next 12 months. The mortality is significantly higher, 15% more than observed in the general population. And these are the complications that are independently associated with osteoporotic fractures. The goal of the treatment is primarily to control pain, because that's the first and the foremost symptom, prevent and reverse neurological deficit. Fracture risk assessment and prevention has to be done so that we can prevent it. Prevent fracture at other sites besides vertebral fractures, prevent and correct deformities, prevent complications, improve quality life, and finally prevent mortality. The treatment can be broadly divided into supportive care, conservative management. Surgical management could be minimal invasive procedures like vertebral augmentation or surgical decompression, fixation, and fusion. Conservative treatment is the primary treatment option, which should be tried first. Basically, it is done for the pain relief, and it is can be achieved by short-term bed rest, analgesic, osteopathic drugs, exercise, and braces. Many patients will respond favorably to non-surgical care. The pain management, most of the pain will spontaneously resolve within 8 to 12 weeks. The first line of treatment are analgesic like NSAIDs and opioids. Please mind you that NSAIDs also impair the bone healing, so we should not overuse it. Others are antidepressant, as 40% of these patients are depressed, anti-osteoporotic drugs, hormones, and calcitonin. The braces can be used at an early stage. With early diagnosis immobilization, you can prevent deformity, collapse, and neurological deficit. Can be worn for 3 months, because though there are some advantages to wearing brace, there are disadvantages also. Elderly patient with a deformity, it can develop sores, reduce pulmonary capacity, inadequate mobilization, poor compliance, and weakening of the core muscle. So it should not be used forever. It may not be comfortable for elderly patient. However, there is insufficient information on the type of the braces, indication, and the time to remove it. Exercise and physiotherapy contribute to the increased peak bone mass, with the resistance and impact exercise showing most benefit. Once the acute pain subsides, the core muscle exercise is recommended. Even simple exercise is beneficial and helps in decrease the use of analgesic and the risk of consequent fracture. The bed rest is useful at early stage of the acute pain, but prolonged bed rest is not recommended. It decreases muscle strength, increases pressure source, and all other complications. Pharmacotherapy is one of the main pillar of the conservative management. Calcium and vitamin D is the main treatment modality. There are other anti-resorptive therapy, thyroid and parathyroid hormones, estrogen hormones, selective estrogen, which I'll be talking about in little detail. The calcium and vitamin D is commonly used. The usual dose is calcium is 1000 milligram a day, and vitamin D 400 international unit a day. Anti-resorptive therapy are mainly the biphosphonates. They are naturally occurring analogs of pyrophosphates. They are the main drugs for improving fracture healing of strength, bones, and prevention. These are the examples. Alendronate is the main one, either giving 70 milligram once weekly or 10 milligram per day. They can, in fracture intervention trial, the alendronate is over 3 years, the bone marrow density is increased by 11.4%. However, the combination with alpha calcidol was effective in management. Teriparatide is a recombinant human parathyroid hormone. It is useful as is an anabolic agent, synthetic form of parathyroid hormone, directly stimulate osteoblast activities and markedly increase the bone formation in a greater extent. You have estrogen and estrogen with progesterone hormones. They also prevent fractures. Combination with the calcium, they also improve the BMD loss, decrease the markers of the bone turnover. This most effective therapy for the symptomatic relief and prevention of bone loss and fracture. Calcitonin is a hormone produced from the thyroid gland. It slows the rate of osteoclast and significant relative risk reduction. These are the estrogen receptor modulators. They act like an estrogen but don't have the side effects of the estrogen. There are newer agents like denosumab have come. There are the monoclonal antibodies, and their treatment for osteoporosis again. Now, when to initiate therapy is when the BMT score is between 1 to 2.5, when there is a rise of marker of relative fracture risk, when the presence of there is a fragility fracture is there. Duration of treatment is not known as such. For teriparatide, it is 18 months, and for responsive, it is between from 5 to 10 years. More than 40% fail to achieve significant pain relief with conservative management within 12 months of symptoms. So 15 to 35% are subject to interventional therapy. The indications are neurological deficit, instability, severe collapse, chronic, and 2 minutes, sir? 2 minutes. Okay. The options are minimal invasive, short segment fixation, and a long segment fixation. Vertebroplasty and kyphoplasty we have been hearing since yesterday, so I will not go into very detail on this one. Okay, I'll just go for the position statement of vertebroplasty. A percutaneous uniportal vertebral augmentation procedure using new novel polymer Kiva implants which are suitable for, this is the newer one. And surgery broadly, it is decompression, fixation, fusion, and deformity correction. The pedicle screws and the other fixation alone should be avoided if the BMD is less than 0.3. The fusion and fixation is the surgical method which can be done in many approaches. The challenges are old age, delayed healing, other associated morbidities, and generalized disease and associated other fractures. The bones are soft with a poor grip in the screws, and high failure rates are there. So methods to improve is the longer instrumented constructs, use of concomitant additional anchors or screw modifications. And the screw modifications means larger screws, larger diameter screws, longer screws, and increasing the number of screws, modified screw designs like fenestrated screws, expandable screws, triangular axial plane, triangulation of the axial plane, and engaging the subchondral bone, and a bicortical purchase. The bone screw interface can be improved by using BMA cement or hydroxyapatite cement. The supplementary interbody fusion can be done to increase the stability and the fusion. Other techniques like cross-link bars can be used. The complications are from 18 to 41.2%. And the prevention is nutrition, physical activity, and all this pharmacotherapy I talked about. We're all at risk of osteoporosis.
The future will go to the conclusion, sir.
Yes, sir, I'll do the conclusion. Osteoporotic vertebral spine fracture is a global serious problem and increasing in incidence. The associated high morbidity, mortality, and cost has made it an important and a challenging medical, social, and a financial issue. The high-risk group includes almost everybody after the age of 50 years and is a subject of serious thought for everybody. Public education awareness is thus a critical issue. Treatment plan has to be individualized. Vertebral augmentation has a definite advantage in a carefully selected patient, carefully performed procedures, and regularly followed up patient to detect and treat complication early and timely. Surgical techniques must incorporate methods to increase pull-out strength of pedicle screws, correct sagittal balance, enhance vertebral body strength, and maintain the height. However, further trials involving the rigorous collection of clinical data to assess the outcome, complication, and cost to come to a consensus and make guidelines for management of osteoporosis of spine is necessary. Thank you very much.
Thank you, sir. Very comprehensive presentation. Thank you very much. Only one question I have to you is, when do you order DEXA? If somebody over 50, I'm just over 50, so I am the high risk group based on your presentation. So do you do routine or only when we have symptom?
Sir, I think before DEXA, we have got clinical symptoms like pain, and there must be some, an X-ray will definitely show some signs of osteoporosis. And intervention with BMD is, if you have, let's say, from 1 to 2.5 minus, then that is an indication for treatment indications. But if you have X-ray or a clinical findings, I think it's a high time you should be serious about the therapy, physiotherapy, and other stuff, sir.
Thank you, sir. So in the interest of time, we'd like to invite, thank you, Dr. T. Sharma. Professor Basanta Pant is going to talk on devious stimulation, intramedullary tumor.
Well, thank you, Mohan, for your introduction. Today, actually, I'm going to talk about technique of intermedullary tumor surgery. I will not talk about data, and I will not talk about, other people's data also. I'll just talk about our own experience, what we have been doing in intermedullary tumor. This data is for 10 years. Mainly spinal tumor, we have done in 10 years, 255 cases. Out of that, 46 have been intermedullary tumor. And for all spinal tumors, all spinal tumors, you need to look at these points, like where is the location of the tumor, and in relation to the dura, cord, nerves. What is the vascularity of the tumor, whether it's highly vascular. Hardness is a very, very important factor. And possible histology, a cleavage, whether there's a cleavage or not, presence or absence of serines. These are the factors that we look in. Like in this case, high cervical intermedullary tumor, you can see that, in both ends, superior and inferior ends, there is a big serines. So these are good cases, actually. If you have two serines up and down, then you enter the serines first, and then, dissect out towards the tumor. A vascularity, sometimes the tumor looks very, very small, but it's very, very vascular. So, size alone is not a determining factor, like in this hemangioblastoma. Another case of hemangioblastoma, and most of the time hemangioblastoma are subpile tumors. So I will talk about how to enter into hemangioblastoma. The technique is a little bit different than others. So mostly it's subpile, another hemangioblastoma. So these are small but very vascular, and you have to deal with the vasculature first rather than tackling the tumor. Simple setups is enough. I don't think we are using navigation in spinal tumor, but if you want, you can. You need a very good quality microscope. Sometimes you can use ultrasound and very nice flat dissectors. Monitoring, we use neuromonitoring, but when we didn't have, we have devised, different, like just simple nerve stimulator. You can borrow from the anesthetist and you can use it. You can stimulate the nerve, or you can stimulate the spinal cord itself. And we have also developed Bluetooth technology of facial nerve stimulator by our biomed people. And this we use in cranial surgery. And, to study the anal tone, we just simply put a Foley's catheter, and then that is the pressure transducer is introduced into the regular monitor. And whenever there is a movement of the sphincter, then you can actually see the wave. Very, very simple technique. You can do this. Positioning is very important because if there's a lot of congestion, then the surgery is going to fail. So your abdomen has to be relaxed, your chest has to be relaxed. So upper cervical, we position like this, and lower thoracic and lumbar tumors we position where the abdomen is actually hanging down. So there's a negative pressure in the intra-abdominal vasculature, and the Batson's plexus is collapsed and you don't have any bleeding. In some special cases, like a few cases of tumor with the pregnancy, this lady was pregnant when she had tumor, so we also use sitting position, but in special cases only. Now, tumor dissection. Before tumor dissection, actually we do arachnoid. We tag the arachnoid to the dura. The idea is to lift the arachnoid so that the cord is also lifted up. And then we also suture the pia to the arachnoid. So the whole of the spinal cord is towards you, towards your surface. Where to do the myelotomy? You can actually do the myelotomy most of the time from the midline. But if the tumor is really eccentric, then it is not a good idea to go to the midline. So you may have to go from, like we also do DRES surgery. So, the approach where you do the DRES, it's almost the same like doing a DRES surgery. So paramedian. And on cases like hemangioblastoma, which is, as I have said, which is subpile, then you can actually go directly into the tumor and dissect it out rather than going from the midline. So this is actually meningioma case, but then sometime you have to cut the dentate ligament, even in intramedullary tumor, and then you put some pile stitches so that you can actually rotate the spinal cord. And especially on hemangioblastoma, where the opening of the mouth is anterior, you can rotate the spinal cord if you cut the dentate ligament, and you may have to cut few of the dorsal nerve root. That will not cause a big issue, and don't hesitate to cut dorsal nerve roots. So if it is coming on your way, you can just cut the dorsal nerve roots. And lamina is exposed most of the time. We are doing laminoplasty, a dural incision, chordotomy, tumor excision, hemostasis, very, very important. And then we do a pile stitch and then arachnoid stitch, and then replace the bone. Some of cases like 48 years old female with upper limb pain and weakness, high cervical. So this is how, we are doing a small video. A small nick is given. The blade that I use is a saving blade, which is the sharpest. And then I always tear the dura with 2 forceps rather than cutting it. And then once we dissect out the arachnoid, we push the vascular clip into the arachnoid so that it is open and the spinal cord is toward you. And then do a myelotomy, in this case, midline. Here I am cutting the arachnoid separately. And then, as you can see, we have also stitched the pia to the arachnoid and dura, so that it's like a book. It's open like a book. And then with very gentle, you try to bring out the cleavage, because if you make an error, the error is in millimeter, unlike in brain. Maybe it's more than that, but in spinal cord, it's in millimeter. So you have to be very, very careful. Once you have dissected quite a bit of tumor, then you can start doing a debulking. We have CUSA, but I don't use CUSA because the tactile sensation of CUSA is not good at all. So I never use it. And the most important part of the removal of the tumor is the end, where there is anterior spinal artery, and you have to be very, very careful not to coagulate that part. Otherwise, you will have profound weakness. This is, sometimes the tumor is so large and has extend into the medulla oblongata. This is a Chinese gentleman who came to us for surgery. not from China. He's living in Nepal. And another video, short video. This we have fast forward. You do a large chordotomy. Big chordotomy is better. And how to know where to cut? You look at the vessels that is going into the spinal cord, then you know that this is the midline. Continuously, there's a vessels which is going down like this, and that is the place that you can cut. And that's the end, and that's post-op. A small cyst in medulla oblongata is there, otherwise total of the tumor is removed. And this Chinese gentleman was a very good cook and owns a restaurant, so he invited every one of us for a dinner, 3 weeks after surgery. And here he cooked the food for us. The case that I just showed you, similar approach, total excision. Sometimes the cyst is very, very big, but the tumor is pretty small, And this is very, very easy case. These are easy case. Don't worry about this. You go into the cyst and then take out the tumor. That's post-op. And sometimes you are very confused. Where is the tumor here? You don't know. But if you do an enhance, then the actual tumor is very small. And that's the only part that you need to take out. Very small tumor. But sometimes there is not much of cyst, and then, but then the cleavage is very nice like this. So you can take out whole of the tumor without damaging any of the spinal cord. This is the lady pregnant, another pregnant lady that we operated. She has got the very large serings from medulla oblongata up to the conus, but the tumor is up to here. And it was a hemangioblastoma, and that's post-op. And that's the baby after surgery. She delivered normally. A driver by profession, and most of the tumor was lying anterior, not posterior. So as you can see, and this time we are not doing laminoplasty, so there's some adhesion there. This is not a good thing. So, I think laminoplasty is better, and we are doing more of laminoplasty. Sometimes the tumor is very, very hard. This is a case where we had a big difficulty operating on this tumor. And so hardness is equally important. Here, even with contrast enhancement, we don't see the tumor very clearly, So it's a diffuse type of pathology. But when we went in, there was a distinct tumor which we could remove, and then patient is okay after surgery. This is a 54 years female with numbness in left half of the body, 2 years, and walking difficulty. We don't know what's going on, and we don't see any enhancing part, but there is a sittings, there's no carry, so we don't know what this is. And there is a lot of, abnormal looking spinal cord there, but we don't know what it is. So we actually went in and found that it's all arachnoiditis, very, very severe arachnoiditis. So we just, separated the spinal cord from the dura by sharp dissection. Like this, you can see that the spinal cord is all deranged, and then took a small biopsy just to confirm. And you can see this is the, blade that we use to shape. So we always use that. Topaz, this is the best. So that was arachnoiditis, that's post-op. Sometime, a corneal lesion can actually extend into the spinal cord itself. So these are, maxillopapillary tumor, but you have to be very careful when you are handling the corneal area. And very large tumor, not very difficult, but when you reach the corneal area, that is the part where you have to use all the gadgets of stimulation and whatever monitoring that you have to get the best outcome. And sometime, like in this case, this is also another very hard intermedullary tumor. When we were operating, at the end of the surgery, we could see that we have gone through the tumor into the arachnoid space anteriorly. So don't go beyond that, because there's the anterior spinal artery there, and that artery should not be touched. So that is the arachnoid at the end of. So the spinal cord was actually split into two. Sometime like a case like this, where the cleavage is not very clear, don't do too much. If the cleavage is not clear, don't do too much. Decompress, try to remove as much as possible, and leave something behind. This is a child that we operated, and we are still following. There's not much of recurrence there. So it's best to have an intact patient than to have everything removed at the same time. Intramedullary lipomas is a very, very difficult tumors. And again, these are benigns. They are there since childhood, since birth. So if they become symptomatic, just decompress, don't remove everything. And lipoma have got matured vessels. All the vessels that are feeding are matured vessels. So it's, the less you do is better in spinal lipoma. This also we decompressed only partly. This is a policeman, and he's still following, and he is okay. The only complication that we have in our series is swan neck deformity. In the initial part, we were not doing laminoplasty, long segments. So now we are doing laminoplasty, but still laminoplasty itself is also not enough. With laminoplasty, also you have swan neck deformity. So now we are thinking, if it's a very long segment, maybe we need to put some kind of stabilization technique as well. But then the surgery will become very, very long, which will add more complication. Some strange things has happened, like this case where there's a cystic, tumor-like thing. We went in and took out, and it was neurocystic sarcosis. So you can have neurocystic sarcosis anywhere in the body, including spinal cord. You can have tuberculosis. We have few cases of tuberculosis also. And this girl, actually, the tumor is from conus, almost conus, to the medulla oblongata. We offered her surgery. She's still walking, actually. We offered her surgery, but then we wanted to frighten her out, actually, because the tumor looked very, very big. And after informed consent, she declined surgery, and probably one day she will come, and then we'll operate. So in this case, we have to cut the whole of the spinal cord. So there were no additional permanent deficit in this series, but there was transient weakness, which almost all of them have recovered. When they have pre-op deficit, majority of them get better. But if it was severe, some remain like that. As I have said, now we are doing laminoplasty, especially if the patient is below 40 and the pathology is in cervical spine. And proper monitoring decrease our stress and also increase our stress level, because every time there's some change, the anesthetist say, oh, there's a change. So, I hardly listen. I am doing my work, and the monitoring is going on. So in conclusion, intramedullary tumor surgery have good outcome if we stick to the high degree of surgical skill. For benign lesions, cure can be achieved in almost all cases. These are very, very rewarding tumor surgery. We hardly use radiotherapy. We have never used chemotherapy. Only in few cases where we have deliberately left the tumor, and then it was, grade 3, then we have radiated. But if the accuracy of, radiation therapy get better, then maybe, our thought process will change. Thank you very much.
Thank you. Thank you, Basant. Great presentation, great presentation. And I'd like to say one thing, name of Professor Basanta Panta is synonymous with innovation. He has done so many innovations. My only one query, because Professor Amit has said no time for question and answer.
Mohan, can I
Is opposed to
have a
11
short
size
comment?
blade, what extra advantage you have with that topaz blade? I just want to copy your technique. That's the reason I asked this.
No, it's
Mohan,
sharp,
can I
pretty
have a
very
short
sharp.
comment?
That's the only reason. Yeah.
Okay.
So we have a blade breaker. We break it with the blade
Okay.
breaker, and then one blade will, you can use it many times because you can cut from different places.
Okay, thank you. How many on Zoom call we have? Okay, anybody in the Zoom call? Any question to Professor Pant?
Mohan, I wanted just
Nikolai?
to have a short comment.
Your voice is not audio.
Can you hear me?
Yes, now.
Yeah, okay. It's just, a great presentation. And surely I enjoyed the way how he presented different things. And he's, as you said, he's innovative and he thinks out of the box in order to do the things. So congratulations for that. Just one suggestion. Looks like you have a lot of experience now with these things. And so I do now most of my tumors with a hemilaminectomy. So if you do hemilaminectomy and if you just get a drill and undermine the midline, you have very good access to the midline structures. So you can do your tumors with hemilaminectomy, and then you will not have these problems with swan neck and all that. I think probably you may like if you try that. So it looks like you have enough experience to start doing this.
Yeah, thank you very much. I really appreciate your comment on hemilaminectomy. A few cases we have done where the tumor is actually eccentric on one side. We have done hemilaminectomy, but I do not have experience when it's a midline, But as you have said, maybe it's possible. Then we can do without a laminoplasty, and we can do without, fusion. So that may be a very excellent idea. Thank you very much.
Yeah, I think start with the eccentric ones, then you will get braver with your experience, and then it will be possible to do everything.
Okay.
Yeah.
Thank you very much. With this, we conclude this afternoon consensus session, and we thank you for the opportunity for giving us to do the moderation part. Thank you. Now we go for tea break. Maybe we bring tea.
Thank you so much, sir. I would like to extend my greatest thanks to all the magnificent speakers for successful completion of another session, the consensus meeting. Due to lack of time, we are going to continue with the program. Also, at the same time, the tea is being served outside. You can go and bring it in. Continuing with another session of Symposium with World Spinal Column Society on MIS and spine endoscopy, I would like to invite our moderators for the session. First up, we have with us Dr. Amit Pradhananga, Faculty of Neurosurgery, Tribhuvan University Teaching Hospital. Sir, may I please have the honor of having you on the stage? He will be here with us soon. Our second moderator is invited faculty from India, leading endoscopic spine surgeon from Mumbai, Dr. Malcolm Pestomji. Sir, may I please have the honor of welcoming you on the stage? Thank you, sir. Similarly, as a next moderator, we have with us Dr. Suraj Thulung, Associate Professor of Neurosurgery at Upendra Devkota Memorial National Institute of Neurological and Allied Sciences. Sir, may I please have the honor of inviting you to the stage? Thank you, sir. Now, I would like to hand over the stage to our moderators. Sir, the floor is yours. Thank you.
I think we're going to start with Professor Dr. Nikolai Piv giving his talk today on MIS TLIF. Welcome, Professor. Please start.
Thank you. And again, great pleasure being with you and to have to share my opinion and my experience with different things. In that case, this will be minimally invasive spinal surgery. I would like to have a twist, and I would like to talk to you how we can make it affordable. I mean, minimal invasive is something that it is getting more and more popular, but the common opinion is that it is difficult to start doing it because you need a lot of gadgets, but that's not always the case. You can think minimal invasive, you can introduce the principles of minimal invasive in your practice, and your patients will benefit whatever you do. So coming at the minute, I practice in Belfast. Belfast is part of United Kingdom. This is my hospital. So this is a slide that I wanted to start with. You can see that how the spinal surgery techniques are developing, and we really have the minimal invasive techniques developing after the year of 2000. So nowadays we have minimal invasive options for nearly every surgery that we do. So to one open technique, we have usually a few minimal invasive techniques. As you can see, I have company data from 2019. This is just before COVID, where I was said that about 3% of the surgeries in the world are done minimal invasive. 30% in US, now maybe a little bit more when I talk to the colleagues there, because they realize that with minimal invasive, they keep their patients less in their hospital, and this is good for COVID. So minimal invasive is a philosophy. So if you think about the surgery, what is the surgery as a concept? You have to get in, you have to do the job, you have to reach the target, then do the job, and then go out. But by getting in, you have to go through, quite often you have to go through normal tissue. So you leave your footprints, you leave your fingerprints. So minimal invasive philosophy is to lessen the footprints and the fingerprints you're leaving. So this is a slide that can kind of demonstrate what I mean. So on the left-hand side, start on the left-hand side, start on the right-hand side, and then this is the end goal. So the end goal can be achieved if you do that or if you do that. So it's no-brainer. If I ask all of you, how do you want your end goal achieved? Everybody will say, obviously, minimal invasive, because this is beneficial. So why minimal invasive? Because how you do that? You do that with less collateral tissue damage. You have measurable decrease of the morbidity, and then you have faster functional recovery. And this is a good definition of what is minimal invasive. This was given by McAfee in 2009 in one of his publications. So the minimal invasive principles are muscle splitting technique, avoiding normal tissue injury by muscle splitting, by limited width of the surgical corridor, using known anatomical planes, and don't disrupt the tendons of the muscles. I put this here not without any, not by chance. So probably you all do minimal invasive. This is one of the first minimal invasive surgeries, the anterior cervical surgeries, because at the end of the day, minimal invasive not about how big is your skin cut, but how much muscles you disturb. And anterior cervical surgery is a good example for not disturbing so many muscles. So you all do probably minimal invasive surgery. So muscles are very important. As I said, muscles are extremely important for stability of your spine. So you have to think about the muscles constantly and try to give less impact to them. Why minimal invasive? Why make it complicated? We have now quite a lot of research to suggest that minimal invasive surgeries will reduce infection rate, reduce blood loss, pain. It will reduce the need of instrumentation and fusion.
It will be cost effective, patient will like it and will ask for it. And it will allow you to operate patients that you would not normally operate with the open techniques, like obese patient, morbidity, patients with a lot of morbidity, highly functioning patients. So you will become braver with the minimal invasive techniques, and you will reach further. So of course, minimal invasive technique is something that is not coming on its own. You will have to go through different pitfalls. There is a long learning curve, so you have to put some effort there. You probably, most of you will not do it and may not have a navigation techniques accessible, but you still can do it with radiation with X-ray. So you have to think about the radiation exposure. Equipment could be a problem, but thinking out of the box, you can overcome that issue. And then the last but not the least is technique. So you have to have a good technique. You have to develop a good technique for screw placement, for decompression, for fusion, and like that you will have good results. So let's say a few things about these pitfalls. So steep learning curve. Yeah, it is a steep learning curve because let's say if you do 10, 20 cases, you're still novice. If you manage to get about 50 cases, you reach about 90% of your learning curve, but you're still hobbyist. You know, this is where you're at the learning curve. And then from becoming a hobbyist to become an expert, it takes a lot of cases. So if this is 50 case mark, this here will be at least 200 case mark. So this is why we say that the learning curve is steep, and that's the case, unfortunately. So you have to invest, you have to do cases. Radiation exposure, minimal invasive requires, you don't open everything as with the open surgery. You don't have all the anatomical landmarks. So your eyes will be your X-ray. If you have navigation, it's good, but navigation, unfortunately, is still not widely accessible everywhere. So you have to use your X-ray. If you use your X-ray wisely, if you follow all these principles of safe using the X-ray, then your radiation exposure will not be so big, and you will be safe as well, and you can develop your surgeries. A few things about how to use safe X-ray. You can see that the proper positioning of the tube and the X-ray detector is important. As you can see here, if your tube is on top, then you get a lot of radiation. If your tube is under, then you have less radiation. So be mindful about that. The other thing is that you can see that the distance from your object, from your surgery, is giving you a lot of drop of the radiation. So this is important when you ask somebody to screen for you. Just step one step behind, 30, 60 centimeters from the field will give you significant drop of radiation. Also, the site is very important. You can see that if you stay on the side of the X-ray tube, you get a lot more radiation comparing to if you stay on the contralateral side. This is counterintuitive, but this is the case. So you have to know that, and you have to consider. So usually, if you stay on the side of the X-ray tube, you're getting more radiation. So be mindful about that. This is a very good research that was done by Korean authors, and I used to use lead gloves before, but now after I read this, I stopped using these lead gloves. So if you don't have this situation here when your hand is right under the beam, then you don't need lead gloves. You just need distance. And so what did these authors do? So they put a detector and they wrapped it in a lead glove, and they put it here at point A, and then they X-rayed.
and then they put another, they unwrapped the detector, they removed the lead glove, and then put it 30 centimeters away at point B. So at point A, the detector, which was wrapped with a lead glove, got more radiation comparing to 30 centimeters away detector that has no lead glove. So that distance is very important. So dance back and forth, and that will give you a lot of drop of your personal dose. This is a key message. So special equipment, yes, it is good if you have it, but it's not a disaster if you don't have it. You still can do your minimal invasive. You can apply the principles. You have to think out of the box. So think out of the box, and you will do it. It is good to have Jackson table, Allen table, one of the specialized spinal tables. But if you don't have it, it's not a big disaster. You can apply what you have there. This is how I started my surgeries. This was my setting. I just got a carbon fiber extension. But even if you don't have carbon fiber extension, most of the tables can do AP lateral, so you will be possible to do it. Specialized retractors, yes, if it is okay, it's good if you have it, but if you don't have it, a simple McCulloch retractor, something like that, will give you good exposure. This is exposure. We'll see approach with that McCulloch retractor. The blade is put medially, the spike is laterally, and that works well for me. And I still sometimes use it because it's convenient, and especially if I do multi-level, I will use that. I will not use the tubes. And you can do everything through that. You can see that this is an approach, Wilson approach, using this retractor. I have put the cage here, as you can see. I have decompressed nicely the exiting nerve root. You can see the traversing nerve root, and then you can see the central dura as well. So it is not true that you cannot do good decompression when you use minimal invasive. It's all about techniques. It's all about developing your approach, and it will be possible to do that. So you can see that you can put even big cages through this. So technique is very important. You have to develop a good technique for screw placement, for the adequate decompression, for promoting your fusion rates, and for preserving your nerve roots. These are the 4 things which are most important. I wanted to show you here, I have audited initially when I started without navigation, and I was doing X-ray, and I used these 4 positions of the bevel. I used this bevel tip Jamshidi. And by rotating the Jamshidi in these 4 positions, I can do fine positioning, and then I can have a quite good precision. I've audited my first 800 screws, and you can see that as time goes, the time of putting a screw is getting less and less, and also the screening time, I need less and less radiation to do that. So technique is very important, and with time you will get the technique. You have to persevere. Only if I've revised from this 800, I've revised only 3 screws, and there were no neurological deficit, only pain. So decompression, we mentioned that if you turn your tube, or if you turn your McCulloch retractor, or whatever retractor you have, you're actually in a very favorable position to go across to do central decompression, and even you can reach the contralateral foramen, and you can decompress it. So this is here again anterior cervical approach, and this is a preparation for corpectomy. I did not put that here by chance. This is not a mistake. So I wanted to stress how well we have prepared the end plates. Speaking about the fusion rates, so we are used to prepare this end plate like that. This is the standard what you will have to prepare end plate for ACDF or for corpectomy, for example, for cage. Now, initially I was thinking that I'd really do a good end plate preparation for my minimal invasive TLIFs. And then one day I did a good job. I thought I did a good job, and then I decided, okay, let me put a endoscope inside the disc and see how good of a job I have done after I was scraping the disc for a considerable amount of time. And you can see that it's quite different from the standard that we use for ACDS. Yeah, you can see that there is a lot of work still to be done here. So And that was telling me, okay, this is not right. That the fusion rates of the technique is not good. It's not the technique, it's you. You're not using it properly. I was not using it properly. You can see now my endoscope is going back. I'm going out of the disc, and you see the disc is not nicely clean, so you need to clean it more. This is the exiting nerve root here. This is the traversing nerve root. This is your Camden's triangle. Okay, so cleaning of the disc is very important, and you have to do really good job. And if you do a good job, you will have good fusion rates. Right. And finally, I wanted to tell you a few words about how to preserve your nerve roots. On that side is intraoperative pictures, but it's obviously difficult to find out what's happening here. So I just put side by side a model. To be honest with you, when I'm doing my minimal invasive TILIF, for example, I don't want to see nerves before I put the cage. If I see nerves, I think that they are at risk, and I will injure the nerves. So what I have started, this was initially what I was doing. I was cutting from pedicle to pedicle the facet, but lately what I do is I leave this overhang, and I leave this overhang deliberately. So that overhang is preventing the exiting nerve root when I'm putting my cage, when I'm putting my instrument. So this works well for me, and lately I don't have. Initially I had a few nerve root problems, transient. I had one permanent. But lately I don't have that by using this technique. So this is something very simple that you can use. You can leave a little bit of a bone to protect your nerve root when you're drawing your instruments in, and that will be helpful for you. You may try that. And this is it from me. Less blood loss, less infection, faster recovery, shorter hospital stay. Patients that you were not operating before, you will consider operating. It is cost effective, and you can make it affordable. Thank you.
Professor Peeve, that is a wonderful talk. Your part about the radiology and the effects of radiation to the surgeon was really vital and understanding for all of us. We thank you so much for your talk.
Thank you. Thank you.
Any questions, please? I think we'll move on to the next speaker. Thank you, sir. Thank you so much.
The next speaker is Professor Mehmet Ciceli from Turkey. Over to you, sir.
Hi, everyone. Actually, this is on microendoscopic decompression for lumbar spine stenosis. I will talk about this. Actually, you know that there are different techniques for discectomies. One is the microdiscectomy, then the transforaminal endoscopic discectomy, and interlaminar endoscopic discectomy. Probably the one I will mention you is that microendoscopic discectomy, 3A. This is first introduced by Foley and Smith in 1996. The main issue was muscle splitting instead of cutting the muscles, and by using a tubular retractor and dilating the muscles. The first series by Smith and Foley were about 100 patients and very nice results. Then they called it matrix tube. But after a while, since many surgeons have been more familiar with operating microscope, they then switched to use microscope instead of endoscope. So then they called it inside tube microdiscectomy or microendoscopic discectomy. This is on the left, you can see conventional microdiscectomy. You have to split muscles from the periost. But in this technique, you are just dilating the muscles and then causing less injury to the muscles. So These are the terms. If you use endoscope, MED. If you use microscope, MD. This is the flexible arm of the system connected to a table fixator. And after dilating the muscles, you then place a working channel, and from working channel you can work with an endoscope or microscope. So the instruments are very similar to conventional instruments, only it has to be black or non-glaring instruments because glaring is a problem. This is the dilation tubes, and then working channel, and a flexible arm with table fixator. This is the endoscope with 25-degree angled image. It can provide more image in the back and in the bottom. However, there is a issue problem. If there is bleeding, then you must remove the endoscope and then clean the tip and then place it again. This is the setup for operating room. And this is the setup I used in my hospital. First, you place a guide wire, and then dilators, and then you strip the lamina to clear up the soft tissues, and then you place the endoscope after placing a working channel. These are the stages. And then you can see the inferior part of the lamina and remove a part of the ligament and see the epidural fat, and then see the root and retract it with a retractor, and then see the disc herniation and remove it. Flexible arm may allow you to angulate your tube, and then you can sometimes make two-level decompressions with one incision only. These are the setups I used to do. But then, similar to the US surgeons, I then switched to use microscope and using tube under microscope. This is soft tissues reapproximate after you remove the retractor, and then you make stitches for that. This is one case of L4-5 disc herniation on the left with a free fragment. I will show you the video. This is the phase that I'm removing the ligament. And then similar to microdiscectomy, you can use bipolars, coagulate the epidural veins, and then again similar instruments, and then remove the herniated fragment. In this case, I didn't try to enter the disc space. It is just fragmentectomy. Yes, the bleeding is controlled with bipolar again. And I'm searching for, with a hook, if there is any more fragments. And I'm placing a small sphingostan and then removing the working channel backwards. As you can see, the muscles reapproximate because they are dilated before. Current tubes in the market are Medtronic, Metrix, Stores, Izigo, and the Standu system. And there are many companies who are doing similar tubes in countries like India, Pakistan, Turkey. There are many companies. after a while, if you have started doing that for discectomies, then you can also use it in lumbar spinal stenosis. These are some cases. And you can use unilateral approach and bilateral decompressions. This case, it was from left, and a very nice decompression you can see here. This is a case of more than 70 years old male patient with neurogenic claudication, 4-5 stenosis, and mild degenerative disc stasis. I did not make a fusion surgery, no slippage on flexion films. I did just a decompression surgery. Actually, after stripping the soft tissues, you can start using high-speed drill. In fact, a high-speed drill may obstruct your vision, and then in lumbar spine stenosis cases, I use 18 millimeter diameter tubes. However, in disc herniation cases, if it is discectomy only, I use 14 or 16 millimeter diameter tubes. As you know, there are significant differences with the full endoscopic systems. The so-called full endoscopic system is actually, the main difference is they are with water irrigation. That water irrigation may facilitate your bleeding control because the blood is irrigated easily. After I finish my site, I turn the tube 25 to 30 degrees to the other side, and I also ask the assistant to turn the table a bit, so then it's easier to make the other side by removing underneath of the spinous process and a part of the lamina. Now I'm doing my side. In full endoscopy, actually currently there are also some surgeons who are doing that surgery with full endoscopy system, but it's not easy to make drilling, especially under 7.5 millimeter diameter working channel. Those drills are specially designed, and they are very expensive drills, and you need longer periods of learning time to apply such drillings in full endoscopy systems. However, this system is very easy. You can use conventional instruments and conventional high-speed drills. Only the drill must better be a angulated handpiece. I'm coming to the end. the total bleeding with this patient was 50 milliliters, and total surgical time was 1 hour 20 minutes. Yes, now I see the dura. Actually, I'm removing the other side. This is the contralateral side, and both sides are decompressed, and I'm removing the tube. You can even make 4 levels of surgeries. I have shown these slides, 1, 2, 3, 4, and 5 levels. It is a more than 70 years old male patient. These are the incision lines, and this is the postoperative films of the same patient. Yes, on the left, preoperative, and here is the right, postoperative. If you look at the transforaminal and interlaminar endoscopy, actually indications for transforaminal endoscopy is not very wide. L5-S1 is especially difficult. However, interlaminar endoscopy, it is very, very easy, and indications are quite larger. So there are mainly two techniques. One is the Foley and Smith's technique, and the full endoscopy Rutan's technique with 7.5 millimeter diameter tube. This is some pictures taken from the Rutan's own setup, and you must turn the tip of the working channel to retract the dura and root, and then you can enter the disc space. And drilling is possible with such devices, which like this. But as I said before, those are very expensive drill bits, and the steep learning curve you need. Baseline instruments are expensive, and stenosis drilling is harder. In general saying, the main advantages of microendoscopic discectomy is ambulatory surgery, short hospital stay, less tissue damage, and the smaller incisions. But there are facts that the MIS decompressions are not superior to the open decompression in terms of clinical outcomes in the long term, and hospital stay and return to work are shorter. Infection rate is less. According to some papers, it's 10 times less. And then we then avoid iatrogenic instability with such surgeries. Thank you for listening to me.
Thank you, Professor Mehmet Zilali. Any questions for Professor?
Oh, thank you, Professor Zilali. It was a very nice presentation, sir. One question I would like to ask is, do you redo surgeries using the metric system, and how has your experience been if you are doing redo surgeries for discectomies?
This is a good question. Actually, Foley and Smith in first series have said that redo surgery is not a good option for that. But by the time, if you gain experience, you can do it. I am also doing many redo surgeries because there is scar tissue anyway, even if it is a tube-guided surgery before, although the scar tissue is less, but especially epidural scar tissue may be a problem. But I am already doing also intradural tumor surgery with tube. I can remove some intradural tumors if they are not multi-level, only 1 or 2 levels. With larger tubes, the only problem with tube, if if you injure the dura, if you open the dura, stitching the dura is somewhat more difficult, but you can make it.
Thank you very much, sir. Thank you so much.
I thank you. Thank you a lot.
We will now move to the next speaker. We invite Professor Sandeep Vaishya from India to speak upon MIS in radial tumors. I think we will go to the next speaker because Dr. Sandeep is not available at the moment. Can I request Dr. Ortel from Germany to start his talk on MIS approaches in cervical spine? Dr. Ortel, are you there with us?
For me to be part of this NESON meeting.
Welcome, sir.
Will present MIS in cervical spine surgery. My name is Dr. Jörg Bartel. I have to disclose that I hold patents with Karl Storz Company. I used to act as a consultant to Karl Storz Company until the end of 2020, and I received an honorarium from different other spine companies. This is where I'm from, Europe, Southwest Germany, so the center of Europe. And you see here, this is 1 hour from Frankfurt, 1 hour from Luxembourg, and 1 hour from Strasbourg. This is what the Department of Neurosurgery looks like. We do like 3,500 procedures, 10 consultants, 20 residents, 4 theaters, up to 94 total beds with 20 neurosurgical beds, and we do 300 to 400 endoscopic and 300 to 400 MNS by instrumentation procedures per year. The department is a very traditional department where the first microdiscectomy was described here in Hamburg in 1977 by Kaspar, and the development of the cervical MIS system, the Kaspar system, was done in this department. Well, I will divide my topic in several sections. The first section is what means minimally invasive. What is minimally invasive? Well, any procedure with less tissue damage or less surgical risk, like smaller skin incision, reduced muscular damage, reduced bone removal, smaller laminectomy, less manipulation at the target area, and less exposure of the intact adjacent tissue, can be called minimally invasive. So that means keyhole approach, that means tube-based full endoscopic techniques, that means a detailed surgical planning, that means higher magnification, that means use of angulated optics. So any procedure with less tissue damage, but also clinical benefit for the patient, can be called minimally invasive. So it's percutaneous instrumentation, endoscopy, etc. pp. The term minimally invasive neurosurgery was coined by Bauer and Helwig in 1995 for neuroendoscopy. So what are the peculiarities of the cervical spine? Next stop. Well, the peculiarities of the cervical spine is that we have the option of an anterior and a posterior approach with very, 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 very good results. So when we look at the traditional anterior approach, we have a very high long-term success rate of up to 95% of patients would undertake the procedure again, even after follow-up of almost 30 years. So this is significantly better than in the lumbar spine. And for the posterior, we also have very good traditional results, good to very good clinical results. So 80% of patients are satisfied or very satisfied with the clinical results, and they will are happy to undergo the procedure again. So we have to compare our minimally invasive options to these very high success rate of traditional procedures in the cervical spine. So what are the MIS options in the cervical? And what is the status of evidence? What are the MIS options? Percutaneous instrumentation, endoscopic decompression, or a combination of both? And I will focus today on endoscopic decompression. The endoscopic techniques are particular have particular qualities, so like improved illumination, a better focus on spot, superior circumferential view by angulation of angled optics, less invasive, smaller, less traumatic approaches. And all criteria of MIS, so like keyhole approach, higher magnification, less trauma, angled view, etc., pp, is covered by an endoscopic application. So in contrast to other endoscopic indications, we have no preformed cavity. We have very good results with microsurgery, and we require sufficient decompression. So theoretical advantages mean minimal muscular trauma, decreased scarring at the dura, significant patient demand, superior aesthetic results, less post-op pain, faster recovery, and earlier return to work. The current status of endoscopic cervical spine surgery is: from posterior, there are various techniques well described. They reach from full endoscopic mediolateral discectomy to tube-based endoscopic discectomy, foraminectomy, laminectomy, and there's evidence for superior long-term results lacking. So basically, we only have short-term benefit. For anterior, there are various techniques well described: full endoscopic, partial oncoforaminectomy, partial vertebrectomy, tube-based endoscopic discectomy plus cage placement. No evidence for superior long-term results at all. Just an example what it looks like here from one of the early publications by Rick Fessler and colleagues. You see, this is basically an endoscopic tube-based posterior cervical foraminectomy and discectomy. This is the technique which is frequently used by us as well. You see the patient is put in a prone position, radiological marking of the level, and then a paramedian percutaneous approach with dilators, insertion of the tube. And then this is the intraoperative video. The upper part of the screen is medial. The lower part of the screen is lateral. And you see here the decompression. You see that exposure first of the lateral margin of the spinal canal. And then the dura is still covered by ligament. And then we go lateral, step by step with the Carrison sponge. And you see here how nicely the nerve root is decompressed, far lateral with about resection of the 50% of the facet joint. So far lateral discectomy, decompression and foraminectomy. And here you see the post-operative thin slice CAT scan, which demonstrates the about 50% resection of the facet and the nice decompression of the nerve root. And here you see the example of the various anterior techniques. The various anterior techniques which can be used are discectomy, oncoforaminectomy. You can be a partial vertebrectomy, or you can do a complete vertebrectomy. So this is an example from an Indian group published in World Neurosurgery 2018. And you see that this midline approach from the central disc and the vertebrectomy and the lateral approach, all these are different possibilities for the anterior endoscopic approach. Here you see now the example of an anterior endoscopic approach, the way we do it. You see the upper part of the screen is cranial, the lower part of the screen is caudal. And we look now in this space with a diamond burr. We do the oncoforaminectomy and decompress the nerve root in the neuroforamen with a diamond burr and drilling under endoscopic view. Constant irrigation is applied, which is important to have a control of the heat. And then step by step, the nerve root is decompressed and the oncos is removed. In this case, there was a disc prolapse. It was also actually possible to remove the disc prolapse with the Carrison punch and a hook. You see the disc prolapse that's coming out. This is the post-op. You see the cage insertion. You see the skin incision about 1.8 centimeters and the nice result at the cervical part of the patient. So when I look at our data, so we evaluated 10 years of cervical disc surgery into the endoscope. Only patients with complete data set were included. Only patients we had a follow-up of a minimum 1 year were included. And we only included posterior approaches because we routinely apply these techniques for degenerative cervical spine disease. So there was a total of 95 random foraminotomies. In 76 patients, about 2/3 are male, mean age was 55 years, and 34 had previous cervical surgery, and the mean follow-up was a little bit more than 2 years, almost 2.5 years. There were 62 procedures done at the single level, 13 at double level, 1 and triple level, 4 bilateral foraminotomies, 11 with a 50 millimeter sheet, 65 with a 90 millimeter sheet. There was no emergency stopping and no emergency switch to open surgery. There was 1 DROLT here, 1 postoperative hematoma, and 1 revision surgery because of the hematoma, when the single postoperative hematoma caused a radicular transient weakness. So we did a revision surgery. Surgical time was 77 minutes with 68 minutes per level. And the mean surgical time in hospital was 4 days, which I think is not representative. It's a matter of decision because of the reimbursement system in Germany. So 30 improved, 12 remained unchanged, 2 had a worsening of the sensory results. Motor, 2 had a new onset weakness, 12 had a transient worsening, 22 improved, and 12 were changed. And in the long term, 95% were pain-free. The NDI was 18%. If the patient had previous surgery, the likelihood of a good result was a little bit less. Only 80% were pain-free, and the NDI was 22%. So to conclude, an endoscopic option for a wide range of indications is available in the cervical spine. Tube-based as well as full endoscopic techniques are well established, particularly for the posterior tube-based approach. Very favorable results in degenerative cervical spine are provided. And there's no evidence for superior long-term results. So if you want to look this up, you can have a couple of our papers here. We have done recently in about cervical spine and our results in endoscopic lumbar spine. And I want to thank particularly Dr. Burkhardt for collecting most of the data, Dr. Chan and Dr. Phillips and Dr. Wolko in the beginning of the series, and now Dr. Linzler and Dr. Zenger for their continuous support. And if you're interested, I can promote the 11th Hamburg Neuroendoscopy Week. It will be from September 11 to 17. We will cover 3 different modules, so skull base, interventricular, and spine. And
Sir, thank you for a very wonderful presentation. Your presentation, your talk regarding the approaches of MIS in cervical spine are truly inspiring. I think we will now, anybody having any questions, please? There's one question for you, sir.
Sir, thank you for the excellent presentation. Just wanted to ask one small question. When you did that, oh, he's not there. He's not on.
We'll move on to the next. We're going to start with Dr. Richard Fessler, and we're going to speak about MIS scoliosis correction. Dr. Fessler, are you with us?
Hello, everyone. Today
Welcome,
we
sir.
are going to talk about correction of spinal deformity using minimally invasive techniques. These are my disclosures. This talk is based upon quite a few publications now coming out of the International Spine Study Group, which is a group that specifically studies correction of deformity either through open or through minimally invasive techniques. This is just a brief example of the many publications this very productive group has put out. At this point, we all know the advantages of minimally invasive surgery. There is less blood loss, lower infection rate, less stress response, shorter ICU and hospital stay, less pain medication, faster recovery, and decreased soft tissue destruction. But there are other possible advantages specifically for deformity surgery. For example, can we decrease the number of levels fused and instrumented if we use minimally invasive technique compared to open technique? Will it lower the incidence of proximal junction and distal junction kyphosis? And can we do it through a decreased cost? Beyond that, there are other questions we can answer. Will minimally invasive technique decrease or increase complications in spinal deformity? Can we correct sagittal deformity efficiently using minimally invasive techniques? And can we do complex cases with minimally invasive technique, or are we limited to a relatively small number of simple cases? So for example, here's a patient that comes in with a previous multi-level laminectomy with a 47-degree lumbar curve offset by a 21-degree fractional curve and a 13-degree thoracic curve. And you can see on the right that her lumbar spine bends out fairly well. So this is a fairly mobile spondylolisthesis. Now, if we want to correct this using minimally invasive technique, we have to be able to do all the procedures that we do in open surgery, but through minimally invasive technique. So in other words, to do this, we would start out in either a supine or a lateral position and do A-lifts or A-lifts at L4-5 and L5-S1 and lateral lumbar interbody fusion above that, going up as high as T12-L1. We'll ideally use hyperlordotic cages, and we'll stage our procedures doing the anterior procedures first, and then getting upright scoliosis x-rays to see how much more correction we need to do in stage 2, which is posterior. For the posterior procedure, we make a midline incision only in the skin, and we dissect this down to the fascia, but we do not incise and dissect the fascia or muscles off the bone. We then, by dilating through the muscle, do percutaneous pedicle subtraction osteotomies, Smith-Peterson osteotomies, or facet fusions, followed up with percutaneous pedicle screw placement, and finally, percutaneous subfascial rod placement. If we're starting out in the lateral position, we place the patient in the lateral position with the side up that we want to operate from, and then we tape the patient to the bed. Now, we don't tape towels covering the patient. We actually tape the patient because at some point we're going to have to airplane the table, and we don't want the patient to fall off the table. So the patient is actually taped to the table itself. Her upper arm is supported with a thoracic surgery arm support, and she's positioned over the crack so that we can bend the table and increase the space between the bottom of her ribs and her iliac crest. Then using fluoroscopy, we mark our incisions over the appropriate disc spaces in the dead center of the disc space itself. After making our incision, which is generally 3 to 4 centimeters in length, we bluntly dissect through the 3 layers of the abdominal musculature, the external oblique, the internal oblique, and the transversalis. And we do this dissection bluntly so that we do not sever the iliohypogastric nerve, which will give the patient a flaccid abdomen and possibly burning dysesthesia in the scrotum or vagina. We sweep the peritoneum anteriorly so that we can visually inspect the lateral surface of the iliopsoas muscle. First, to make sure that we're not going to violate any of the nerves running over the muscle. And second, so that we know that we don't have a loop of bowel stuck to the iliopsoas muscle. Particularly in rotary scoliosis, this can be a problem. You have to be sure that you can do the approach safely. So here you can see we've stimulated through, and we're now into the disc space. We then dilate over the disc space and put our retractors in place. This retractor locks into the vertebral body above and below. This is a different type of retractor. And whatever retractor you like to use, as long as you're comfortable with it, it doesn't matter. Some retractors, for example, can push you more ventrally than you want to go. And in this case, you would be risking the inferior vena cava, which is lying right here. So you have to be sure that the middle of your approach is in the middle of the disc space and vertebral body. Here shows a discectomy quite far along with the radicular artery right alongside it. After your exposure is done, you can pack your cage with bone substitute, or whatever biologics you like, and then tap it gently into place. In this case, you can see we've done a 4-level, so 4-5, 3-4, 2-3, and 1-2 interbody fusion with all of our cages in good position. At 4 levels, we often make 2 incisions. 3 levels I can typically do through 1 incision. And you can see that we've gone a long way to correcting her coronal balance already. We then flip to the prone position, make our midline skin incision and dissect it down to the fascia, but then dilate fascia for all the rest of the procedure. In this case, we're doing an L5S1 T-lift. I no longer do T-lifts at the bottom of long constructs. I prefer to do an A-lift. It gives you a much more solid base at the bottom of that long construct. And then using either fluoroscopy or image guidance, you can place your K-wires, advance your K-wires through into the vertebral body, tap over your K-wires, put your screws over the K-wires, and then pass your rod. All of this done percutaneously. So I've showed you this patient a few minutes ago, doing a completely percutaneous procedure. You can see she had excellent coronal correction of her scoliosis and good sagittal balance as a final result. Our early results demonstrated that we could get equally good correction of coronal imbalance, Cobb angle, as we could using either hybrid or open techniques. Early on, however, we were not correcting lordosis as well, and that was demonstrated by our pelvic incidence minus lumbar lordosis measure and by our SVA. We will go into that in more detail later. However, even with the relatively poor correction of sagittal balance, we demonstrated that our clinical results were equal to or better than the hybrid or the open techniques. Now, looking at this more closely, what we found was that for younger patients, it was very critical that we corrected them as well as possible. So here you can see we had corrected them to 28 millimeters. When we did not correct them as well, our clinical results were different, and this group did not do as well. But we also found that in the older population, it didn't matter whatsoever. So we've learned that we don't have to correct an older population of degenerative scoliosis patients to the same degree as we do the younger patients. In fact, our bodies have naturally adjusted to more kyphosis and more sagittal imbalance as we get older than when we are younger. What we did demonstrate was that we had far less blood loss. Our average blood loss today is less than 200 cc's, and that means that we rarely have to transfuse our patients, which is a tremendous advantage. The operative time is about the same as an open procedure. Our hybrid procedures took longer. However, what we did demonstrate was that our minimally invasive groups, we were fusing approximately 5 motion segments, and our open groups, we were fusing 10 motion segments. Nonetheless, our clinical results were exactly the same. So we did in fact demonstrate that using minimally invasive techniques, we can fuse fewer levels. That means doing a smaller operation and get equal clinical results as to our open procedures doing many more levels. However, we also saw that we did not diminish the incidence of proximal junction kyphosis. If we looked at distal junction kyphosis, however, We did not quite reach statistical significance, but it suggested that we can decrease the incidence of distal junction kyphosis by using minimally invasive technique. And in terms of cost, we demonstrated significantly decreased cost using minimally invasive technique. And that was because virtually every parameter we looked at, length of hospital stay, blood transfusions, cardiac ancillary care, intensive care nursing, imaging, etc., every single one was less than doing open procedures, and that totaled to a tremendously significant decrease in cost. So we already knew of these advantages, and what about our other possible? Can we decrease the number of levels fused? Absolutely. Can we lower the incidence of PJK and DJK? Well, I don't think the answer's in there yet. We're still looking at that. And can we decrease cost? Absolutely. What about our questions? If we use minimally invasive technique, does it decrease or increase complications? And can we correct sagittal deformity, which our early results suggested we weren't doing a very good job? In complex cases, can it be done with MIS, or can we only do the simple cases? Well, if we look at complications, we've dropped major complications from 45% to 10%. So we had a tremendous decrease in major and minor complications doing minimally invasive technique compared to open. However, what we did find early on in our results that we definitely had a profile of patients, and they were the patients that had less severe scoliosis, either in sagittal imbalance or in coronal imbalance. And that led us to devise an algorithm for individuals to use to determine whether they were going to use a minimally invasive technique or an open technique. As our experience has evolved, the majority of these cases have even moved over to here, where an experienced minimally invasive scoliosis surgeon can now do most cases through minimally invasive technique. Cases that have had multi-level fusions, however, still remain as open cases. So can we correct sagittal deformity? We pointed out that early on in our experience, we weren't doing a very good job, but several things changed that. One is the development of hyperlordotic cages. So putting 30 or 35 millimeter cages at L5S1 and L4-5, and perhaps 25 millimeter cages at 2-3 and 3-4, we do a tremendous sagittal correction just with that. And then we also developed what we call the push-through technique. The limitation in rod bending with minimally invasive surgery is determined by the amount of open space we have in our towers, and that's relatively limited. So what we did to get around that was, rather than doing a very severe lordotic curve for L5S1, which wouldn't go through all of the towers, we do a gentle curve initially and use a very long rod. We go proximal to distal, and what we then do is push the rod out of the incision and then make our hyperlordotic curve and pull the rod back into the tower. So now we're not passing it through, we're simply pulling it back into it, and then lower all of our set screws to get a hyperlordotic curve at L5S1. And with those two techniques, we've gotten excellent correction. Here, for example, this patient was 14 centimeters positive sagittal balance with even a short construct, hyperlordotic cages, and the push-through technique. We pulled her back into excellent sagittal balance. Well, what about doing complex cases? Can we do a rigid thoracic scoliosis using minimally invasive technique? Here is a man, 32 years old. He is an educator. He teaches people how to drive buses in Chicago. He's got a very rigid, severe curve. And as you can see, he got an excellent correction coronally and sagittally and was able to return to work in approximately 2 months. This is another young man with a very rigid thoracic kyphosis who is an NCAA collegiate basketball player. We were able to correct his curve again with excellent sagittal and coronal balance, and he was able to finish his career as a basketball player in the NCAA. Well, what about double major curves? That's always been assumed that you simply can't do anything like that using minimally invasive technique. But if you look at this patient who's got almost a 60-degree thoracolumbar curve balanced by a 50-degree rigid thoracic curve, and you can see that neither of these curves bend out on flexion extension. Nonetheless, using minimally invasive technique, we got an excellent coronal balance, good correction of her kyphosis, of her scoliosis, and excellent sagittal balance. Well, what about this patient? Again, a very severe double major curve, thoracic and lumbar, excellent coronal balance, excellent sagittal balance, all done through minimally invasive technique. And again, here is a third, with once again showing with hyperlordotic cages and rod bending and the matter that we discussed, excellent coronal and sagittal correction. Well, what about a rigid thoracolumbar kyphosis? This gentleman has a 30-degree thoracolumbar kyphosis, putting him almost 10 centimeters off balance. Once again, excellent coronal, excellent sagittal balance, and excellent correction of his thoracic kyphosis. So, what about our questions? Can we decrease complications using minimally invasive deformity surgery? Yes, we can. Can we correct sagittal deformity now with hyperlordotic cages and the push-through technique? Absolutely. And can we do complex cases? Yes. So in summary, at this time, correction of deformity using minimally invasive technique is a reality for most types of scoliosis, and it depends upon the surgeon's experience. Technology and experience are still early in development. As we get better and better, our techniques and our results will also get better, but already the anticipated benefits are clearly proven. And although the results are still early, they are very encouraging for the future. Thank you.
We thank you for such a wonderful talk, and we'll now move on to our next speaker, Dr. Salman Sharif. As we all know him from Pakistan. Welcome, sir. Please start your talk on endoscopic disc surgery.
I'm sorry, if Dr. Sandeep Vesha, do you want to give your talk first? Do you have to go to your surgery? Sandeep?
I can do that because I have to go back to work. Yeah, I just came from surgery. I just took a break from surgery to give the talk, so I can do. Hello?
Yeah,
Hello?
please go ahead and
can you hear me?
Okay. Yeah, it's fine.
Just one sec. Oh, can you see the screen? Hello?
We can see you, sir. Please go ahead.
Okay. Yeah, sure. So I'll be talking on the minimally invasive surgery for intradural extramedullary tumors. So to begin with, most of the time when people talk about minimally invasive surgery, they talk about trauma, listhesis, instrumentation, but nobody ever talks about the tumors being treated by minimally invasive surgery. Since Victor first removed the tumor since 1888, the techniques have surprisingly remained more or less the same. Most people still do laminectomies and fusion versus non-fusion for minimally for these intradural tumors, and they were sort of favoring fusion, so they were doing multi-level laminectomies and fusing the spine. So traditionally, the technique has been midline exposure and laminectomy. This leads to potential instability of spine, particularly if multi-level laminectomies are performed. So these can be easily done without doing a laminectomy or destabilizing the spine. The minimum dissection leads to less pain, early mobility and back to work, shorter hospitalization, and maintenance of integrity of the posterior tension band. So these are the common tumors that we have done. We have done 160 circles also, and though dural AVF is not part of this series, but I have done 8 dural AVFs also through the tubular retractor. So in last 12 years, we have done 195 intradural tumors. 10% were cervical, 50% were dorsal, 40% were lumbar. I always use 80 millimeter matrix tubes for these tumors, and this is just to show that if this is the location of the tumor as it's seen in the first, then you just simply need to do a hemilaminectomy on that side. While if the tumor is between the two lamina, you may not even do a full laminectomy, just a partial laminectomy of the upper and lower lamina will suffice. This was one of the longest that I did. It's a 4.5 centimeter tumor. And and you can see the post-op MRI, and you can see the trajectory that we had taken. The facet joints are intact, and the interspinous ligament and the spinous process is also intact. I'm just showing a video of this patient. This is neurofibroma at L2, L3 junction. And so we have inserted the tube. And so you can see the exposed lamina. So you basically dog the tube at the spinal laminar junction and then drill out the lamina. As I mentioned before, the drilling of the lamina depends upon the location of the tumor, whether you need to drill it completely or partly. And then you go laterally, and it's just like exposure is just like doing for lumbar canal stenosis when we do a minimally invasive decompression. And now once the dura is exposed, you open the dura, and L2-3 level becomes particularly more difficult because a lot of cauda equina roots are there. Dorsal spine is usually easier to do, and this is a pretty tough tumor. And sometimes the tumor is soft and easily mobilized, so you can just take out the tumor completely in one go. It just comes out in one piece. I just fast forward this video. Sorry. So, actually, the video jumped. So I just fast forward this video. So first you internally decompress to make it easily mobilizable, and then this we are cutting the upper pole of the tumor. It's attached to one root. You cut it, and the tumor is mobilized from there, and then you remove surface. Sometimes in certain meningiomas which are anteriorly located, I put in an endoscope also to just confirm whether the tumor is out completely or not. In most of the neurofibromas, you generally don't need it. And now you can see that the tumor is out. And so now you can see that the tumor is out completely, and a small bit is left, which we'll remove. And then the dura is closed completely with, I use 6-0 nylon to close the dura. It is actually quite tricky to close the dura through a tube, but once you get the neck of it, then you can do it. So now actually I don't even struggle to do that. All my associates can do it. So now once the tumor is out completely, you can see that the nerves are floating around, and so you can close the dura now. So this is another patient with the cervical neurofibroma. You can see that the tumor is in the posterior lateral location. Cervical tumors are more easy to operate than as compared to lumbar ones. So now you can see here the dura is open and this tumor is there. It was quite easily mobilized, and we did a little bit of internal decompression. I use a long narrow CUSA to internally decompress these tumors. Anyway, so the tumor was out, and now you can see the way we close the dura. You have to take it in a bit oblique manner, and sometimes you have to bend the needle also. So I use the smallest possible needle that we have in our OR, and then in some patients, you can, if there is difficulty, you can bend the needle at an acute angle so that you can pass and close the dura. So, a watertight dural closure is performed. It is essential because otherwise there occasionally there can be a CSF leak if you don't close it properly. I normally don't use glue to augment it, only in meningiomas where sometimes the dural closure is not possible completely, then we use glue to supplement the closure. And now this is the post-op MRI. You can see the tumor is out completely. And this is the small incision. And all patients are discharged next day. So this is another patient with a midline tumor. And you can see in the MRI, the tumor is absolutely in midline and there are nerves on both sides. And even in the MRI, you can see it is in midline. I'm just showing this because midline tumors are traditionally supposed to be a contraindication for tubular tumor decompressive surgeries. But we have done quite a few of them. And I have done completely anterior tumors also with the help of a tube. So technique of exposure is practically same in all the patients. In dorsal spine, one has to be careful that you don't cross over to the opposite side because the laminae are quite, the spinous processes are quite flat, and you can actually go to the opposite side without realizing it. So this is the tumor here. It's pretty soft tumor. So, and they were actually two separate tumors, as you could see in the MRI also. So now you see the tumor was out completely and the dura is closed. And this is the patient walking the same day evening in surgery, same day or evening of the surgery. And this patient was actually discharged the same day, and you can see the post-op MRI. This, I'll just skip these. So in none of these patients, a laminectomy was done or interspinous ligament was cut. In one patient in recently, which was not in this presentation, I had to actually convert that into an open procedure because it was a completely calcified anteriorly located meningioma. So it was just not getting mobilized. So I've done quite a few calcified meningiomas with this technique, but that one was completely calcified. And then we had to go more literally and had to remove the facet joint. So we converted that into open procedure. So out of 195 patients, only in one patient, we had to convert that into open procedure. 4 patients developed transient worsening of power, which improved in 3 to 4 days into, and about 4 weeks in another with a conus ependymoma. One patient recently took almost 3 months to get back to preoperative level, and now he's doing quite well. And dural closure has to be done properly, otherwise there may be a risk of CSF leak. In one patient, we had a CSF leak. It was one of the earliest cases, but we just put an extra stitch and that stopped. A few years ago, another patient had a leak. We re-explored and put in more glue, graft, everything, but she continued to leak. And then we had to convert that into a T patient, after which the leak stopped, and then the patient did all right. So to conclude, MIS techniques can be used to operate most of the intradural tumors safely. It doesn't require a long learning curve, particularly if you are used to do decompressions with this technique. And it's a pretty safe technique. Recovery is rapid and the morbidity is minimal, and there is no risk of instability. Thank you.
Any questions from the floor? So, sir, thank you for the excellent presentation and awesome videos. Just wanted to know, what is the size of the intermedullary tumor? What is the limit of the?
No, not intermedullary tumor. I don't do
Sorry. IDEM. Sorry.
So
what is the like you said?
See, the largest I have done is 5 centimeters with the tube.
Sir, does the
somehow I did not need to have a longer than that. No, diameter doesn't matter. I have operated patients who had completely anterior tumor from one end of the canal to the other end, and you can get a corridor to remove that. So diameter doesn't matter. Length sometimes may matter. 5 centimeters I have done, but I think beyond that, if it is there, then I will use different type of retractor, and I'll still do a hemilaminectomy only. I would not do a laminectomy And if there is any doubt about the pathology of the tumor, sometimes in occasional patients, one can get confused between intradural or intramedullary. In that case, if it's a long segment disease, I would do a laminoplasty, but I would still not do a laminectomy.
Thank you. Thank you, sir.
Okay.
Can we invite Dr. Salman Sharif from Pakistan for his talk on endoscopic disc surgery? Dr. Salman Sharif. Is he there with us? Dr. Salman Sharif, are you there with us, sir? Can you please start your presentation?
Okay, and everybody, hello? Can you hear
Welcome,
me?
sir. We're waiting for your talk to start, sir.
Hello, can you hear me at all?
We can hear you, but we'd like you to start your screen sharing. We cannot see your screen yet, sir.
Hello?
Sir.
All right.
We can hear you, sir, but...
Sir, बताइए. हाँ जी, आ रही है. हाँ, पापा ने बताया था ना. मैं अभी ग्वालियर गया भी था.
Okay.
We can hear you, but we can...
Good. Can you see my screen now?
Yes, we can see, sir.
All right. I'm sorry that this. So we are set to go. I again thank my dear friends in Nepal who have given us an opportunity to contribute here. And I was looking at those presentations, an unbelievable, super presentation by my dear colleagues and friends. So from this part is actually with the help of World Spinal Column Society. And I'm grateful for giving us this opportunity. So let's move on. I have no disclosures. Well, gold standard for surgical treatment lumbar disc herniation is open microdiscectomy. We all do that routinely. But recently we've been using dilators and using tubulars and using an endoscope. And it is thought that dilating the muscle rather than stripping the muscle actually reduces the surgical morbidity. So, a few years ago, 7 years ago, actually, we wrote this article and we were thinking, really, is it the gold standard yet? And so we addressed this, that a basic tenet of surgery is to effectively treat pathology with minimal disturbance of normal anatomy, leaving the smallest footprint. MIS advantages, we already know, everybody's talked about it: reduced postoperative pain, tiny scars, shorter recovery, shorter hospital stay. Obviously, endoscope gives improved illumination and you're seeing that the problem real close, a better focus on the spot, superior circumferential view, and it's less invasive. The impact of muscle retraction was looked at in 1998 by Kawaguchi, and what they did was they did 3 comparison groups with the 2-hour continuous retraction, then with 5-minute release after 1 hour and 5-minute release at every 40 minutes. And they looked at CPKMM at 48 hours and also biopsy. And what they showed was that the impact was that CPKMM was much higher. Again, Taylor in 2002 repeated the same thing, especially looking at IMP. And they showed that with those biopsies, that IMP was significantly increased during retraction and reduced function during retraction. So that is the ATP is decreased, and that's why we have this problem. Theoretical advantage, obviously minimal muscle trauma, maybe decreased scarring, minimal opening, and it's patient demand and superior aesthetic results and less postoperative pain. So, you can do various things with it. So you could have a disc prolapse, unilateral stenosis, you can have far lateral disc, and, disc lying completely outside the canal. So all this can be achieved without any problem. In fact, quite easily with endoscopic minimally invasive tubular surgery. So decompression obviously can lead to the stripping of these muscles, cause serious problems because of pain and scarring. And that's what we are educating now. Endoscopic assisted spinal decompression for lumbar stenosis. So this was published way back in 2013, in which they had pretty good results in about 80% of patients and poor in 8%. So they had complications at that time when they were starting out, and you can clearly see, and they at that time said that microendoscopic laminotomy is a safe and effective procedure for degenerative lumbar stenosis, although the complication rate was at that time outcome about 8% was quite poor at that time. Ruitin actually looked at 161 patients with microscope and endoscope and saw that the results were pretty good. In fact, the clinical results of endoscopic interlaminar technique was equal to that of microsurgical technique, because we as neurosurgeons do that all the time. And the advantage was reduced trauma and smaller incision. Again, Sebastian, same person, did a prospective randomized trial looking at 178 patients, and they said that the results were again equal to that of microsurgical technique. I use a EasyGo system, which was done by Gab and Joachim. I have no shares in this or no any kind of investment in this, but I do this quite routinely along with transfemoral surgery. So this particular thing, obviously the important thing is positioning, that you decompress abdomen and thorax just like you do any other surgery. Dilate, interlaminar fenestration, localize the dura, sequestra taken out, root decompression, and evacuation of spinal disc if it's required. The few important tips for young people when you're starting out, that you need to be about 2 centimeters from the midline, paramedian, and risk of skin ischemia increases if your incision is too small. So it needs to be bigger than the size of your tubular retractor. So they come in 16, 18, and 21. The intraoperative fluoroscopic image should be something like that. So you should be docking all the way onto the lamina, and you should be directing towards where your disc is. The incision of the muscle fascia is very important, because if you do not incise the fascia and the line of the skin and the line of where your tubular retractor is going, you can cause serious problems, because you'll be pushing the fascia inside, and then you have to abort the procedure and then reinsert the sheath again, which is causing more harm than benefit. Again, the trajectory is important. For example, smack on the lamina with a disc prolapse coming out on the disc, which we'll see in the center of our alignment. So trajectory is very, very important. Alignment on the perpendicular to the lamina is important. Position, then pitfalls that you could, if you start out, you could perforate the lamina, you can go into the interlaminar window, and dural sac, you can cause problems. This is when you're starting out with this simple needle. Now we don't do that anymore when we use a bigger size tube before we go in. So the advantages we have already talked about, not going to go into that. There are limitations. There's a learning curve to using this system efficiently and safe. Complications like dural tear, initially you will see, and if you are good at your microsurgery, understand your anatomy well, then it becomes easier. The instruments are more delicate. The drill is essential because of you cannot manipulate or move in some of these systems. Decompression can be unilateral or bilateral, and you can come from one side and go across underneath the spinous process to the lamina and freeing the root on the opposite side. So ipsilateral decompression you can also do, and contralateral in the same sitting as well. So let me just show you a brief video. I know you guys are running short of time. So this is a patient who had a disc prolapse, and so we went in. This is our drill. So match head drill, and followed by the diamond drill. You're taking out the ligamentum, and you can see the fat underneath. And then you can see the disc sequestra underneath and a small incision. And you decompress, and the disc fragment come out. So you don't have to do much once you've removed the sequestra. That should be the end of your surgery. Then you just need to put the fat back. The important thing is instruments, the technique, and the diameter of the various sheets. So there is an interlaminar technique. You can just go through the lamina, which is if you're using a size 16 tubular retractor, and you can easily get that for simple sequestra, which is sitting out. HD system is important because you can see things completely different compared to the old system that we used to have. So I'm just going to show you this particular interlaminar technique that we showed there. So you can go through the lamina and take it out. So this is a real minimally invasive spot-on procedure, which hardly takes 45 minutes maximum. So you can have similar outcome with less muscular damage and superior cosmetic results in these interlaminar approach. Endoscopy will play a significant role in the treatment of degenerative spine disease in future. I'd like to invite all of you to World Spine 9, which will be happening in November 3rd to 5th in Athens, and also to Pulse from the OR, which is a World Spinal Column Society's regular feature, which we do for our members, and perks of membership are shown here as well. So I'm grateful, and thank you for giving us this opportunity to contribute.
Thank you, Professor Salman Sharif. Do you have any questions for Professor Salman? If no, then I would like to request Professor Malcolm Mestoji to present on endo-TLIF.
With all due respect, I think the last tubular surgery I did was in 6 years ago. Since then, I've really moved on to the genuine application of endoscopy in spine surgery. Today, my talk is on basic 2 forms of fusion, which I do endoscopically, completely endoscopically, in every sense of the word endoscopically. And that is KLIF, that is transcambien lumbar interbody fusion, and by another technique that is unilateral biportal endoscopy. I do endo-TLIF. Both these surgeries are awake spine surgeries. We have moved to a new paradigm in spine surgery today. Can I get the screen back? No problem, I'm staying here only. Amit, I'm not sending you home until my talk gets over. Okay, so we jump to the next slide. Huh? Hello. Yeah. Now KLIF and UB endo-TLIF. Now, what are the basic differences? Both are endoscopic TLIFs. In both, the scope is inside the disc. But why did I go back there? I want to go back to the first slide. They're jumping my slides. Yeah. Now, KLIF, the advantage is that I preserve both the facets. I'm going transforaminally. I'm landing right under the Camben's triangle. I insert my cage under a local anesthetic. At the second stage, I use epidural anesthesia, that is sensory epidural anesthesia, for percutaneous screws and rods. Patient is doing his or her own neuromodulation. I don't need neuromodulating devices. The absolutely minimum loss of blood. There is a visualized preparation of end plates. There's no blind preparation of end plates. I know exactly where what piece of cartilage is left, discal material is left, and I can peacefully prepare the end plates completely and nicely. There is a zero accidental durotomy in this procedure or a root tear in this procedure. And the basic reason for that is you don't see it. What you don't see, you don't touch. What you don't touch, you don't harm. Ideal for elderly patients with severe comorbidities, poor ejection fractions, diabetes, hypertensives, severe obesities, which involve large scars and wound dehiscence and other problems. All this is absolutely obviated. Disadvantages, obviously, when you're going through the transcameron approach, you cannot resolve central canal stenosis. It cannot be done for old redo surgeries where I feel that there is a severe nerve root entrapment, because I do not want to indirectly stretch out a nerve root. Infrastructure, yes, initially expensive, but later on, as you become good and you keep on using the same infrastructure over 500 and 1,000 cases, obviously the price drops. Need for endoscopic training, yes, I insist upon it. I learned it from somebody, somebody learns it from me, and the chain goes on. So we go to the next slide. And can you play this slide for me? Audio, no. Yeah, play it with audio, please. Never mind. You just play the slide, and even if the audio is not there, I'll speak to my friends here. Basically, we are doing a transcameron fusion over here in a patient with an L4, L5 degenerative lysis listhesis with instability, but the sac posteriorly is capacious. There is a broad-based disc over there, and we will be doing this procedure under local anesthesia. Patient is aware and awake. You can see over here the anterior movement of L5 on S1. Yeah, it's an L5 S1 level. And in extension, it auto-corrects. So it's a mobile instability, decreased disc height, large disc bulge posteriorly, which you can see in the AP. But the sac looks nice and capacious. Sac does not seem to be very badly compressed. So I decided I can get away with a K-lift rather than do a UB endo T-lift. So the choice in this patient was towards transcameron fusion. Now we will be proceeding with that procedure. And can you please go to the next slide, please? Here you see me preparing the end plates. This is fluoroscopically controlled. After I've done my basic entry into the transcameron, put in my tube, put in my scope, seen inside the disc, and then I start with the preparation of the end plates. You will be able to see the preparation of the end plates on the fluoroscopic views. We're just adjusting the fluoroscope. And there, you can see that we are nicely inside the L5S1 disc. You can see that I'm using a rotary punch. I can angle it also. I can rotate it inside the disc space also. I can free up all the necrotic tissues over there. This helps me to prepare the basic end plate. And then comes the step of visualized end plate preparation. Next video, please. Now you can see here how the end plate is being prepared. It's nice, raw, bleeding. Little few discal tags left. The entire discal material has been removed from the roof, which is blue colored over there, painted by indigo carmine. You can see the L5 end plate also. You can see both the end plates. So if anybody tells me that L5S1 can't be done, it's difficult, it's impossible to do, it's not really. You need a little bit of expertise, you need a little bit of patience, you need a little bit of learning and persistence. That's all that takes you through it. Next slide, please. In these patients, I harvest graft from the anterior iliac crest, which I then cut into long slivers, put that in through the scope itself. Can you play the next slide, please? Yeah. Now I'm going to be inserting a 10 millimeter cage through a pre-prepared tube, which I'm now sliding. It's a larger tube with a larger tank to it. And I'm removing the dilator out. And now I'll be introducing a titanium cage completely loaded with bone graft. And you will see the cage as it enters the disc on the IITV. Now I'm going to start hammering it. Now, as I enter the foramen, I stop. And I ask the patient to start moving her limbs. She's awake. She's saying hello to all of y'all. She's moving both her limbs. So I'm sure I don't have a foot drop at the end of the surgery. A little bit of sedation with fentanyl just to keep them comfortable. And now you know that the cage is proper. Now the cage is entering into the disc. I'm placing the cage nicely inside. It's a large disc, a large cage. Now I'll be withdrawing my tube. Slide got over? Then play the next one. No, but I don't think. Okay. Anyway, the cage is in. Now I've gone from the opposite side. I'm decompressing discal material, which is dorsal to the cage. On the opposite side, you can see the cage nicely. The titanium part of the cage over there. The bone graft is all packed anterior to it. Here we are seeing the dorsal roof in the opposite foramen. So I've gone through the opposite foramen. I've done a biportal endoscopy to make sure that I do not leave behind any discal material in the opposite corner. This is one of the major most complications of all TLIF surgeries. Patient waking up crying of root pain in the opposite side. So to make sure that these kind of things don't happen, I do a biportal endoscopy. Can we go to the next slide, please? Yeah. Now my experience, in what all have I done this? So I've done this in degenerative retrolisthesis, lysis listhesis, which I showed you right now, in cases of severe lateral canal stenosis. Please listen to the words lateral canal stenosis, where I can undercut the lateral canal externally with the endoscope and a drill. Next slide, please. Transforaminal fusion is a distinct possibility. It was first decried. People said, no, it can't be done. Now we're showing the world that yes, it can be done. You can see the percutaneous screw scars, and you can see the scar on the patient's back, showing from where I've inserted the cage. Next slide, please. This is the radiological result. The cage is nicely in place. This is another case. This is a case of an L4-5. Next slide, please. This is a case where there is a grade 3 lysis and a spondylolisthesis. You can see how badly the L5 is on the S1. It's really bad slip, absolutely unstable slip. And you can see how we are in the L5-S1 positioning, how the dilator has gone in. Next slide, please. And here, complete reduction, a large cage nicely set in, percutaneous screws put in, and I think this was a very satisfactory result. Done, transcambin. I think the cage is nice and large, no? No comments on the cage, thank you. And on the reduction. Okay, guys, next slide. So now we come to UB endo-TLIF. This is another form of endoscopy, and it's TLIF. Why I love this is because I can visualize the entire cord if I wish to, but I usually don't. I do it extra flavorly. I just visualize a small dural edge and the nerve root in its entirety as it is traversing and then exiting from below, and the exiting root above, both the pedicles and the entire valley in between, showing me the full discal surface. I love it because I can take care of associated central canal stenosis, facetal cysts, and other pathologies. I love it because of redo explorations where I feel there is severe nerve root entrapment, and I need to see that the nerve root has been explored from the dura to the extraforaminal region. I want to see the nerve root in its entirety, from its origin, hugging the pedicle, coming out of the pedicle, maybe even 2 inches out of the pedicle. And I want to make sure there's no fibrosis, nothing touching the nerve root there. So that is that beautiful advantage that UB TLIF gives me. It's literally like an X-LIF. It's not even a TLIF, it's like an X-LIF. It is easier for a traditional spine surgeon to adapt to because you all are all used to this neural anatomy, and a much larger size cage, even 12, 13, 14 millimeter cages can be easily introduced. Autologous bone graft from the spinous process base, lamina base, and facet joint itself is more than enough. I do not need to harvest graft from the anterior iliac crest. Disadvantages, obviously, here I need to be dependent more on the sensory epidural anesthesia. Sometimes general anesthesia if I feel that patient is not cooperative. Possibility of a root or a partial dural tear somewhere, and blood loss is a little more in comparison. Next slide, please. And can you play that slide, please? Now you can see, can you please play that? Yes. You can see the cage is nicely in. It's a peak cage. And you can see the edge of the dura. You can see the traversing root, which is exiting beyond the pedicle over there. And you can see in this corner, the exiting root. Both the roots are completely visualized. You can see the flaval edge. I have just exposed a millimeter of the dural edge. Just a millimeter of the dural edge has been exposed. And the cage has gone in. I have not even done the flavectomy. I have not exposed the dural surface. Obviously, the advantage is I can use a little higher fluid pressures. Now, so what do I achieve? Full decompression, sublaminar decompression on both sides. I can do interlaminar, contralateral foraminotomies. I can excise the ipsilateral SAP, opposite SAP. I can complete the discectomy. Again, there is a visualized preparation of the end plates because the scope is inside the disc. The scope is absolutely inside the disc and you're cleaning the disc from inside. Bone grafting can be also visualized and done properly. And then you can put in an adequate size cage and fusion can be achieved. So can we go to the next, please? Now here you see this patient, a slip at 4-5, reduction, and unilateral fixation. Now this is the big bear. It must be running in all your minds. Why unilateral fixation? Why not twice? I mean, why is he not fixed bilaterally? This is a degenerative listhesis, mild instability. I have not touched the opposite side. I've elevated the height. The opposite facetal joint function is normal. The central column has been restored and my ipsilateral column I have fixed. I have done the largest series in the world of 58 patients with unilateral fixations and 0 failures. It's already gone in print and this is the early part, that is we have put in publishing the 9-month follow-up. We are waiting for the 1.5-year follow-up to show the fusion results. So this is that. Next slide, please. Here you can see a severe degenerated disc, completely collapsed, bilateral foraminal stenosis. Please, next. Can you play this slide? You have seen the reduction and the height achievement. And here you can see how I'm putting in a cage. I'm by the side of the cage. I'm tracking the cage as it goes into the disc. The dura has been retracted away. The exiting nerve root is just by the side. I've already passed it. And here I'm entering into the disc. As I enter the disc, I change my angle a bit and I cross the midline. I think I like the positioning of this cage. Can we go to the next slide, please? This is a case of severe stenosis at L5S1. And you can see how by UB, we've got a beautifully placed cage, almost 8 to 10 millimeters inside the posterior vertebral line, reaching out nicely anteriorly on the way to fusion. Next slide, please. Now, this is a case of multi-level, double level. And here you can see there are only 3 screws percutaneously put. The rod has also been introduced through the same screws. There is no 4th cut on the patient's skin unless you're using a Medtronic sextant system. But here I've been using the Korean system of Technoshine, and I'm quite happy with my positioning and reduction. Next, please. Can you play this slide? Now here you will see that I'm on both sides of the facet. I've cleared the inner and outer surface of the facet. I'm osteotomizing the facet and removing the entire facet. Now this, when I do a redo surgery, I need to approach the facet from outside. I do not approach it from inside. I cut it from outside, thin it out, and finally crack it away so that the dura moves away. So It's an outside in facetal cutting rather than an inside out facetal cutting, which is used in virgin cases. Here you can see how narrow and how small and collapsed the disc space is. Barely a 2 millimeter edge space. The root is completely plastered to it. We are pushing away the root and we are opening up the disc space. From here on, we started expanding the disc space, gaining height, and then finally implanted a cage over there. So this visualization of the exiting nerve root, the bone that is over the exiting nerve root, cracking that bone, freeing the nerve over there. Now all this cannot be achieved if by transcambien approach. This nerve was trapped in bone. If I had not done it this way, in a transcambien expansion, I would have damaged the nerve root permanently. Endoscopic vision takes a little time to get used to because you're very focused, but eventually it all falls in place. Now you see I'm coming laterally, opening the disc space, but where is the nerve? The nerve is trapped in this bone by the back side of my dissector. And I will gradually crack it open and I will show you the freed nerve. Right now I'm just coming laterally and creating space. But the nerve is completely, that pedicle can be seen, but the nerve can't be seen. Why? Because there has been bone growing over the nerve. Now I'm going to crack open that bone. Can you see that bone? Yes, I'm going to crack open that bone from there and I'm going to free that nerve from there. Yes. Now if this case had been done by any other method, without seeing this complete nerve in its extraforaminal path, we would be finished. Can we go to the next slide, please? So for redo spine surgeries, endothelium is my favorite. Next slide, please. Now this is a patient who has undergone 2-level laminectomy. There is no spinous process, no lamina in between. And he comes to me for an endothelium workup. You can see how I have done the fistectomies and I put in the cages comfortably. Next, please. This is the scar on the patient's back. Can you please play that video? This is UV endothelium percutaneous screw fixation. And you'll see the patient wide awake. He was the father of an anesthetist. He had an ejection fraction of barely 23%. Elderly gentleman. And he's awake as an owl, despite all these sedatives. But he was cooperative, so I could do it very nicely. So this just goes to show to you that awake spine surgery is a concept that is there and it will grow. It's just that we need to set up a proper team and manage the logistics in it. Thank you very much. Next slide, please. This is the case of severe stenosis. Next slide, please. And you can see that we have nicely inserted a cage and again fixation. Next slide, please. This is the end result, 4 percutaneous screws. Again, in a case of lysis listhesis, you can see how bad the listhetic segment is over there. And it's horrible. It would give sleepless nights for a surgeon. Next slide, please. And we have reduced the grade completely. Good reduction, good fixation of a high-grade slip. I had a very good purchase. I didn't feel that I needed to extend the fixation anyway. Next, please. So thank you very much. I hope you enjoyed this talk.
Thank you, sir, for your excellent presentation and amazing videos. Do we have any questions from the floor? So would you like any questions? So one question from my side. So I think you have already mentioned, but I want you to re-emphasize how do you select patients for a transcambien versus a UBE?
Transcambien, basically, when I see a capacious sac size posteriorly, no posterior associated pathology like canal stenosis or a facetal cyst or a bad degenerative facet which needs to be removed. So that is where I feel that transcamping is easier, faster, effective, and I preserve both the facets. While in UB, you sacrifice one facet. But then in cases of redo spine surgeries, where you really want to explore the cord, you want to go below it, you want to see both the roots, you want to see the extraforaminal path of the root, and you want to be absolutely sure, okay, yes, I have done a perfect job. So that is the time when I decide to switch over to UB. So then UB becomes a favorite if there are favorite posterior pathologies associated, and if it's a redo surgery.
Thank you so much, sir. With that, I think we come to the end of, oh, sorry, we have, oh yes, we have Dr. Balgopal for his talk on learning curve in endoscopic spine surgery. Dr. Balgopal from Pokhara, please.
Good afternoon. Good afternoon. No slide moving. Okay. Yeah. So the outline of my presentation would be a brief history on endoscopic spine surgery, the different nomenclature for endoscopic spine surgery according to AO spine, a brief introduction about the learning curve, and the learning curve for individual procedures, the endoscopic procedures, and how to overcome learning curve for the beginners like us. The history of endoscopic spine surgery goes back a long way. Like in 1973, the first percutaneous nucleotomy was done. And in 1990, the Cambin's triangle was defined by Mr. Purvis Cambin. So this is called before this time, this is called the golden era, that is the pre-Cambin triangle. Then there is the Renaissance era, after the description of the Cambin's triangle. Then we are in the modern era of endoscopic spine surgery, where there is the flattening of the learning curve. So this is the classification of different types of endoscopic procedures given by the AO system, because the different surgeons use different terms for the explaining or describing the techniques. So I'll be talking only about the transforaminal endoscopic surgery, UBE, and the endothelif that sir had just mentioned. So the endoscopic spine surgery can be fully endoscopic surgery, like transforaminal endoscopic surgery, or it can be endoscope assisted surgery like UBE. Why endoscopic spine surgery? In open surgery, we do the paraspinal muscle stripping, and that causes the post-operative weakness and muscle atrophy. And that is one of the main causes for long recovery time of the patient, and also the increased chances of post-operative infection. And obviously needs the prolonged operative time. And sometimes with this open technique, there can be inadequate decompression, like especially for the patients who have pathology on the hidden zone of McNabb. Why there is rapid development of endoscopic spine surgery, especially in India and South Korea, this technology and technique of endoscopic spine surgery is rapidly taking over. This is because of our better understanding of pathoanatomy and pathophysiology. It's because of better visualization and magnification, and also because of the demand of the patient in the modern time for the minimally invasive techniques. But we have to understand that this is because of the departure from the traditional systems, there can be some problems and the steep learning curve. So in Open surgery, we are working based on the tactile feedback. But in endoscopic surgery, we are basically working on the intraoperative image guidance. And there must be a very good hand-eye coordination in endoscopic spine surgery. And there is also increased work distance, especially in the transperineal surgery, there is increased distance of work. And the surgical view is entirely different in the open and endoscopic surgery. And we are working on the very narrow channel. And we have to learn how to use the modified instruments. For endoscopic spine surgery, we have to recognize the painful spinal anatomy, because this endoscopic spine surgery is very targeted surgery. It's not like exploratory surgery where we can increase the incision size. So we must be very sure of our target. Unless we are sure of target, we cannot do the endoscopic spine surgery. And this needs very good hand-eye coordination, and we must be able to operate looking at the video and fluoroscopic monitors instead of the patient. And we need to effectively direct the instruments at the target area, integrating the visual information with the tactile feedback of our instruments. And these procedural elements that are unique to the endoscopic spine surgery constitute what is known or what is referred as the learning curve in endoscopic spine surgery. Different authors have found out in different numbers of patients that we must operate before we develop from a level of expertise or mastery over these techniques. So mastering this technique, this learning curve, takes anywhere between 15 to 80 cases, depending on the specific procedures. Why this learning curve is there in endoscopic spine surgery? As I already mentioned, the instruments are unique and modified. These are very different from the conventional instruments that we are trained to use. We have to develop or acquire a new sets of skills. And obviously there is a departure from traditional surgery with new operative view. There is new anatomy that we have to learn. And we have to learn the new anatomy of approach and also the new anatomy of the target. And so there obviously will be increased operative time, at least in the initial stages of our learning. And there is significant investment before we can reap the benefit from this type of surgery. Why steep learning curve in endoscopic spine surgery? Because we have to learn how to handle the working channel endoscopes, and we will be working in plane and off plane the axis. Sometimes we'll be looking at the fluoroscopic image, sometimes we'll be looking at the monitor. So there will be constant change of our vision, and then there will be surgical progression from X-ray to endoscopic view. And in endoscope, unlike in microscope that we are usually trained to, there is lack of 3D perception. So it takes a certain time to develop that 3D perception or visualization in the monitor. And in traditional training, we also lack the formal training in endoscopic spine surgery. And we also have very less understanding of endoscopic anatomy and high capital investment as just described. So how is learning curve measured? In different studies, learning curve can be measured or is measured in different ways. Like one of the way is how long does someone take to complete the surgery? How long does he take to prepare the patient for the surgery? So that is the operative time. Then the other way of measuring the learning curve is to what is the surgical outcome that is produced? Like how much reduction is their blood loss? Then what is the hospital, by how many days the hospital stay will be reduced, or for how long the patient takes for return to work. And it can be also measured with the surgical failure or surgical complication rate or recurrence rate and need for any additional rate, procedural rate. And clinical outcome in terms of improvement in visual analog score in pain, or it can be based on the patient satisfaction according to different criteria. For percutaneous endoscopy lumbar discectomy, like the different studies have shown that it can be different, but usually takes around 15 cases for a shortened time that to plateau the operative time. For example, in TLIF, for a traditional surgeon, the endoscopic without experience, the stable operating time comes after operating around 30 to 40 patients of patients. So how can we flatten this learning curve? We can do this by reading the anatomy, because the anatomy of traditional open surgery is entirely different from the endoscopic anatomy. So this book, Atlas of Full Endoscopic Spine Surgery, is a very good reference material for all endoscopic spine surgeons. We can develop our skills in dry lab, in the spine models, or in the wet labs, maybe in the porcine spine models. We can reduce this learning curve by taking part in the caliber workshops like we did yesterday. And we can also do short courses like from 1 week to 3 months, depending on how much time you can spare. And also there are now formal fellowship programs after your residency training. And early resident exposure is important. Initially, there can be some resistance from seniors who are doing the traditional surgery for adopting this procedure, but they must provide the opportunities for mentorship and fellowship through contacts if they want to develop this new technique, if they want to introduce this technique. And at the administrative level, obviously getting the instrument, the initial investment is a little bit high, so they must help in the getting the instruments. And as professional society and chapter, we must conduct the different workshops and courses regularly, so that we regularly have exposure to these new techniques. Thank you.
Dr. Balgopal, that is a fantastic lecture, and it was aimed at the right audience. The learning curve of spine endoscopy and the resistance around it is gradually disappearing like the Himalayan fog. Spine endoscopy is a bright future. The very fact that organizations like EO Spine and others are now including these spine procedures in their nomenclature itself is an acceptance to the world that we are on the world stage. And we are pushing the limits in spine endoscopy. Believe me, 2 years ago, there was nobody doing fusions in spine endoscopy. My first scale fusion I did in 2018, and the world refused to even believe it. These videos had to play in God knows how many organizations, had to play it in Korea itself for them to even accept that scale fusion can be done. But that's how things are. Resistance is always going to be there, but your perseverance, your persistence, your transparency, and your aim to bring education and capabilities to the forefront of the world, that is what takes you ahead. And that is the lesson that Dr. Balgopal has given all of us. So thank you very much, sir. Thank you.
Thank you, sir.
So moving ahead, we have Professor Amit Thapa, and he would be talking on coordinating role of minimally invasive spine surgeries. Nepalese perspective.
Good afternoon, chairpersons and dear friends. Well, as a speaker who is finishing the talk in the whole day, there are definitely benefits and disadvantages. Benefit is that you have learned so much from the other speakers before you. and the disadvantages that there may be some repetition in your talk. But then I would like to cut short my disadvantages to this talk, which is most often philosophical. I was just listening to Dr. Malcolm's speech, and then he just said that for the last 7 years, he has not used a tube. And the same goes with us also. For the last 7 years, I have not used a microscope to operate a pituitary tumor in the brain, because we have already taken up for the endoscope, and that's why the endoscope actually turns the whole game around. So it's a philosophical approach. So when we say minimal invasive surgery, it's all about philosophy. We all understand we have to do a minimum collateral damage to even pluck this particular mango from the beehive. Maximum exposure of the area of interest is always a surgeon concern, and maximum working freedom and allowing for any extension conversion is something which an expert wants. So as a beginner, we're always concerned about the first two, but then as an expert, you start looking for different corridors and approaches as you go ahead, because you're not limited to one. You want to do many things from the single hole. So, and as a person who was trained in microscope, so we all understand that microscope actually opened up the corridor for us. In the last 15 years, I have myself evaluated my journey in spine, and we have seen 4 different transitions, and I will be speaking about through my slides. The first was definitely the use of microscope, and I used to think that microscope can actually done everything. And then we realized that endoscope, when it came into picture in the last 15 years, it actually started looking inside the corridors, inside the ends of where the microscope cannot reach. But the philosophy does not end there. There are a lot of many advantages of endoscope, which we'll discuss. But then there was a lot of publication which start coming up. So there was a peer pressure. The patient would come to you and ask for an endoscopic approaches. So there's always a peer pressure. And then there's always a question which a surgeon needs to ask to himself, does it really necessary for you for the practice? Because now you have done a marvelous job using a microscope. Ask me, I can finish my microscopic discectomy in 30 minutes. But using an endoscope and MES in the beginning used to take 1.5 to 2 hours. So that's why you have to first of all convince yourself whether are you ready to spend so much of time when you are trying to transition from one form to other. But then it's always the patient which comes into picture. When you see that the patient's having good quick recovery, early discharges, cost reduction is there, early return to job, and also additional advantages like low blood transfusions, effectiveness, less pain, motion preservation is all there, which is basically the supplemental advantages of minimal invasive approaches. Then you start thinking that maybe the literature should have some answers, and definitely literatures are full of a lot of advantages to these approaches. The only difference is that the patient reported outcome measures for disease specific concerns have not been shown to be highly advantageous with the minimal invasive approaches. But then all other supplementary advantages are there, and definitely it has a role in near future. So the challenges definitely are there because they are confusing names. Everybody is doing endoscopy, but then what endoscopy they are using, nobody knows. It's only they know when they're using it on the patient. So there's very confusing names, better experiences with the microscope, which almost all neurosurgeons have. And then in initial phases, they're always reversal to open exposures, lack of exposure and training, which Dr. Balgopal has already mentioned, initial cost of equipments, learning curve, fear of complications. These are all challenges, but then they're all mental makeup again. So if in case one wants to change, then this change is possible. Now, this particular paper has made things a little bit more easy. It has not divided endoscopy either into a full endoscopy where all instruments and the tubes actually go through a tube itself, biportal endoscopy where your scope is away and your other instruments are in one side. Now it can be inside a tube or outside the tube, which Dr. Malcolm has already demonstrated in his presentation, and micro endoscopy where you are putting a tube, but then you are still using a microscope to look inside. So these have made life very easy by explaining and then considering your approaches as to what to be done. And similarly, AOSpine has also come up with a lot of classifications in endoscopic spinal surgery, calling it as a full endoscopic decompression at depot level, cervical spine, T-spine or lumbar spine, or endoscopic assisted surgery where you're using it for decompression and fusion. I will not go into details because this is not the intent of my talk. But then the uses are definitely, when you see, the list is actually ongoing. And this is one of the latest review paper, which I have quoted, where the person have actually lot of other pathologies can be addressed using this minimal invasive spinal procedures. But then definitely there are a lot of advantages by the use of these things. But then how to transform? There's $1 million question, because you are now trained in one art. which you have actually learned over these so many years, and then you are asked to jump into endoscopy and minimal invasive by using those tubes, which does not allow you to have a lot of freedom. So definitely, you will definitely have to look inside your own advantage position. You need to have equipments. There's no issue about that. If you do not have a good illumination, retraction, or instrument to go inside the depth, then it doesn't make a sense if somebody is not investing on your things. And definitely concern with safety will die off within the time limit as you start working and then you have an expertise. So what we did in our practice was once we were much more adept in micro discectomy or dural repairs, even using a small hole, we pushed ahead with a hemilaminectomy approach. So hemilaminectomy actually did away the need of instrumentation, and that was the need of the hour basically, because our population could not spend so much money on instrumentation. So hemilaminectomy could actually save the patient from a post-operative kyphosis or loss of lordosis, or for that matter, loss of spinal alignment. And that's why the need of instrumentation was far less. And we have actually showed many results with this technique of MyHem, where we have removed tumors at a lot of levels, more than 3 or 4 levels even, and then operated on syringe. So intramedullary pathology can also be dealt with MyHem approach. And we have also presented this paper in World Spine Symposium on 2016, and it was also awarded as the best paper. But then the story does not end here. Why? Because this video actually speaks some things more. Look at the amount of muscle coming back to its level when you are using a tube or a dilator system to go inside, rather than a subperiosteal dissection. This tells a lot of story. That means you are not doing a lot of muscle damage. By subperiosteal dissection, which we are still doing by using a lot of other tubes, we are actually devascularizing the muscles, and the patient will keep on having post-operative pain. And this has been reported in a lot of literature. So forget about the PORM. Patient is still having a post-op pain at the operative site is because of the devascularization we have done to the patient while we are trying to do a subperiosteal dissection. But then we did not have that thing then, and that's why we actually started with Distando system earlier, because Distando system could actually allow you to look inside the depth. It is a very good system. We used Distando system, and then in the Distando system, we did have a lot of benefits. So this is for the tubular system, which we are using now for the MIS technique. So discectomy process being shown. But then rather than this, I will be talking about the Distando system more, because we are doing a lot of interlaminar Distando system earlier, and we found that Distando system, the best part is that it is mobile. It is not restricted to one end. You can move one level above, one level below, and that's why for the extradural pathologies at different levels, even a single cut can lead to a lot of exposure. So this movement is not possible in the fixed system called MIS. But then there was also a difficulty. You can only remove an extradural pathology, decompress on ipsilateral part. Distando system can also allow you to look up on the opposite side, but then that's it. You cannot put in a cage. You cannot do a TLF procedure through this. And the challenges to work inside a tube is that you actually, at many places, it's a blind spot, because one instrument which is already inside will not be seen by the scope, which is actually staying just 180 degrees behind it. So that's what the problem is. If by any nature you can bring a scope from an angulation, then that particular end is completely visible to you. And that makes the life very easy. And thanks to Dr. Malcolm, we have been introduced this topic. And then we have also seen this particular thing in practice when we are doing an endoscopic surgeries, like in this case of clival chordoma, which we operated. We had a very beautiful exposure, and that's as also a very lot of VP space for work, because my instrument was not going through the scope. My instrument was sitting outside. So the scope was looking from the front, and then all the instruments are working from the down. So you have a lot of space. Similarly, you can do this thing with the UB technique, where you can look from the above and then operate from the below. The benefit apart from the vision is that the water which is flowing inside will carry off your heat. It will actually clear the debris and the bone dust which is coming in the front. And then it makes it makes a space for yourself. So as actually I was looking at you, how you're making a space by asking the students to compress on the packet, so that a lot of pressure can be generated, and it makes the space for itself, unless and until the ligamentum flavum is not intact. So that's a very good concept, where you make a space for yourself inside the spine canal, where the space is very limited. And then of course your technique of putting a fusion cage is always very better. So this is how we can actually approach many things. But then of course we have to accept here also that equipment are necessary.
you need to have at least 2 gadgets in your hand. One is a radio frequency ablation. I have intentionally blurred that margin because we do not want to promote a company in our talk, as well as we need to have a hooded burr so as to preserve the other side of the nerves to get trapped inside the instrument. I think these are the only instrument which is utmost of necessary. Otherwise, a lot of other things which we are using in our surgery from day to day can still be used. And then there's always a question of exposures, radiation exposure, which Dr. Nicolay has also bring up in his talk. A little bit away from what he has presented, we can actually use navigations. Now, navigation is an in thing. In Nepal itself, there are more than 8 installations of navigations in the country. Now, navigation is something which we can always use. Neurosurgeons have been using it nowadays. Now, if we can merge this particular technology with endoscopy, then your life will not only be easy, but also will save for the patient, and the surgery will be much more effective. So here you can actually merge your technology. Like in this case of C1, C2 fixation, we were using this navigation system, and we could only do this procedure with minimal exposure, unlike a C1, C2 fixation, which takes a lot of exposures. However, definitely there are learning curves. So now these learning curves I find is much more with the tubular approaches, because difficulty in exposure, frequent fogging of endoscope, and orientation is in with all the endoscopes. But then once you start using water to flush off your area, then frequent fogging is something which is not there. And also the blood, if in case they're minute bleeding, you can even flush it off. So that's something which can help you a lot. And definitely there's a second phase when you go into an expert level, then manipulation of the nerve root and avoidance of the thecal sac becomes a second type of learning which we need to do for advanced surgery. Now, the question is, are the surgeons ready in Asia? Now, unlike any general perception, which we think that the Americans or the European countries would be far ahead, mind you, dears, this is where the Asia led this particular field. Why? Because the fusion surgery is still in vogue in Americas. It's industry driven. But all this minimal invasive approaches is much more Asian driven, because we don't want to do instrumentation. Instrumentation is costly. So this all MIS and endoscopy thing is basically to avoid fusion. And that's why when we ever talk of putting a cage using an endoscope, there actually lies a conflict of interest, because endoscopic surgeons have already been talking about non-fusion rather than a fusion. But then this literature actually was published in Journal of Spine Surgery, and it actually did a survey of the Americans and the Europeans and the Asian market. And it has been seen that the Asian market is very much fast driven in endoscopy. They're taking up this art as the most important one. And biportal endoscopy was actually driven by the Asian scientists and the surgeons. So to conclude, endoscopic spine surgery is not a specific procedure. It's just a platform that provides optimal visualization and access to the spine while mitigating damage to the surrounding health tissue. Healthcare system globally has continued to move forward towards value-based care programs that financially favor lower cost outpatients neural decompression. So as we heard Dr. Malcolm talking about local procedure, a patient is completely awake. The awake test, which used to be said earlier, was basically the end of GA. The moment a person was supposed to be an awake test, that means you have finished your surgery. Now you cannot operate anything else. But then he is doing it before he puts up a cage. So that is something where the transformation is very visibly seen. And endoscopic spine solutions have direct to consumer appeal. Supported technology like navigations and instrumentation tools do assist surgeons. And MIS and endoscopic spine surgery, when you adopt in your practice, always go in a phase-wise development. Do not jump on the bandwagon because of the peer pressure. Always evaluate your place, your strength and weaknesses, because there lies the challenges. And of course, there's always an opportunity which is hidden behind it. And a continuous phase of learning and problem solving does help. And of course, there's no point discussing about it. It is definitely good for the patient and health system. Thank you for your patience listening.
Excellently summated, sir. Excellently summated. No other words. Thank you.
Thank you.
So today's last lecture is from Professor S.S. Kale, training of a spine fellow. For it, I would like to request Dr. Krishna Sharma to come on the stage, as he has graciously accepted mentoring proposed spine fellowship program in Nepal.
In Nepal, we're trying to start fellowship in spine. So this is very crucial, and I think in this crucial time, we're very fortunate to have Professor Kale with us, who is going to guide us into this particular system so that we make no mistakes and there is no going back after we start it. Sir, please, thank you very much.
Good evening, everybody. I think this is the last or maybe the second last talk. Dr. Neelam got bumped off in the morning, so I think he's going to speak in the end. However, this is an invited talk. I was requested to speak on this, and I hope I am able to live up to the faith you put in me, my friend. Guide the fellowship. Let us see. So I'm going to briefly tell you what went on in our minds when we started the Spine Fellowship in AIIMS. And it has become quite a competitive fellowship. People compete, and not only neurosurgeons but also orthopedic surgeons compete for this. So let us see. Yeah. Okay. So I'm going to answer this same basic, simple questions about who, when, where, what, why, and how, and finally conclude about what we did in AIIMS to get the Spine Fellowship started. Now, who is a fellow? I mean, you can have all kinds of definitions from Lord of the Rings or from the Google Oxford Dictionary, but what we have defined a fellow in AIIMS is that a fellow in spine surgery is defined as a postdoctoral neurosurgeon or an orthopedic surgeon who undertakes appropriate formal training in spine surgery with acquisition of special expertise for diagnosis and management of various diseases of the vertebral column and the spinal cord. Not just the vertebral column, but also the spinal cord. Now, let's see who actually will do this spine surgery fellowship. Now, I'm going to take you to this article or this survey which was done and the results published. Comparison of neurosurgical and orthopedic resident training in adult spine surgery. You know, they actually compared the volume of the operations and hours-based analysis. How much does a neurosurgery resident see spine and how much does an orthopedic? And they saw that graduating neurosurgical residents logged almost 7 times as many spinal cases as their orthopedic colleagues. It's a fact. It's a fact. I mean, it's published literature. So neurosurgery residents, by the nature of their training, see a lot of spine surgery in their old training of MCH in neurosurgery. Neurosurgical residents logged 6 times as many spinal procedure hours as orthopedic surgery residents. 6 times more, and the number of cases was almost 7 times more. Over the 5 years, usually in all over the world, the neurosurgical residency is 5 years. In these 5 years, both fields saw a linear increase in graduating residents, adult spinal case volumes, and procedural hours. So neurosurgery traditionally has had a lead in doing spine surgery vis-a-vis orthopedic residents, because the orthopedicians, they have joints and arthroscopy and this and that. But neurosurgeons basically have the brain or the spine. I mean, there's nothing else, not much more. So naturally, this is the result that neurosurgical residents see more spine, do more spine, and they are more versed with especially the intradural and the intramedullary lesions of the spine. So this is the difference between orthopedic and neurosurgery residents, which already exists. No, but why does anybody want to do spine? Why do orthopedic surgeons want to do spine? Well, this is the answer. The return on, somebody has even analyzed that. The money, the moolah, the greenbacks or the bluebacks or whichever color your currency is. They say in America, within 5 years of doing a spine fellowship, all your loans are gone and you're a rich man after that. And the spine surgery market is the fastest growing market amongst all medical specialties in the US. And that's a huge, huge market, trillions of dollars. And that's why the sudden interest in spine surgery, at least as far as the orthopedic surgeons are concerned. In the beginning, the neurosurgeons felt that we already do so much spine, we don't need to be trained in spine surgery. But unfortunately, in the next few slides, I'll show you why even neurosurgeons need to have a spine fellowship. Why is a spine fellowship needed? Well, they've documented it that if a department has fellows, everything in the department becomes better. The outcomes become better, the research becomes better, the publications increase, everything becomes better if you have a fellowship program in a subspecialty, especially spine surgery. And that's why you need. Now, which place should go in for a spine surgery? I mean, who should be training these spine surgeons? The rule of the thumb is the surgical volume should be at least 250 cases for the year per fellow. So if you plan to have 2 fellows, your center must be doing 500 cases of spine surgery every year. Now 500 cases means average 2 per day, because there'll be holidays, there'll be Sundays, there'll be days when there'll be no surgery. So 2 cases of spine per day at least, and then you can have fellows. If your center does not have this much volume, then the fellow is going to feel frustrated, and the finished product is not going to be as good as you intend it to be. If you have greater numbers, even then you should start with 1 or 2 first, 1 maybe, and then increase it gradually. Even in AIMS, we have the Department of Neurosurgery does about 5,000 operations every year, which includes everything, trauma, tumor, spine, everything. And about 1,500 of them are trauma. And out of the 3,500 non-trauma, about 50% are spine. So there's a whole lot of spine going on, but we still have taken only 2 fellows per year, in spite of the volumes which we generate. And it should have a mix of both adult and pediatric. It should have classical degenerative spine. It should have acute trauma. It should have elective, and it should have the neurosurgical component of spine as well. That means intradural tumors, intramedullary tumors, vascular lesions. Spine doesn't just mean putting bone to bone. That concept of spine surgery should be now given up. When you are a spine surgeon, you should be able to deal with everything related to spine, which includes bone work as well as the intradural part and the vascular part as the need may be. Well, this is basically they've analyzed that the workforce in a department which has fellows in orthopedic surgery as well as the neurosurgical departments which have fellows, they're approximately the same way. Both the departments, whether ortho or neuro, grow in the same way. Training the next generation of spine surgeons, orthopedic and neurosurgical collaboration with historical precedents. Now, this is crucial. This is what we did in AIMS, and we are still following it, that the spine fellow in AIMS rotates in orthopedic department as well as neurosurgery department. It's a 2-year fellowship, 8 months in neurosurgery, 8 months in orthopedics, and 8 months in trauma, because we have a trauma center which is geographically and administratively completely separate. So we have this 8 months, and for 2 years he gets trained only in spine. In orthopedics, he concentrates more on deformity, scoliosis, all the bone work. In neurosurgery, of course, you have a mix of everything. And in trauma, well, it's trauma. So that's what we achieved. And with the cooperation and collaboration with orthopedics, I think this is the best way forward, that you should have a comprehensive training which includes neurosurgery as well as orthopedics. And it cannot be exclusive. You can't say that only neuro, no ortho. And it can't be in orthopedics that it's only ortho, no neuro, because the spine surgeon needs to address all kinds of pathologies. So this ortho versus neuro thing has been, it's always been going on. But if you see that, if you want to make the Ganga, it has to be Alaknanda and Bhagirathi both together. Both have to join to make Ganga, otherwise it will remain Bhagirathi and it will remain Alaknanda. So if you want to make a good spine surgeon, it has to be a mix of both. And most important thing, once you do get a spine fellowship, what is he expected to do? Well, this is the tripod on which the fellowship stands. One leg is teaching, one leg is research, and the third leg is patient care. If any one of the legs is missing, the fellowship is incomplete. It has to include all three. The fellowship has to have mandatory publications for the fellow. It is compulsory in our department for the fellow to have a couple of publications. There's no need for thesis. There is no need for a theory exam. There is no theory exam for our fellows, but they have to mandatorily publish. And it can be a research project which they start from scratch, or it can be a retrospective data analysis, something. And the proof of the pudding is in eating it. If somebody is ready to publish whatever the fellow produces, then it is worth it. It's as simple as that. So that is what these three things. And by teaching, I mean the fellow should be able to take classes for the residents, or if you have an undergraduate department, for the undergraduates. That's how he will hone his own skills in teaching. And so it covers all the three legs of this tripod. And again, this analysis that wherever there is fellowship started, the patient care satisfaction and everything is better. It's associated with a higher ratings in all modalities, whether it is questionnaire-based patient care or outcome-based patient care, everything becomes better, including the publications and research from the department, whichever has a fellowship. Oh, another advantage. What they saw was the people who do fellowship, many times or more often than not, they end up in an academic career. And that's what we want. We also have to look at the next generation. Not only do we have to look at our own generation, but there should be academicians who are ready to teach and impart the knowledge to the next generation. And what they have seen is that the fellows, more often than not, end up in an academic position, which is another good thing, Because the more you propagate this, the more your students become teachers, the more this philosophy will spread. So this is also another advantage which a good academic fellowship will have. Again, the same thing, academic productivity and contributions, fellowships always increase. Another idea is competence-based. I don't know what is happening here, but in India, the NMC, the National Medical Council, has taken over or replaced the MCI. And their curriculum for MBBS now is competency-based. It's not about theory only. It's competency-based. An undergraduate student must be able to take blood pressure. He must be able to know what is this diastolic blood pressure, what is systolic blood pressure. He should be able to take some samples. He should be able to draw blood, etc., etc. So the teaching in medicine is competency-based now, at least in India. And most of the colleges have adopted and are changing their training. Similarly, the fellowship, if you intend to begin, I would suggest that it should be competency-based. That at the end of the training, the fellow should be able to do this operation on his own. If it is competency-based, I think it will make a paradigm shift in the training. And here in India or in the subcontinent, we don't do this. We don't let the residents and fellows do independent surgery. I think there is a need to change that. You have to have competency-based, and then the program director certifies that, okay, under my supervision, this fellow has done 15 lumbar discs or 10 cervical discs or whatever other competencies you want the fellow to definitely have. So it has to be competency-based. If you take care of all these things, I think you will have a fantastic fellowship program, especially in spine surgery. And another suggestion is that if it is not possible for one department to have so many numbers, I would suggest you collaborate. Maybe with an orthopedic department, maybe with other neurosurgical departments, and the fellow can rotate in all three places. If not on a daily basis, then at least 6 months or 4 months in each place. And that would, I think, train him. It will give a well-rounded training to a fellow, who would probably lead to become an academician himself, to become a trainer himself, and then pay back in the form of, pay in front, pay ahead, or pay advance of whatever training he has received during his fellowship. So these were some basic suggestions which I had for your fellowship program, and best of luck for you to start the fellowship. Thank you very much.
Thank you, sir. Listening from the state-of-art institute, from the state-of-art man, has got both ages. It's little disheartening because I think more encouraging. But we are not discouraged. We will start. We will start. Maybe not tomorrow. I'm sure the number may be low, as Professor said, 252 spine surgeries a day. Probably we will not have immediately, probably, but probably once a week we start off with, but we will start off with. Sir, thank you very much for encouraging lecture.
Thank you.
We'll work on it. We'll be behind you, sir, all the time.
Definitely. Whatever, any help you need, I'm there. No
Yes,
problem.
sir. Thank you so much, sir. Thank you so much. Last but not the least, we have a surgeon who have had the best of the experience of the central, as well as the most peripheral places of our country, Kathmandu as well as Jumla and Humla. So I think we have a very unique experience to be shared with us today. I welcome Professor Neelam Khadka with us, please.
Yeah. Dear seniors, professors, and ladies and gentlemen, and the chairpersons. I'm very thankful to Professor S.S. Kali that he mentioned that he was not the last speaker. And I cherish him very much because I had observership under him 2 years ago at AIMS, and he is one of my mentors in spine. Okay. Now I'm talking very different, in very different perspective, and that is, as you have seen, difficulties in providing spinal care in remote areas of Nepal. Yeah, it's, I mean, there may be a long list, but I cherish this one, this trustee. I'm one of the trustees looking after health of Dharmasringa. It's in Budhanilkanta, Nepal Vipassana Center. Now I would like to begin with this quote from Samyukta Nikaya. What it says is, giving food, one gives strength. Giving clothes, one gives beauty. Giving lamps, one gives sight. Giving transport, one gives delight. Giving shelter, one gives all. But one who instructs in Dhamma, that is morality. The excellent teaching of the Buddha, such a person gives ambrosia. Ambrosia in Nepali or Hindi is Amrit. So the Buddha, the Buddha means not only Siddhartha Gautam Buddha. The Buddhas are enlightened person. So we have established one meditation center far in Jumla, and on the backdrop is Kanjiro mountain. And any of you can come there, go there, and there is kitchen, there is bedroom, and you can spend hours or days there and meditate. Now going to the subject matter. Low back pain and neck pain affect 1 billion people worldwide, and spinal pain contributes more to the global burden of disease than all these diseases here mentioned. And again, in 2015, over 500 million people worldwide had low back pain, and more than 1/3 of a billion had neck pain of more than 3 months duration. And myself, I have some back pain and neck pain. I started with neck pain, and I went for physiotherapy. It resolved. And then I had low back pain, and I went to physiotherapy. It didn't resolve. Then I resorted to yoga. Now I do yoga for the last 2 to 3 years. I do yoga regularly, and I'm fit and fine, though sometimes bit back pain, sitting all day long in a chair. So low back pain and neck pain are the leading causes of years lived with disability in most countries and age groups, including Nepal. That was Dr. Bohra, I think, did research on this. And now, going to the Karnali province. This red area is the Karnali province, which is, I suppose, the most difficult and remote part of Nepal, with high hills, mountains, and bordering Tibet, all in the north. The largest province, occupying 20% of Nepal's area, and population is around 2 million. It's a mountainous region with 3 mountains. I mentioned one mountain there. You just saw one mountain, Kanjirava, and Rara Lake, very beautiful lakes. Rara and Sefoksundo are there, and the largest national park of Nepal is Sefoksundo National Park, which is situated there. So this is Karnali province, and in the middle is yellow. This not yellow, little bit pinkish, orange is Jumla, and I am working here at Surkhet at the moment. But I am the only one. I am the single neurosurgeon covering this whole of the Karnali province. So Karnali province, Karnali is divided into 10 districts. There are 25 municipalities and 54 rural municipalities, and 10 districts. Jumla is located in the northwest mountains of Nepal, and Siza Valley, if you have heard of Siza Valley, it is known as the place where Nepali language evolved. So we should visit this place once. This is Jumla, that is Jumla Bazar from Patmara. The Patmara mountain or Patmara hill, the Dafi Lake is at 3,500 meters. And if you go to Rara, you have to cross this Dafi Lake and another lake, another mountain that is around 4,000 meters high and around 11,000 feet high. So this is the landscape of this region. Now, the fact sheet, we have to go to it's very beautiful, but what the fact sheet says about Karnali. Gross domestic product per capita is 1,000, around 1,000 for Nepal, and it is more than 56,000 for USA. And only 22% of the citizens have access to insurance in Nepal. And Karnali province, which is province number 6, GDP per capita is only around 600. And 30% people are below the poverty line. And the SDG goal, Sustainable Development Goals 2030, says that states that the United Nations and Nepal is one of the signatories, that by 2030 the poverty should be ended. But there is no sign all over the world that poverty will end if we continue in our own ways, if the government and all the citizens of the world continue in our own old ways. So last year I worked in Karnali Academy of Health Sciences, which is the University Hospital of Karnali province. And I worked there, we did, I mean, some work there. The spinal cadaver dissection, 2005 spine surgeries, both cervical and thoracolumbar. And one of the case I also is C4C6 spondyloptosis. And we did excellent surgery with 360-degree fixation and stabilization, fusion. But when I came back to Kathmandu, I was wondering what happened to the patient, because there was no skilled manpower to look after the patient. So we did two of this. It is one of the surgeries, but we did similar surgery in 2 patients. So challenges, let's talk about challenges. Then we'll talk about opportunities. Every cloud has a silver lining. So we'll talk about opportunities also. Difficult geographic and transport, as you will see more in pictures. Poor socioeconomic conditions, as we have already said, 30% are below the poverty line almost. Inaccessibility or shortage of trained human resources and equipments, and the list goes on and on. See the difficult terrain and the mount. This is the last village of Jumla, which is called Sotra, and beyond that is Dolpa, and also the mountains there. I think beyond that is Dolpa, another largest district of Nepal, which also lies in Karnali. So it is largest in all all categories, except poverty and poor socioeconomic condition. So the ways of subsistence is meager. So opportunities, let's also talk about opportunities. Otherwise, whole of my presentation will be very dismal. So what National Health Policy 2019 states, the vision is healthy, alert, and conscious citizens oriented to happy life. It orients with the Sustainable Development Goals 2030, I suppose. And the goal is develop a healthy system for all citizens in the federal structure based on social justice. So Karnali health budget is now for 2021-22 is 7.1%, 7%. To talk about health budget of Nepal, till 2018-19, overall Nepal, till 2018-19, it was below 2%. But now there is a hope. Recent spine health camps we conducted, and we saw in 2 half days, in around 12 hours, we saw 15 patients with spine problems. And this is a recent, 1 week, just a week ago, or less than a week ago. And out of 15 patients, only 3 needed referrals, and not urgent referrals. There were no red flag signs. And they all could be managed in secondary health institutions for physiotherapy or some sort of life modification, posture modification. So the health camp, Dr. Andre, Dr. Geoff, all the way from Canada, they participated in the health camp that were examining the patient. So now we are coming up with a community spine care clinic in Karnali. And in liaison with CAS, that is University Hospital of Jumla, Government of Nepal, and Old Spine Care and NESON, where now it's feasible and it can be started in a month if we are really committed. This purpose place is Gutichor Rural Municipality, around 5 kilometers east from Jumla Bazaar. Though we have also selected, seen the building, 2-story building with 10 rooms, including 2 halls with minimal rental cost. And Dr. Andre and Dr. Jeff stayed there for almost a week. And now talking a little about Gutichor village. It is one of the most beautiful place. I consider it as Switzerland. So you may see, I may have the photo. That photo, preceded photo were from Gutichor, these mountains. It was taken recently. It is one of the 20, no, I'm sorry, it is one of the 8 Gaon Palikas of 7 rural Gaon Palikas municipalities of Jumla. It lies towards east of Jumla Bazaar and towards Dolpa, and has very beautiful landscape and scenery with Kanjirova mountain in the backdrop and Sirin Tila Karnali flowing through it. You can see here. This is one of the big tributary of Karnali River. And in the backdrop, you cannot see there. It was in the monsoon, so you cannot see the mountain. Proposed services of the clinic. What will be the clinic will do? What are the services catered by the clinic? Triaging. Number 1 is triaging. It's a traffic. Non-surgical treatment of spine problems, spine health education, and self-care. This sustainable development goal number 3 also says that healthy life and healthy life, and well-being. We have to promote this thing. And spine training of community spine care providers, then primary contacts, and the research. The most significant thing we are hearing all day long, research. Without research, we cannot move ahead. So now 8 questions we have translated in Nepali. That old spine care has 8 questions, and this is for triaging. There are 8 questions, and whether they need referral or not, these 8 questions will determine. And if there is any red flag signs, it will determine. And this we have translated in Nepali. So, and we also tested. We also did testing on that 2-day health camp. And it I think, in my opinion, it works very much. तपाईलाई कहाँ दुख्छ एउटा औँलाले देखाउनुस्. तपाईलाई यो समस्या भएको कति भयो? 3 महिना भन्दा बढी, 3 महिना भन्दा कम. यो समस्याको कारण गत 1 महिनामा गम्भीर दुर्घटना वा कुनै कतैबाट लड्नु वा खस्नु भएको थियो. These are the red flag. These are the red flag signs. I mean, के तपाईलाई हालसालै भन्नाले पिसाब अथवा दिशा भन्नाले bowel bladder involvement. These are the red flag signs here. So we are moving inch by inch ahead. This is the proposed clinic building at Gutichor. And we have also calculated, this how many human resources and their cost. But it's not the final, but we are working on that. I mean, less than $1,500 for 2 doctors in a year. So I think I have to conclude. National Spine Health Program. What I very much appreciate and admire Professor Amit. He is after this. And whole NESON and spine chapter should back him. And myself, I'm also helping him a little, or maybe a little bit more. But if the government, if we can convince the government to introduce a national spine health program in its strategy and incorporate it as its, own it, then the people of Nepal will have a, healthy spine. And curriculum revision in schools, undergraduate, postgraduate. And the Dean of Karnali Academy of Health Sciences, he said that he will revise, incorporate spine. He was convinced that spine health in the undergraduates, at least for the undergraduates. And he asked Dr. Andre and Dr. Jeff to help in devising, preparing, teaching materials. Even he said that. And MC has 3 months posting in periphery. I think this is my suggestion, so that they can see how the people in remote areas live and how we can help them. Our help, how can we can extend our helping hand, and that is important, I think. And research, but the people there are, very generous. They are happy, and if you may be knowing that, with all these miseries, they are still happy. They have smiles, and the recent thing is that Nepal stood the happiest country out of the whole South Asia, and we should congratulate ourselves. So let's be more happy. By doing resource coordination and collaboration, we can really move ahead. Sorry. This is collaboration with these pharmaceutical people here, but not only pharmaceuticals. All diverse and all many and diverse institutions and people. And here, this is the province hospital, Karnali Province Hospital, where I work. And he is MS training, and he is a MS, general surgeon, newly trained general surgeon. They are working under me, and they were helping me a lot in my work. Now, so though the pace is slow, we should move on and on to achieve practical and equitable, evidence-based and sustainable, spine care in Nepal for all citizens, for all ages and all genders. Thank you very much.
Thank you very much, Neelam, for taking us right to Karnali, where we can only, I think, almost all of us can only imagine from here. But what is seen is, I think, beyond we can imagine. And I congratulate him, and I encourage myself as well as many others to help him in his endeavors. And rather, not only Karnali, somebody should take up the far eastern side, maybe western side, and develop together the whole Nepal. Thank you very much. I hand over my mic to the MCs, please. Thank you very much. Thank you, sir.
Thank you, sir. With this, we have come towards the end of INSPINE 2022. Coming up next, we have our valedictory function ahead. As we all know, we had our talking poster presentation outside throughout the day, which was judged and marked by our judges. The result has been tabulated and we already have the names of our winner written up and framed in a certificate that sits right there on the table. As you have all visited and watched our talking posters, I am sure you all are excited as we are to know the name of the winners.
To award our winners, firstly, I would like to invite our dignitaries on the stage, and then we will be giving you away the names of our winners. So first of all, may I please invite the Vice President of NESON and Organizing President of INSPINE 2020, Professor Dr. Amit Thapa, on the stage. Thank you, sir. Likewise, may I please invite the Organizing Secretary of INSPINE 2022, Dr. Samir Acharya, on the stage. Similarly, I would like to invite Chairperson Scientific Committee INSPINE 2022, Dr. Balgopal Karmacharya, on the stage. As you all know, we will be giving out 2 awards today. The first award is for the best research paper in allied specialties, and our next award is for the best neurosurgical research paper in spine. As my co-host already said, we already have the names, and I can already feel the hall getting silent in anticipation of our winners. Before I announce the name of our winners, I would like to thank Dr. Krishna Sharma, who's made a special contribution of rupees 20,000 for the winner of Best Neurosurgical Research Paper in Spine. Let us give a big round of applause for Sir. Similarly, we would also like to thank Dr. Balgopal Karmacharya, who's made a contribution of rupees 10,000 for the best research paper in allied specialties. Thank you, sirs, for making this contribution, which will definitely be an encouragement to the winners. So I think we're all here for the moment of the truth. Maybe I should open the floor to make some guesses on who you think is going to win the best paper award. Any guesses? Can I get any guesses from the audience, please? So firstly, we will be giving our award for the best research paper in allied specialties. So may I please have the guesses for that? Okay, guesses. Since no guesses, okay. So since we did not get any guesses from the audience, I would like to make the announcement. So we are very pleased to announce that the best research paper in allied specialty goes to Amita Mokhtan, Senior ICU in charge nurse at Annapurna Neuro Hospital. May I please invite her on the stage to receive her award. Let us all give a big round of applause for our winner, and we would like to wish her congratulations. Thank you very much. Now it's the time to announce the winner of Best Neurosurgical Research Paper in Spine. Although I'm really scared to ask, do you have any guesses? Okay, so I got some guesses this time. So I'm directly going to announce that the Best Neurosurgical Research Paper in Spine goes to Dr. Mohammad Jedan Adil, who's a neurosurgical resident at Kathmandu Medical College Teaching Hospital. I would like to invite him on the stage.
Well, just a word here. Though only few people are being awarded, all the people who have presented their work and have contested in front of the judges, they are actually the winners. To come in the front and then speak in the crowd, it needs a lot of courage. And then your paperwork, which you have done, is extremely good. So as the organizing committee, we felt that all of you are winners. It's just few names who have been actually got by the judges. And then, of course, the scores was also very tight. So the differences had been not so much. So I should congratulate all the participants for presenting the best work. Congratulations once again.
Thank you, sir. Congratulations to all our winners and all the participants of talking posters. Now, moving on with the program, we have our next event. Our event INSPINE 2022 has been grand and has been able to run smoothly in 2 days, and it wouldn't have been possible without the support of our sponsors. As a token of our appreciations, we'll be handing out certificates to our sponsors. So first up, I would like to invite the representative of INTAS, who is our diamond sponsor, to the stage. Would you please come to the stage? Thank you, sir, and congratulations. Now, I would like to invite our gold sponsor, Medtronics International, to the stage. Could you please come to the stage, representative of Medtronics International? Similarly, I would like to invite our next gold sponsor for our conference, KMC Pharmacy or Bisal Implant, representative from KMC Pharmacy, Bisal Implant. Moving on, I would like to invite our another gold sponsor, OSIS Surgical Private Limited, to the stage. OSIS Surgical Private Limited. Last but not the least, I would like to invite our silver sponsor, Magnus Pharma Private Limited, to the stage. Thank you. Thank you, sir. Now moving on with the program, we also have some more exciting certificate distribution. We will be handing out certificates to our volunteers. I would like to request the volunteers to be on the stage upon calling out the name. So first up, we have Akash Mishra. I would like to request you to come up on the stage, Akash Mishra. Second up, we have Mamata Adhikari. Next, we have Diksha Malmi. Next, we have Abhilasha Singh. Next up is Salika Sakya, Sobha Sapkota, Sridhar Prasad Acharya, Mizas Pokhrel, Samir Sivakoti, Drishti Giri, and Eshna Thapa.
Our sponsor, KMC Pharmacy Vishal Implant, the representative is here. I would like to request you on the stage to receive the certificate. Thank you, sir. Now I would like to request Professor Dr. Amit Thapa to convey a vote of thanks for today's event.
Thank you, ladies. Well, this is the easiest task of all because all the hard work has already been done by the team. And I should be thankful to all of you, particularly our faculties from outside in Nepal, to have come all the way to our place and then taught us a lot of things. I personally have learned a lot from all your deliberations. Despite of being at a hybrid meeting and a lot of other faculties were online, I could feel the vibe, the strength, the dedication they want to continue with the program. So that was really inspiring. And the best part is that all the participants who have been there with us throughout the day, I have been actually interviewing them and their feedback had been excellent. And we could feel the change. The whole workshop or in fact, any conference becomes successful if the audience learns something out of it and tries to put it into practice or either do some research on it. And I can see there are a lot of inquisitiveness to learn more, interest to perform certain researches in their own place. So that is something which we should learn and we accept it. That's particularly the satisfaction we can understand from this meeting. Well, other thing is like all the things which are being recorded here on this conference is supposed to be put on the web. And that's why all our participants can actually access it after they go back and they can go back on through this again. So this will be definitely a very good resource for their learning. So since I'm being called for validatory function, beside my faculties, of course, it's my organizing team. I'm very thankful to it, my volunteers, and then the sponsors who have been here throughout the day. The Kathmandu Medical College for having given us the cadaveric lab, the cadavers without a single charge. Of course, that's a big thing for us. And then the SIAM, which you people were using yesterday, was the newest SIAM in the Kathmandu Medical College, which actually had not been handed over. So I'm thankful for the institute for giving us this space and the things to work with, and Hotel Himalaya for giving us a very good hospitality. The audio video for giving us their continuous presence felt, even though there were certain glitches, but then it's okay. Whenever we have a continuous program running at 3 different fronts, it's very difficult to have a track. But then having said this, after having conducted a lot of hybrid meetings, I think hybrid meetings are always best. You keep a track of time. Physical meeting go 2 or 3 hours late. Hybrid meeting hardly go 15 to 20 minutes late because people cannot wait there online. So that's the best part about it. And thank you all once again and enjoy the dinner with us. Thank you.
Before going for our social dinner, I would like to invite everyone up on the stage for a group photograph. Could you please come to the stage, everyone on the stage, for a group photograph?